Hello, am I audible? Hello.
Yes, sir.
Yes, sir. Aha. So I think we are already late, okay, because cases are plenty and we have short of time. Okay, so the theme of the conference, if required, I will reintroduce in between around 11 a.m. that what is the basic theme of conference, because many delegates are coming around 11 after taking a routine hospital round or something like that. So I am going to just introduce. Uh, I am going to share the screen. So,
Good morning, sir.
morning. My slides are visible.
No, slide share. Okay, now you are visible. Slide are visible.
Okay. So, good morning, everyone. And this is our second advanced endoscopic conference, in which we are going to perform around 20 to 25 surgeries with 4 new technology. Myself, Dr. Saumin Shah, and I'm from Gujarat Gastro and Vascular Hospital. Uh, so, this theme is basically experiment, research, and advance. So, from basic cases to advanced cases, we have tried to include everything in 4 hours. And with the extremely good endoscopist around the India as well as from USA are with us to enlighten us with for the new technology, as well as few tips and tricks of the day, that how you should perform that surgery. So there are two famous quotes. The test is all knowledge is experiment, but experiment is the sole judge of the scientific truth. So we are going to experiment with the new technology. How is it useful, particularly in our clinical scenario, Indian scenario, and as far as concerned, our South Gujarat scenario. So it may we experiment, we fail, or we are not going to adopt that technology, but we always learn something, and we are going to repeat this conference yearly or 2 yearly as per circumstances. So another experiment is all the faculties are coming across the India, but there is no PowerPoint presentation today. Everything is live, and I request all the faculties to demonstrate instrument first. Whatever the new technology, you should focus on the instrument first, and try to explain the principle of the instrument, as well as the clinical indication, particularly the target audience is surgeon and physician. So what is practically or clinically useful, how this equipment is useful, should explain. Okay, and we are dividing our delegates into the 3 area. Agonist means those who are going to perform endoscopy, aggressive endoscopist. Second is the antagonist. Antagonist is surgeons we used to more favoring of the surgery, and there are monks. Monks is they are neutral person, and we have selected Dr. Naresh Gabani, Dr. Vismit Joshipura, Dr. Pankaj Sel. But Pankaj sir is not well. He has some rhinitis and fever. So Dr. Tejas is inside OT. And if you consider myself, then I will help you. But 3 surgeons I have considered as a neutral person, so that we can conclude, rather than competing with each other, we can become complementary to the each other. Particularly, our mindset has been changed. So this is the aim of the conference. We can merge together. So what are the new techniques we are going to introduce today? One is the speedboat. Second is the artificial intelligence. Third is the spiral enteroscopy. Fourth is the revised ESG. And fifth is the magnification endoscopy. So all these are uh, today we are going to demonstrate. And there are 3 OTs and there are 25 cases, and we will try to finish if possible. I will be with you till all 4 to 5 hours. I may not be visible, but I will be audible. So if any question you want to ask, you can ask to the faculties. And if I want to ask anything to delegates or as well as the faculties, I can ask. So let me introduce my team, but I think we are running out of time, so that we can done at the end of the conference. But up to that, we are going to switch towards the OT1. Okay. In OT1, Dr. Sanjay Rajput sir is there, and everybody knows him. He is a very senior and extremely good and innovative endoscopist from the ANS Clinic, Maninagar, Ahmedabad, and you name the equipment and he has. Sir, our focus, Rajput sir, our focus is you demonstrate the equipment first, whether it is a laser and spyglass, and then once you demonstrate the equipment, laser as well as spyglass, after that you explain the procedure. So basic principle of this procedure is you can visualize the CBD with spyglass, and you can take a biopsy, do foreign body removal or a stone bracket. Everything can be done. Okay, so this patient is presented with the jaundice and CBD jaundice and cholangitis, and that suggestive of the large CBD stone. We try to remove that CBD stone, but we are not able to remove. So we put a multiple stent in view of the cholangitis, and today plan is to break the stone with laser. That laser is from the Jena company, and his guy is also will be in the OT. So if you want to ask anything about the laser, if you want to ask anything in the laser, you can also ask. Okay, so I will be there, and we are going to start. Rajput sir, can you hear me?
Yes.
Okay, so it is
Good morning, sir. From auditorium here.
Good
Sir,
morning.
can you hear my voice?
Yes.
Okay, sir. So to begin with, can you just introduce the instrument, the parts, functionality, and
Yeah. This case is I have been told that this case is cholangitis and put multiple stents for cholangitis because the stone was large. The best thing is to put 2 stents rather than putting 1 stent, because 1 stent can be clogged. And it requires laser lithotripsy because of the lower CBD is small and the stone is too big. Today we are going to use this laser from Jena.
Jena laser from
Jena
Germany.
laser. Yeah,
Germany.
Germany. So they are going to explain the instrument because I have also not used this Jena. I am also using this first time. So can you explain this laser?
Good morning, doctors. We are from Jena Laser, Omkara MedTech.
can someone focus camera on him?
And
Can you focus on the laser machine?
Okay.
It looks very compact and very nice instrument.
Jena, this is our 35-watt laser, which is a tabletop model. And the advantage of our tabletop model is it's a compatibility. As you can see, it can be moved from OT to OT, so with ease. So that's the advantage. Apart from that, Jena laser has got a lot of features, which is very good as far as the lasing is considered. As you can see, this Jena lasers not only offers the fragmentation, it also offers the benefit of dusting. So you don't need the over usage of baskets or that way. So straight away to dusting and irrigations, the stones moves out. So that's the advantage. And the reason behind this dusting is basically the principle of long pulse. Jena is the only laser which offers that benefit of long pulse as compared to any conventional laser. The pulse duration, the pulse width that we call is almost around 1900 microsecond. So with every frequency, the pulse width is increased, and because of that increased pulse width, the moment you lace it, the stone gets into dusted rather than getting fragmented, which becomes easier to be removed through irrigation. So that is the principle of our Jena laser with the benefit of longest pulse. And here we have 3 variations. This is the lower end with 35 watt and with a frequency of 30 hertz, energy up to 8 joules, and the pulse varies from 90 microseconds to 1900 microseconds. Now, another features that Jena laser is the only one that is offered is you can modulate with the pulse. Earlier conventional lasers only had the permutations with the frequency and the energy. Either the frequency has to be increased or decreased, or energy has to be increased or decreased. But what Jena has come is they have given one more benefit of pulse modulation, that the pulse can be varied from a longest pulse of 1900 to medium pulse and then shorter pulse. So that is how you can permutations is available with Jena laser.
And another instrument is spyglass, which we are going to use. And as we all know that previously all these large stones were used to go to surgery because of difficult anatomy or because of the size of the stone. We are using Boston Spyglass DS2, which has changed the management of CBD stones as well as the stricture management. Previously, in large stones, we used to do the lithotripsy, mechanical lithotripsy, and as we all know that it is very cumbersome procedure. It requires lot of your effort, lot of time, and then ultimately when it was not getting broken with a mechanical, we have to send the patient for the surgery. Now with the help of this spyglass DS technology, we can use this spyglass technology to look into the CBD and then look into the CBD, break any size of the stone. Now no stone is bigger for spyglass laser lithotripsy. We have
Sir,
recently, yeah.
So please give us a minute. We will call the chairpersons so that we can start discussion along with the procedure.
Okay.
The chairpersons for these sessions are Dr. Yagnesh Waghani, Dr. Anup Patki, Dr. Kiran Patel. Please come forward, sir. And medical. Okay, thank you.
Okay, sir, carry on, sir.
So this spyglass has a chip. The chip is very important in this spyglass because this spyglass normally they recommend only single use, but in this in our setup we cannot do this because it is very costly instrument. So we have to save the spyglass also. We have to save the spyglass. The technique of saving the spyglass, usually they recommend single person using the spyglass, the same endoscope. But we use 2 person. One my assistant Chotu and myself will guide this instrument inside the CBD. So the most important part is the chip in this spy scope. So you should not use your elevator until this part is out. The light blue part is out. So now I will ask him to do it up.
Sir, what is the diameter of scope?
Diameter is 10 French. It is a very delicate instrument, so you have to use it very carefully. Once I go in, there is a channel for flushing, there is a channel for guide wire or laser. So we will go with the laser uploaded on the CBD, uploaded on the scope. Once you are in the CBD, you can change your scope. 1, 2, 2. And now,
for the sake of audience, the view on the left side is intra CBD. It is the scope inside the CBD. While on the right side, we are seeing the dual view from the main scope.
Now we can increase the size of the scope and we can change the view. from endoscopic view to the spyglass view. And can you just repeat the question?
No, I was just introducing which because there are some physicians, surgeons in the audience. So for their sake, I just told this is the endoscopic view and this is the intra-CBD
Yeah,
view.
this is the intra-CBD view, and you can see a large stone which is impacted in the CBD. So carefully you have to just go near and continuously flush. I will ask Chotu to take the laser out, you can see, and now I will ask them to keep the laser ready. Now you can see this green light which is going there. What are the watts? It's 10 watt, 0.8 joule and 12 hertz dusting mode. So now I will go
indications
near
for
to the
using spyglass means in which cases do you prefer them?
which cases I prefer spyglass.
Yes, sir.
Usually it is used in large CBD stone, indeterminate biliary stricture, and taking biopsies from the malignant strictures inside. And now, now we are just near to the stone and I will start firing my laser. I have to go a little bit near and then start firing. And now you can see there is a breaking of the stone. This is the excellent modality for the stone which are got impacted. And one more important thing about this laser lithotripsy is you should not put dye. You should not put contrast before doing this laser if you have an image of MRCP before or an cholangiogram before. Because you don't need to see the cholangiogram again and again, and you have to be very careful while applying this laser. You have to see that you are in the middle of the stone or just by the side of the stone. Before firing, take care that you are not injuring the common bile duct. So now the stone has started.
Sir, in which cases you do cholangiogram because it is almost out of date?
If I am in doubt or somebody has not taken cholangiogram before or MRCP has some doubt of malignancy, then only we will do the cholangiogram. Otherwise, most of them, and keep laser bar.
Yes, such MRCP is sufficient.
Yeah, MRCP is sufficient most of the time. So minimal invasive technique without putting a contrast, because if patient is having cholangitis, you put 2 stents before. We have seen many a time that people are doing even in cholangitis. So it is relative contraindication to do the laser lithotripsy because we are putting lot of fluid inside. So patient may develop cholangitis later.
Sir, what about the stones which are in the common hepatic and extending into right and left hepatic?
We can remove any stone from anywhere if your scope is going up to that place. But if there is a stricture in the common hepatic duct and above that there is a stone, you should subject this patient for surgery. You can remove that stone, but recurrence of stone is very high in those cases where the stricture is there in common hepatic duct or right hepatic duct. The next second modality is put a metal stent into the hepatic duct, and then through the stent we have removed the stones. And then the stricture part is taken care of by the metal stent, fully covered metal stent.
Good morning, sir.
Good morning.
Sir, one doubt may I ask, sir?
Yeah.
Sir, if patient has lower CBD stricture,
Yes.
in that case, how you try to negotiate, because it's a 10 French device. And
We have a tendency to put a metal cover, fully covered metal stent in the lower CBD, and through the stent we do this laser lithotripsy.
okay.
That is a novel technique of removing the stones in a case of lower CBD stricture with large stone above the stricture.
And while, sir, this lithotripsy,
Yeah.
whether it should be from the center of the stone or from the periphery of the
No,
stone,
you have to move your fiber according to the breakage of the stone. So first you have to remove the cell. You can see I am moving my scope from center to periphery.
okay. And by injury of that lens, what precaution we should take care while using it?
See, I am seeing this blue fiber.
Yes.
So you have to see the blue fiber all the time before you start firing the laser. So that is the most important part. And you have to flush the water or saline all throughout this laser lithotripsy.
And how far, sir, we should keep this fiber from the stone or stricture?
1 to 2 millimeter away from the stone.
Sir, by this laser, maybe sometimes some growth or some, if not able to negotiate the wire, maybe use this to do tissue penetration.
Yeah, there are reports of tissue penetration, like they are doing a cutting. Dr. Rahat Shah is doing a stricturoplasty with this laser, and recently we have done one pancreatic stricturoplasty with this and removed the stone after dilating that stricture with the after cutting with the laser.
Thank you, sir.
So this is a novel method where we can use this laser for cutting the stricture inside the CBD as well as pancreatic duct with the help of this laser. And we have recently removed a large stent which was impacted inside the CBD. इसको डस्टिंग मोड से हटा के उस पे करो. Fragment mode.
Yeah.
Sir, when you change this mode, sir, and how you decide now I want to change?
Yeah, because the dusting mode is not giving me good result. It is not, because it is not necessary that you have to dust the whole stone. You can just put barnacle. You have to thoda barnacle. You have to break it into 4 or 6 pieces, and then you can remove it with the help of baskets. So in that way you can save this. Now you can see the stone is getting broken into the.
This is the fragmentation
mode.
Sir, any chance of bleeding? Any time?
See, if you touch the CBD, it bleeds, but it doesnst matter because you are anyway going to put a stent inside.
And it resolves by itself, or it sometimes requires some stenting or that kind of thing, sir?
Center, Baba. So you have to always keep the stone in center. Up. Push.
Sir, about reusability of instrument, how many cases you can do with this fiber and this scope?
Fiber you can use up to whatever amount till the fiber says no. And scope, most of the time we can use 4 or 5 times, but we have used this for last instrument for 15 times. Because our staff is very good in saving these scopes. If you can use it for more than 5 times, that is very cost effective. Because one scope will cost you around 1.25. So each for single procedure it costs you around 25 to 30,000. And the laser is around 10 to 15,000 per procedure. You can reuse these fibers for at least 10 to 15 times.
Sir, after crossing stricture, is there any possibility to get stuck that scope inside the stricture, or difficulty in maneuverability, or it can be handled easily?
You always have to dilate before going in.
So how much, sir, you dilate, sir?
12 millimeter, 10 to 12 millimeter.
Okay. And sir, with balloon or dilator, what
With
you
balloon.
prefer?
With balloon, usually with balloon, because balloons are good to use. There are very less chances of using dilator, because if you use only dilator, the stricture becomes very narrow again immediately. The tensile force of the balloon keeps it dilating more than the routine biliary dilators. Now the stone is getting fragmented.
So what are the possible complications?
Most common complication is cholangitis. Most commonly. So you have to drain the whole duct, and you have to be careful when patient is in cholangitis. Just put the stent, come out, because you always have a second look. You always have a chance to go in again. But if you can increase the cholangitis, patient will go into sepsis and die. So it is always better to do a conservative approach when patient is in cholangitis. Put two or three stents, come out, ask the patient to come after 2 to 3 weeks. Patient will come after 3 weeks very happy, without jaundice, without cholangitis. You are safe, patient is safe. Fine.
Sir, in EHBBO with CBD stone, there is a multiple collateral in around CBD and in the wall of CBD. Then
That is very interesting question, because we have done around 6 to 7 cases of EHPO with CBD stones. In all those cases, only once we had a bleeding. So now we put metal stent beforehand, covered metal stent beforehand to prevent the bleeding while we are removing the stone. Because most of the bleeding stone while you are removing the stone rather than breaking the stone. So when you remove the stone gets stuck to the vessel wall and it injures.
Sir, when
So
will you remove that stent then?
Most of the time immediately post procedure, because keeping a stent inside the EHPO is also very dangerous for long time, or at least 1 week or 2 weeks. You put plastic stents afterhand. If you remove these stones.
Can the removal of stent cause bleed because there will be some local trauma there?
Yeah, local trauma as well as and the stent got stuck, because most of these covered stent don't have the outer sheath covered. They have the inner sheath covered. So outer sheath is still open. So if the stent gets stuck to the vessel wall, while removing also we had a bleeding.
So the sequence of event like to put stent, because the CBD is full of stone, and how you that because entering wire or that also sometimes cause massive bleeding in those cases. So what precaution you took, sir?
Always try to give, reduce the portal hypertension. You can give terlipressin before ERCP to reduce the portal pressure. So if you keep the patient on terlipressin 24 hours before the ERCP, it is also helpful to reduce the portal pressure.
So, hi, Dr. Saumin here, sir.
Yes, sir.
While you are fragmenting a stone, we are switching towards the OT2,
Okay.
where Dr. Kalpit Devani will be there to do a endoscopic sleeve gastroplasty.
Sure. No problem.
Please switch towards the OT2. And this case is 45-year-old male having BMI of around 42, diabetic, hypertension, and doesn't want to take a risk of surgery. And he has been advised bariatric by 2 bariatric surgeons in different center other than Surat. So other center than Surat. So here is Dr. Kalpit Devani. You are live now. You can speak, sir.
Okay.
Vikram bhai.
You guys hear me okay?
So for this session, I think we will first call the chairperson on the front, and chairperson for first session will be there only. They will remain seated at their position, and chairperson for second session will announce the name.
Dr. Vikram
Naresh, can you hear
Notwala.
me there? Dr. Naresh, can you hear me there?
Yes.
Yes, sir, we can hear you.
Okay. So today we're gonna demonstrate endoscopic sleeve
Sir, for a
gastroplasty.
minute, we will call the chairpersons for discussion, and then we will hand over the mic to you.
Okay.
Yeah, chairperson
Just
for
let me
this
know when
session.
I can get started.
Yes, sir. Dr. Ravindra Chabda, Dr. Mukesh Patel, Dr. Jitendra Panchal, and Dr. Piyush Anajwala. Please take the front rows. Thank you, sir. Yes, sir, you can continue.
All right. So we're gonna do the gastroplasty using Apollo device. Can you please focus here? So this is a handle which has a needle over it, which I'm going to use to take a suture.
Sir, can you first please introduce the case? Actually, what is the exactly case so audience can have perspective?
What's that?
About the clinical history of patients.
Yeah, we have already told Naresh bhai. It is a
because there are so many new people has just came, so they can have some perspective.
Old male suffering from the diabetes plus hypertension since last 5 years, and BMI is around 42, and he advised by a bariatric surgeon in 2 different center for the bariatric surgery, but he is not going to take any risk and want to go for sutureless surgery with excellent safety profile. So we switched him to the endoscopic sleeve gastroplasty, and here we are going to demonstrate handle and everything of device first by Dr. Kalpit Devani, and Dr. Rakesh from Hyderabad is there, who is also a master of ESG and going to do the second case of ESG by Dr. Rakesh. But two people is always better during the live procedure. So Dr. Rakesh is there, Dr. Kalpit is there. Okay.
So as you can see, we have set up our handle right over where the suction and biopsy channel is. If you focus on this, can you hold it up? Using this handle, I can take a bite of the tissue and open the bite of the tissue. Now, I'm going to show you how. So using 2.0 proline suture, non-absorbable proline suture, we're going to take stitches once. What's that? No. Okay.
Can you show suture material? If
Yes.
you can see.
So here is the suture material. I'm going to take
focus
this.
camera on that. We can't see it. Yes, now we can see.
So suture material has a needle on the tip, and that is followed by 2.0 proline suture. So this is the catheter which you can use. Okay. And load your needle. And here is your suture material ready so that you can get started.
Actually, this is modification of endo stitch that we sometimes use in surgery, based on same principle. And then thread is attached to the needle in the midway, and needle
Yes.
moves in both direction. So this is a little bit modification of endo stitch that is used for endoscopic purpose.
So now I'm gonna go ahead and load my suture material on the handle. So one important thing which you need to make sure you communicate with your tech is that they're keeping a constant tension on this suture while you're trying to load your needle. Ready? Are you guys able to see?
Yes, sir. So what are the other parts of the equipment?
So far we have two things. One is this handle with the needle where you're gonna take the bite of the tissue. And the second thing is the suture material. So I'm just trying to demonstrate how you can take a bite. See, now my needle is loaded. And once I get a tissue, I can
Please
get a bite of
focus
the
on
tissue,
the needle.
unload my needle,
Tip of
and
this.
can open my. Okay, so I'm gonna load my needle. I took a bite, unloaded the suture material, and right now my apparatus is ready to take a bite. Once I take a bite, I go ahead and unload my needle, and right there, you got a bite, and your tissue should have a suture material in there. Third thing which we're going to use is the tissue helix. This is used to grab the tissue material. Can you focus here? Once my helix is out, if you can, right here. Can you see it?
Yes.
Yes, sir.
It's a shape of a helix, and once your helix is out, you can grab the tissue, and that will facilitate grabbing your tissue into the suture material. So far we have three things. The last piece of instrument which we'll use is the cinch. Cinch is used to cinch. Can you? So once you are done with your suturing, and you want to anchor that cinch over there so that you can tighten up the tissue. We'll definitely demonstrate this at once we had taken few bites of the tissue. So with that being said, we can get started.
Double chin. So what is the diameter of your double channel scope?
I'm not very sure, but diameter is around 12.5 millimeter.
And there is some existing sheath, I mean pre-placed sheath. We could see.
Pre-adjusting?
So pre-placed sheath, some sheath through which the scope is moving.
So that was an overtube which
Overtube, okay.
yes. We put an overtube so that you can facilitate passage of the apparatus. Can you guys hear Dr. Rakesh too or no?
We can hear you, sir.
So I'm right close to the antrum. I can see the angularis. I'm going to start taking sutures from the angularis one bite at a time in a U-shaped pattern. I'm going to keep on coming proximally up to the fundus. We're going to leave the fundus without sutures. So here I'm going to go ahead and get started loading my suture. This is your first step.
On it? Yeah, okay. Yeah, so the double channel scope has got two working channels, the 3.7 and 2.8. 3.7 is through which Dr. Kalpesh has put in the anchor exchange, and the smaller channel 2.8 is for the helix to come out. So this is one procedure which is a little cumbersome and it will take a little time, and it is completely operator dependent. The role of the tech in this is very minimal.
I think my needle.
So while Kalpesh is doing it, if any questions from the audience, I will be taking some of them while he's busy in doing the procedure.
Get this taken out.
So, what is the most difficult part, do you think, sir, during this procedure? Which step is most difficult?
The most difficult part in sense, see, one is, I mean, see, nothing is difficult if you pass the learning curve, actually. But otherwise, when you are doing a U pattern suture and you are coming back to the place where you started, that is where you will have a little bit of confusion, because the edema will be there from the mucosal folds, number one. Number two, as you're coming up above the GE junction, then the space gets narrowed and you will be having some islands which are untouched. So you will end up, sparing those islands, and that will not give a robust suture pattern. So this again comes up with practice, and the learning curve is around 20 to 25 cases, definitely. So, what happened?
Needle is stuck in the chain. Okay.
Okay. So there's a little bit of technical issue they are doing in the scope. They are just trying to rectify it. So how many in the audience are doing ESG currently?
No,
Anybody
there
in the
are
audience?
predominantly surgeons in the audience. You can ask how many of them doing bariatric surgery.
Okay, that's a good one.
Hello.
So,
Yeah, Saumin, in the meantime, they get the scope technical snag. You can go on to another theater and come back.
Yeah, so
Yes.
we are going to again to OT, switch to OT1, where almost 40% stone has been broken. Please switch towards the OT1.
Yeah.
Needle है ना वहाँ पे engage नहीं हो रही थी इस much.
I will do it.
Sound, and you switch sound also from another OT, so that Dr. Sanjay Rajput, sir.
ये तो engage नहोती थाती.
Hello.
ना
What happened?
यहाँ पे वो engage
Dr.
नहीं हो
Rajput,
रही.
sir.
Can you hear me?
Yes, sir.
So now you can see the stones fragmented, and then we can go above the stone. We can go into the IHBR.
Can you switch the view, because intra-CBD views is very small in the corner. Can we enlarge that view?
Yeah. Can you increase the view? Now you can see inside the CBD.
Yes, we can see.
All the fragments are broken and we are in the IHBR. So we have to be also careful while breaking the stone that some of these stones might go into the IHBR. So you do not flush too much of water once you have broken the stone. Guide wire. So I am removing my laser fiber and now I will put my guide wire through the spy scope only because I want to go into the IHBR.
Can someone enlarge the view of the spyglass, because here it is in a very small
Enlarge the view of
corner.
spyglass.
Yes, now we can see. This is the intra-CBD view from the spyglass.
Can you see now?
Yes, we can see now.
So we have gone into, because the clearance of stone, most important thing is you have to go above the stone. Unless you see the normal mucosa inside, you have not broken the stone completely.
This is intrahepatic part of the biliary tree.
Yeah, intrahepatic part of the biliary tree, which we can see very clearly. Then you have to pass the guide wire into whatever duct you, this spy scope is very important also in cases where you cannot pass the guide wire into selectively into right or left IHBR. And very recently it has been shown that you can pass two guide wires, 0.025 two guide wires from the same channel. So that is also important when it is difficult to pass a guide wire into the right duct or left duct when there is a cholangiocarcinoma. So you can pass two guide wires, 0.025 guide wires from the same channel. That is also a very good armamentarium. Wire.
Sir, here most of the audience are surgeon. So one practical question from surgeon side. In absence of malignancy or stricture, which are the cases that you will not do by spyglass and refer to surgeon?
For stone? Or stone?
Yes.
No. Not a single case. Unless
not very encouraging answer for surgeons.
Yeah, I know, but now with the help of spyglass, we can remove any stones from any side except patient having multiple stricture with large stone above those stricture which require diversion also to prevent the future stones.
Sir, in case of stone, large stone impacted ampulla.
Yeah, we are going to publish a series of 30 cases of cystic duct stone which are remaining there for post-cholecystectomy. We have removed the stones from the cystic duct and we can help you in cases of Mirige's syndrome where you cannot reach up to the level of CBD due to adhesions or due to some other reason where complete clearance of the common bile duct and cystic duct is not done while doing cholecystectomy. So we can help in those cases also. We can go into the cystic duct, we can break the stone and we can remove this. So in near future, we are going to publish this series of 30 cases of cystic duct stones.
So in stone impacted ampulla, when the large stone impacted ampulla, so in that case,
that is very easy to remove without laser.
That you just do pre-cut.
You do pre-cut.
Excellent demonstration, sir.
Yeah. We are just going to clear this within 2 minutes.
Yes. So just to
you can wait for 1 minute. Yeah.
Audience enlightenment, the stone size was 2.5 centimeter. Okay. So you see the actual procedure time is around 30 minutes and we can discharge this patient in the evening with oral antibiotics for 2 days. That is also we are doing prophylactic stenting because we don't want any chance.
See the stone fragments are coming now. So we have done enough fragmentation of all stones. And with the help of spyglass, you can do the without IITV also. That is, in pregnancy, it is also very helpful to remove CBD stones with the help of spyglass without doing fluoroscopy. So it is no fluoroscopy, laser lithotripsy can help in the cases of pregnancy. You can directly cannulate into the CBD and then go with the help of this spyglass. And after clearance, you can demonstrate clearance with the help of spyglass. So that is also a very important indication. If patient is having cholangitis during, see the stone fragments. So we have almost completely cleared the CBD, and now we will put a stent. There are a question that whether you will put a stent or not. We always put a stent just to after clearing this CBD, even with the laser, because there are some chances of cholangitis even after doing the laser lithotripsy and spyglass lithotripsy. So it is always better to put a stent and remove it. If patient is not affording, there are questions that if patient is not affording, he has to undergo another procedure, but that is acceptable rather than putting the patient with the risk of cholangitis. So you can do it free of charge if you want to reduce the cost. So now
excellent demonstration, sir. We are now switching to OT3.
Thank you very much. Thank you.
Where, sir, your assistance will be needed in second case also.
Yeah, sure.
So you stay here, and we are switching to OT3, where Dr. Zahir from Asian Institute of Gastroenterology, Hyderabad, and Dr. Radhika Chavan from ANS Clinic, Ahmedabad,
Down the pen.
going to perform eclasia cardiac case for peroral endoscopic myotomy. This is a young boy around 50 years, presented with the dysphagia of 1 year duration and manometric eclasia.
Without IIT,
What is the age actually? We couldn't hear exactly. What is the age of patient?
Zahir bhai.
Yes. So
just discuss about this speedboat also.
Sure.
Okay, then you discuss about the eclasia.
Right.
Okay.
So good morning, everybody there. Am I audible there?
Yes, you are audible.
And is my screen visible here?
Yes, inside view is visible. Outside view is also visible.
Right. So I'm Dr. Zahir. With me is Dr. Radhika, who is also a third space endoscopist, along with many other things that she is doing. So this is a young boy, 30-year-old, with type 2 eclasia, symptomatic for 1 year. Actually, they are symptomatic for many years. But then the way they describe their symptoms is that symptoms have increased for last 6 months or 1 year. So usually these patients are symptomatic for many years before they present to us, because initially they are being treated as either gastroesophageal reflux disease or functional dyspepsia or functional heartburn before they finally, now with the availability of manometry, these cases, more and more of cases with dysphagia, they are being referred for manometry and they are being diagnosed early. 30% of these cases, they have normal endoscopy. So a normal endoscopy does not mean that the patient does not have eclasia. If the patient has, in the correct clinical context, they can still be diagnosed as eclasia if you use high resolution esophageal manometry, which is the gold standard for diagnosing these patients. Now coming to the management options, that what options do we have to manage this patient? Now we have three main modalities of treatment. One is pneumatic dilatation. The other is Heller's myotomy. Both of these modalities for many decades, they have served these people and they are still in place. It's not like now we have started doing peroral endoscopic myotomy that they have replaced, but this is an additional option that these patients have. Now, a 30-year-old patient, why do we not prefer pneumatic dilatation? Now, there are many studies which say that these patients are likely to have a relapse, especially those less than 40 years of age, if we do pneumatic dilatation. Means the number of dilatations that these patients require may be endless. So it's not a long-standing treatment in these cases. Now we have two options. One is Heller's myotomy and one is peroral endoscopic myotomy. Both are equally good treatment options. I have no grudges against Heller's myotomy. It's a beautiful treatment. It has matured over almost 100 years. Now it's in place and it's a very good treatment modality. Many patients now prefer a scarless type of therapy for them, and which will give equally good relief as Heller's myotomy. So you can see that I am into the esophagus, and in this case, what we are going to show is the use of a new device, a new knife, which is called the speedboat knife. Now, why do we call this a speedboat knife, and why this device is different from other devices? You can see that shape of this device is like a speedboat. So that is why this device is called speedboat device. Now, how is it different from other devices? This device is a bipolar device. All the other knives, they are monopolar knives. Now, what's the difference between monopolar and bipolar? In bipolar, the path of electric current is localized, right? So you don't need to have a grounding pad. You don't need a long circuit to be completed. There are minimum chances of any skin burns. And moreover, there are no additional, the current will stay where we apply it. It won't pass on to the nearby. So there is no collateral damage when you are using a bipolar device. So this is very important to understand that now the world is moving towards bipolar devices. Bipolar devices are safer, bipolar devices are more efficient. And this device, unlike the other knives, it uses a complete different energy platform. So this uses radio frequency energy for dissection and microwave energy for coagulation. The other advantage of using this device, which is now available in India, is it has an integrated 26 gauge needle, which means that you don't need a separate injection needle. You don't need separate coagulation grasper. It has coagulation capacity as well. So with the same device, you can complete the entire procedure without the requirement of changing accessories. Now you see the yellow surface. If you see the screen, this device, the top surface is the insulated surface. And if I turn the device, you see a metal hull here. So this is a protective hull, means it will protect the muscle bed till the point we want to cut the muscle. So this is a protective hull, and the white ceramic edges that you see, you can see a white band here. This white band is the main cutting portion. So it's a bipolar electrode here, where the current travels from top to bottom of this white ring. So now to begin with this procedure, we have seen that his G junction lies at somewhere around 42, 43. We come up, because this is a type 2 achalasia, we don't need to do very long myotomies. So we will start somewhere around 5 to 6 centimeter above gastroesophageal junction. I'll just rotate. I have with me a very expert assistant, Mr. Narayanan, who is also the main distributor of this device and very expert assistant. So you can see there is a hole here from where the needle will come out. I'll project the needle and we'll start the procedure. So you'll see this is the needle here. I'll insert it and he'll start injecting.
So Dr. Zahir, are you going to do posterior myotomy in this patient?
So you can do an anterior or posterior, but when you are using this device, it's very convenient to do a posterior myotomy. The other reason I do posterior myotomy, look, nothing is permanent for these patients because achalasia cannot be cured. This has to be remembered. Achalasia is basically a problem which occurs due to degeneration of neurons. So whatever treatment you are doing pneumatic, or you are doing Heller's, or you are doing POEM, you are not going to grow back the neurons. So a proportion of patients will definitely come back with recurrence. For example, 5% of patients with who undergo POEM, they'll also have a recurrence. 5 to 10% of Heller's myotomy will have recurrence, and 50% of pneumatic dilatation, they'll have recurrence. So why posterior? Another reason being, suppose this patient comes back and says that I don't want to undergo a POEM again. So there is an option that Heller's can be done in this patient because I am leaving the complete anterior side intact. Enough. So you see, the first and important step is a good injection. You see that this is our submucosal injection that we have done. So this is the first step. The next step is that we'll use this device to make a mucosal incision.
So for this device, you just tap or you press foot pedal continuously.
So tap is always better because it's more controlled. So see, this is the mucosal incision that we have created. I'll increase a bit more. So now you see the bluish structure here. This bluish structure is basically submucosa. So our main aim is to clear these submucosal fibers. So here I'll use this device. So this blue is all submucosa, right? So what I'm doing is I'm clearing the submucosa from so that I will create a space so that I can enter into this submucosal space. So I'm not hurrying to enter inside. My main aim is I should clear enough fibers so that I can enter into the submucosal. Now see, you see two layers here. This is the one that is at 6 o'clock is the muscle layer, and on the top the bluish colored layer is submucosal layer. So my main aim, the first aim is that I should conveniently enter into the submucosal. The first aim is almost over. I'm entering inside the submucosal tunnel. So this is the submucosal tunnel. So I am between the mucosal layer and the muscle layer, and I'm clearing the submucosal fibers, which are bluish fibers. So see, this is a very controlled process, means all the steps you are under your control. And see how beautifully this bipolar device is working. It's not transferring current to any other place. So in contrast, if you are using a monopolar device, the monopolar devices tend to, because their current, there is always some collateral damage, means your current also gets, the thermal energy also gets transferred to other areas where you don't require it to be transferred.
Excellent demonstration. And you see, there is almost no blood. Okay. And meanwhile, you are tunneling, sir. We are switching to OT2, where Dr. Kalpit is taking stitches for sleeve gastroplasty patient.
Sure, Saumin.
Please switch to OT2.
Dr. Kalpit sir, we are with you.
So here we have taken 4 bites so far. Started from the antrum. We're going towards the posterior side. Right now, I think my needle is stuck right there. We're having some technical difficulties here. So I'm gonna try to take 1 bite over here. Helix out. Rotate. So what I'm trying to do is grasp a gastric tissue.
So the suture pattern, what he's doing here is, we take the first bite on the anterior wall of stomach at the incisura, then the second on the greater curvature, third on the posterior wall, and then take a U-turn. Again, the posterior wall, greater curvature, and the anterior wall. So by and large, around 6 sutures, 6 bites will be taken. So he's now going back to the position where he started. So he's on the posterior wall. Now, Kalpesh, you're going to take on the greater curvature, right?
Yes, I'm going to take 1 more bite on the greater curvature, and then finally, once we have a U-shaped formed, we're going to let close the suture. So here, out.
Yeah.
Okay. Rotate.
Yeah.
So again, I'm trying to grab the gastric tissue.
So you can focus on the hand movements of the operator. So the helix is used to grab the tissue inside the 2 towers and then close the anchor exchange, transfers the suture, and unheal the helix. As you see here, there is a bite. It is a little superficial, but still okay. Now you take 1 more nearby. First load the suture, transfer the needle, and then probably here you can take 1, so that the superficial bite what you have taken earlier will be a full thickness now.
Okay, out.
Yes. Yeah.
All right. So this is a full thickness bite. You want to see the blind out so that you can make sure that you've got your muscularis mucosa and even to the serosa.
Right. Nice.
Unhelix it.
Okay.
So
you can take the helix inside so that the vision won't get obscured. Now you transfer the suture onto the needle and ready for the next bite. So I think here, Kalpesh, we can go here and then here. 2 more and then cinch it.
okay.
Okay.
I think
Yeah.
right
Oh,
there
yeah.
is fine.
Yeah,
Helix
exactly.
out.
Perfect. Looks good.
Rotate. Do 1 more time. Yes, that's good.
Yeah.
So here I'm grabbing the tissue while slowly trying to get a full thickness bite.
Yes.
See, once you see this red out, you know that you got all 4 layers of the stomach.
Yeah, it's something like the banding.
Okay. You're going to see small amount of bleeding. Of course, this is more magnified.
Yeah, but not to worry, I think, because once you cinch, that itself will cause the hemostasis. So now we have come to the place where you started. So I think you can take 1 here and then show them the cinch.
Okay, right there.
Yeah.
helix out, rotate it 4 times.
Okay. Yes, looks good. Okay. So Kalpesh, you want to cinch it here
So-
because you have come
yes,
to the
so
place
we-
where you started.
Yes, we've came to the spot where we started, get my helix out. I'm
So
gonna
it-
go ahead and deploy my needle.
Yeah, you can show them the hand
Okay.
movements. So he has
So-
left the T tag is out and he's taking out the anchor exchange. And now this suture will be cinched with a device called cinch. You can show them the device.
So can you focus here? So the cinch comes with. Okay. So the cinch comes with the system where you can literally thread your suture material into the cinch. So he's just gonna pull this out. How are you?
What happened?
So what he's doing is he's troubleshooting the T tag which came out. He's just trying to thread the
Oh, yeah.
cinch through that hole.
Or you want to take a new one?
If you have a new one, we can just take a new one.
We can redo it later.
Get me a new cinch. So this cinch is usable. You can still use it. For sake of time, we're just trying to use the new one so that we can fasten up. We'll just do the cinch.
We'll do
and
the
then-
cinch and then you can go. Just 2 minutes. So that- Yeah. So Shyam, you
Okay.
can show. So you can see on the screen. So this is called the cinch with a Apollo overstitch tag. So this cinch has to come onto the suture, as you see here, and then this will be held by the operator, and this
So-
has to be gently parallel to the ground, has to go inside. 1 second, hold on. Yeah, you see? Yeah, right. Okay. Yeah,
You
I'll
got
leave
it?
it. Yeah, okay. Perfect. Okay, so the cinch will railroad onto the suture.
Okay. You got the.
Yeah, we got the thing. So you can push the cinch out and showcase on the. Now we can show the endoscopic view. Let the cinch come out.
We have Dr. Vismit Joshipura with us. He is very familiar face in surgical community in Gujarat. He is from
All right.
Ahmedabad. He has
Now
done.
my cinch is out. What I'm gonna do is I'm gonna tighten up my suture a little bit.
Yeah, hold the suture. You have to go there.
Gonna try to just
Yeah,
cinch it
yeah.
a little bit.
Okay.
And
Yes. You want to push the scope?
yes, push it a little bit in.
Yeah.
So what I'm trying to do is get
Mhm.
my cinch out a little bit up.
You can give the tension to the suture.
So right here, you can see the stomach is slowly.
Yeah, very nicely. You can see the stomach folds getting
Fold.
opposed. And I think you have to go here and then aim the cinch there. You can push the cinch inside into the outside, I mean,
Okay.
outside the scope. Yeah.
All right.
Okay.
Now go ahead and fire my cinch.
Okay. So one important thing here is you have to see these concentric rings, at least
Okay.
4 or
Got
5. Because you see- And you can also show them how
Show the handle.
Shyam
so the
is
how-
cinching it.
So right here, I'm gonna keep my constant tension on the suture.
Yeah.
While he's firing my cinch.
Yeah. So he'll unlock by loosening his fingers and the lock is open. Then with both the hands, he'll give good amount of pressure. Yeah.
This
He's
is an
showing it.
important
Sham,
step
go ahead.
because whatever
Yeah.
six.
See what he's doing is he's tightening both the hands and then you'll get a click and the suture got cut. So now you see on the endoscopic screen, the suture is out of the scope. And can you show them the first line? You see,
Can
there's
we
a nice.
reverse the view? We can see enlarge inside view.
Yes. Can you show the
Yes.
endoscopic view?
So as you see here, there is a nice concentric ring kind of pattern of a suture. As you already see, there is a luminal compromise here, and that's where he started. So can you showcase them?
Yes. So this is where I started.
Yeah. So
You
that's the
can see
pylorus,
the,
and this is the antrum, the incisura. So one round of sutures is done. So in this way, we'll go in the ascending order up to the GE junction. By and large, the rule is around 5 to 10 centimeters above the GE junction we stop, and we don't switch the fundus because fundus is blind for us, unlike in sleeve gastrectomy where you chop off the fundus.
Sir,
Yes.
how the knotting has been done? We couldn't, as a surgeon, we always have curiosity. Once you pass the suture, how you knot the suture ends?
Yeah. So as you see here,
what has it been exactly done there?
What is?
What is exactly done there? How we knot
So see,
is placed?
I'll tell you, the suture, once it is done, there is a T tag at the end of the suture, right? So the T tag is dropped. And this cinch, what it will do is, it will go from the other end of the suture. And on one end, you have an anchor like a T tag, and on the other end, the cinch is there. So these two will oppose, and then they create a robust suture lining. And with that, once the cinch is put across, then we cut it. So one end, you have the T tag, and the other end, you have the cinch. So these two will become a knot. I think I am explaining, but you cannot imagine. What I'll do is when he's doing the second line of sutures, I'll show you exactly on the screen what we are going to do. But I hope as surgeons, you can get my point.
Is it extracorporeal?
We are taking another 4-5 bites. We are switching to the
sort of clipping on the two ends. Sometimes people do, they during surgery also, they keep two ends together and apply the clip. This is something like that only.
Exactly. Yes. Very true.
So we are switching towards the OT3,
Sure.
where they are reached near the GE junction.
Okay. Right.
Okay. So this is the crucial junction of dissection. Okay. So
normal scope.
Zahir bhai?
Yes, yes.
You are live. Okay.
Yes, yes. So we have almost, meanwhile you were there watching the ESG procedure, we have almost finished the tunnel. I'll just show you that what we have done so far. So this is the stomach side. So we have already reached till stomach. And how we recognize is, one is of course, because we find a narrowing at G junction, and then when you cross it, then you can realize that, okay, this is the narrowest part of the tunnel, which is of course going to be gastroesophageal junction. The second is, can you see the vessels here, which are spindle shaped vessels? So I'll just freeze it here, and you can see that at 6 o'clock position, you'll see a small spindle shaped vessels, which are which indicate that this is stomach, nothing else. So these spindle shaped vessels, they are classically present on the gastric side of your tunnel. So coming up, I'll just show you what how much we have done. So this is the tunnel that we have made so far. I'll again show you the mucosal incision. So this is our incision that we made, and we have gone till across the G junction. So this is the G junction that we have crossed, and you see that we have gone. You can see this bluish discoloration, which means that we have gone across into the stomach. So our tunneling is almost complete, and this is the extent to which we have gone inside. So I come again. See, this is all everything is pretty controlled. This is my incision. I go inside and will show you the tunnel again. You can see a narrow part right at this end of the tunnel. So this is probably the gastroesophageal junction, and we have gone at least 2 centimeters beyond gastroesophageal junction. Can you appreciate the narrow part? So this is the part which is causing trouble to this patient. So the next step is, of course, myotomy. And Again, as I told you that a single device can handle almost everything. So everything is bit controlled, and you can see that here we start cutting the muscle.
It's a very beautiful view of myotomy we are observing.
So you see the circular muscle fibers here,
Yes.
right?
Yes, sir.
So it means that we are still, we have to still go a little more.
So are you performing a selective myotomy in upper part?
Anything can be done. It all doesn't matter if you cut only circular or you cut both circular and longitudinal. My practice is, the way I have learned is that I cut only circular in the upper part, and then I in the lower part I cut both circular. Now you can see the longitudinal muscle fibers as well. Can you see? So how
Yes, sir.
beautifully we can selectively separate longitudinal and circular muscle fibers. So there are a bit of small oozes here that I can control using the same device. And this is microwave coagulation, which is working here. So again, my job is to hook into this groove, which is the groove between longitudinal and circular muscle fiber. And step by step I go. So I don't press it for too long, because if there is a bleed, I can control it then and there itself. So you can see that we at this moment we are preserving the longitudinal muscle fibers, but then it's not mandatory that you can cut both the muscle fibers. There is no difference in the outcomes. There is no difference in complications. So doesn't matter. But it's just the way I have learned this procedure, that I cut circular in the upper part and cut both longitudinal and circular in the lower part of the tunnel. So as I reach the G junction, I'll be cutting both. That portion also I'll show you. So, and see the cutting capacity of this. I just have to press the pedal. It's like a speed car. You just press the pedal and it will cut. So you have to be careful as well, because you don't want it to go uncontrolled. So, and the role of assistant, unlike ESG, where Rakesh was telling that it's all dependent on the one who is doing the procedure, here it's equally important that your assistant is also trained well, so that he can rotate the device whenever it's required. So it's very important that you have a good coordination with your assistant. So, and you keep on checking whether the direction of your myotomy is right or not, because if you don't orient your myotomy correctly, then you may go towards the mucosal side, right?
So,
Dr.
Zahir,
Zahir,
you are doing a myotomy. We are switching towards the OT one, where another stone has been braked by another technology called electrohydraulic lithotripsy, EHL, and that case is means performed by Dr. Sandeep Pal from Calcutta and Dr. Kapil Jamwal from Delhi. So we are, meanwhile you are doing a myotomy, we are switching toward the OT.
Sure, sure.
आगे इसको थोड़ा आगे नीचे करने थे नहीं अभी रखो बाहर ही रखो बाद में निकलेगा नहीं दिक्कत होगा हेलो
yes,
are you audible?
Yes, yes.
Hi, I'm Dr. Sandeep, and along with me is Dr. Kapil. So what we are doing here is we are demonstrating. You have seen earlier Dr. Sanjay Rajput has done this ERCP, in which he used laser lithotripsy to break the stone. So this is another technology by which you can break the stone. This is known as electrohydraulic lithotripsy, EHL. So if the cameraman can show the machine here, this is the machine. This is known as otolith. The machine, can you see the machine, otolith?
Yes, sir.
So here you can see there is power, then EHL pulses. So you can adjust the EHL pulses from 5 up to 30. Maximum is 30. And the pulses come in 5, 10, 15. So we'll keep it as 10. And the power also you can keep it as low, medium, and high. So it's a very simple machine, nothing much. So what you can, what we have done here is, so we are inside the CBD. You can see my cholangioscope inside the CBD, and adjust karo. And you can see the fiber of the EHL fiber outside the cholangioscope. I'll show you the stone. So this is the stone.
We can see the cystic duct also. Yeah.
So you can see the cystic duct opening. So here the principle is you target the stone, but your fiber should not touch the stone. It should be little bit away from the stone with some millimeters difference. And the principle is there are some electric pulses. There are electrodes in the tip of this fiber. And when you press the pedal, these electric forces, they create some electrohydraulic power with the pulses of the water, high jet water we have to flush along with this, and this breaks the stone. So let's see, and always it's better you target the center of the stone. Hello?
So it's a electrohydraulic.
Electrohydraulic
Means you have to continuously
flush
flushing the
water.
water.
Yes, yes.
So this electric pulses will produce the shock wave in the water.
Yes,
And
yes.
because of that shock wave, stone is going to
break.
Yeah,
Exactly.
Sir,
That
we
is
need
the
a
basic
minute
principle
just
Yes,
to
yes.
with the laser
call
and
our
EHL.
chairperson for more interactive
Well, the
discussion.
patient is a little bit awake. Yeah.
One second, sir.
You can see
Dr.
already-
Harish Mistry.
You can see already the stone
Dr. Anup,
has started
Sir,
breaking.
you can
Sandeep sir,
continue
yeah.
here.
We are
Please.
inviting few chairperson, so please.
We are inviting some more chairpersons for more interactive discussion. Dr. Harish Mistry, Dr. Sanjay Prasad, Dr. Vipul Pastagia, Dr. Rahul Gupta. Please come forward to the front rows. Dr. Rajesh Patel, Dr. Natu Kataria, Dr. Janish Sheth, Dr. Prashant and Dr. Mitul. Please come forward to the front row and participate in the discussion. Thank you. Sir, you continue, please.
Yeah, so as you can see, the stone, we have to target the center of the stone. As the stone is moving, it's a little bit of a challenge to keep on focusing. But because, as I said, there are a particular number of pulses which you can fire from one fiber. So to save the, to get maximum utility out of the fiber, you should always target the center of the stone so that it breaks into pieces, and later you can take it out either with balloon sweep or.
Dr. Pal.
Yes.
What made engineers devise this another lithotripsy apart from laser? Why it was required? What was the limitation of the laser that led to this?
No, see, both the modalities you can use. The laser it requires this machine. The one-time expenses of the laser is more. This is bit less cost. This
one is cost.
Yeah. The cost is less.
And second is, it is basically the urological technique which has been brought into the endoscopy. So all this were made for ureteric stones only. Both EHL and the lasers were made for them only. So now they have the technology has come into for our use also. So similarly, they were using both the laser as well as
the stone has fragmented quite a bit. You can see the powder. Yeah. Yes. Keep on giving flushing. So we have created this crater in the stone. You can see the center of the stone. We have created this crater.
Yes.
And it's almost broken into half. So what you need to do is to just break the stone into two pieces or smaller pieces so that later you can take it out with the balloon sweep or basket sweep. So this is a simpler technique, not so difficult. The advantage with laser is more effective than EHL, that I have to admit, because in laser you can make the stone more powdery. You can convert the stone into a powder. This will just break it into pieces.
Okay. Any other advantage over laser?
Advantage, as I saw, this is, as I said, the initial expenses is less in this unit.
And the data is similar. So the
data is similar.
Yeah, the data is from 67
and
to
safety
90.
profile is similar, right?
Yes, safety profile is very safe. If you heat the CVD also, nothing happens.
Right.
Hi, good morning. This is Dr. Janish Sheth.
Yes.
What are the specific indications for EHL and what are the specific indications for laser lithotripsy in these cases?
As I said, these two are same. The work is same. What that is to break the stone. There are whatever you have. If you have the laser, you can use laser. If you have, so I have crossed the stone. As you can see, we have broken the stone into pieces. So I have to come back.
This
So
is into hilum, yeah.
Yeah, this is into hilum. If you have just seen the hilum of the CBD. So center mein rakho. So this is the stone. Yeah. So there is no specific advantage of one above the other. Effective wise, I think the nikalo. Effectiveness, if you see, the laser is better than EHL in breaking the stone. But again, if you the cost is more of laser machine, whereas the EHL is.
Sir, what is the initial cost of both laser and EHL, and what is the per case cost of the both comparison?
The cost depends how much you keep. So along with cholangioscopy in my unit, along with cholangioscopy, if we break a stone, it's around 50,000 rupees.
So initial cost of, I think, laser is higher as compared to EHL. And if you have an associated urology unit, you always have a laser with you. So that time you can use a laser. Suppose you don't have, and then you can buy EHL. So it depends upon how your hospital dynamics are. So if you want to buy only one machine, I think the cheaper is the EHL.
So just now you have seen, we have broken the stone again. So it's a more, already the stone is small size now. So when the stone is mobile, it is difficult to focus the laser on the stone, on the EHL. If the stone is fixed, it becomes easier.
Yeah. So if duct is dilated,
So I think if the stone is fixed, it is easier. Then I believe that it would be easier to do the same procedure from the top end, that is through the laparoscopic CBD exploration. If we can, if urologist lends up the same machine to us, we can do it better, because the flow of the fluid is towards the duodenum rather than towards the liver.
Yeah, both
What do you
modalities
say?
you can do. If the patient comes to you, you do. If the patient comes to us, we will do. The effectiveness is same. The only the invasiveness is less here, as you can see.
Yes,
This is just
but this needs
endoscopic procedure.
cholangioscope. One additional instrument is required, is cholangioscope, which is expensive one, delicate one, and the expertise is less.
Expertise, I think the learning curve is not that high. It's not that steep.
Okay, availability is less.
Sir, it is just like you are doing ERCP and you are inserting another accessories. So
Yes,
learning curve is
agreed,
low.
but the
So
availability of
expertise is not at best,
cholangioscopy is less.
If you are able to do a good ERCP, you will be able to do cholangioscope. Only thing, handling requires a little bit more delicacy. Otherwise, there's no very high technical skill is not required. You don't require a very high learning curve.
So I think we are
and
done.
good thing
We will
comes with the cost only, sir.
give a
So
balloon.
non-invasiveness is always more costly than invasiveness.
So we'll just use a balloon now to take out the fragments. We have converted the stone into very small
we
pieces.
believe that the invasive, on the long run, invasiveness is costlier than non-invasiveness.
So I think over the time when other companies come up with a cholangioscope, I think 2-3 companies are there. When the competition will increase, I think the cost will come down. At the moment, only Boston is making it in India or in world. So that's why the cost is little on the higher side.
No, the cost also, if you see, as I said, we charge around 50 to 60,000 rupees. Anyway, that is not much. And the same day admission, patient can be discharged on the same day.
Yes, we can know. We agree on that. But regarding the cost, I think the bottle of the Coke and the bottle of Pepsi are of the same price still, even after competition of around 70-80 years.
Yeah.
Change the image.
VIP.
Change the image.
Which image you want to see?
No, he has already removed the cholangioscope, so he will change it to endoscopic view.
So we are switching towards the OT3, where Dr. Zahir has almost completed the myotomy. So we can see the post-myotomy view.
Fluoro.
Okay. Switch towards the OT3.
By the time, just regarding the cost, that when I was studying and the robotic was introduced in the world, and at that time also people were hoping that the cost of the robot will come down. I think 20 years, the cost has not come down at all. The cost of equipment, especially the good equipments, I don't think they come down just because the competition has increased. I don't think that is a myth now.
I personally feel, sir, cost discussion is depends on the patient profile also. Okay. So when you are going to provide some excellence, it comes with a cost, because whatever the company has developed this device, they have invested lots of the money
Yes,
for the
yes.
research. Okay. If
Yes,
you
yes.
discuss about the spy
Sufficient.
glass, it may take around 20-30 years to develop this device. Okay.
Yes, yes.
Before initially prior model. So we have to agree with that, but that the research is an important part of, and we have to pay for it. Okay.
Yes, yes.
Now,
We agree upon the cost demanded by the company. What I want to convey is that the myth is that the competition will reduce the cost. I don't think it will reduce the cost. If you are demanding quality, then I don't think the cost will come down.
and another thing, sir, once cost will come down, quality will automatically come down. Even in competition.
So there will be some less efficient, cheaper alternative will be there, but it can never be as good as the one those who have pioneered or those who have mastered the equipment.
Yes. The set of Karl stores is of similarly costly still, even which was even in 90s.
Yeah, and recently introduced CMR is nothing, I mean, in competition with the Da Vinci, which, okay, so when cost is less, definitely the quality decreases.
Hello.
Yes, we can hear you, and we can see Dr. Zahir,
Yeah,
we can hear you.
Yeah, so we have completed the myotomy. In fact, almost the entire procedure has been completed. I'll just show you the G junction, how the G junction looks like once you finish the myotomy. See the
Beautiful.
G junction now.
Convincing. Dr.
this-
Zahir, only one question for you, technical. It was a beautiful dissection, and probably it was not anatomical dissection. I would say it was an histological dissection, right? You show us the circular fibers, you showed us the longitudinal fibers, which we were only imaging when we were studying anatomy. It was a beautiful dissection. The only one question is that, would it be the same nice dissection if the patient would have undergone some sort of balloon dilatation previously? Or would it be difficult?
Very good question. In fact, what I have found is that if the patient has undergone pneumatic dilatation, sometimes it's easier to cross gastroesophageal junction because it becomes a little relaxed. It's not as relaxed as after you do poem or Heller's, but it's a bit relaxed. The LES pressures are lower as compared to those who have not undergone treatment. So some cases, very few occasions, who have undergone multiple dilatations, say 5 or 6 dilatations, as is commonly the scenario in our country. In some cases, you may encounter some amount of submucosal fibrosis, but usually that's not an hindrance to performing per oral endoscopic myotomy. Now the technical success is close to 100%. Technical failures are only reported as very rare occurrences. So this is the end point of myotomy. You can see what we want to see is at the top is at 12 o'clock is mucosa, which we want to preserve because that will be our barrier, and we don't want to injure the mucosal part. And here you can see the submucosa, and you can see some omental fat as well. You can see some yellowish glistening fat from here, which is also a telltale evidence that we have entered into the stomach. Otherwise, you are not going to see this peritoneal fat here.
Dr. Zahir?
Yes.
So from the inside, do you think at 12 o'clock there is some muscle fiber is there and there is a mucosal injury is also there just above it? Your cap. Can you withdraw a cap a millimeter?
Yes, yes.
Can you see the upper end? There is a mucosal injury. Yeah, this one.
So it's like it's a partial mucosal injury because here we did encounter
And
one
some
bleeder.
muscle remnant is also there.
So this muscle remnant is as good as nothing because I can see the mucosa through it, and you can see the width of myotomy here. So the width of myotomy and this whole strand of fiber, I believe it's not going to cause any recurrence in this patient.
So my point of is only why you are not cutting this.
Which one?
Generally we cut this segment. Why you are leaving this?
Which segment, Dr. Puri?
At 12 o'clock.
I don't believe this is any segment.
Yeah,
I
this
don't
is-
believe because this is, you can see the mucosa here, and you don't want to apply any thermal current on the mucosal side. This is very clear.
So what is the trick if you come across, you have gone through the muscle and the part of the muscle has gone towards the mucosa. So audience, if you will guide them, then how you are going to remove the part of the muscle which has gone towards the
So
mucosa
suppose
side?
there is a significant bundle of muscle which has been left intact. You just have to inject between the muscle and the mucosa so that you can separate them, and finally you cut that remnant muscle bundle fiber. So here you don't see any significant, this is all mucosa that you can see. There is no significant remnant bundle of muscle that's remaining here. And this is some mucosa. This is, we can beautifully see the cut end of muscles here. The cut end of muscle is very well defined, very neat. So I don't believe that this bundle should receive any more thermal treatment, because this is mucosal side and all your attempts should be to preserve mucosa. It's not you cannot close any mucosal injury. You can close them endoscopically, but the best is prevention. So if you can prevent them, there is nothing better than that. And you see, this is what I have done is I have applied microwave coagulation. It can coagulate vessels, bigger vessels, smaller vessels. For example, here you can see the bubbles arising and acts very good. And the best part is with this generator that the settings are same, whatever procedure you are doing. You are doing an endoscopic submucosal dissection, you are doing this, just switch on the generator and you are there.
So you recommend to burn these vessels?
So delayed bleeding is bad. So in case I have a doubt that the vessel has been partially injured during my dissection, though it's not actively bleeding right now, but it may bleed subsequently, because these delayed bleeding is very difficult to control. Once you close the tunnel, delayed bleeding is very difficult to control. So it's always better that if you feel that the vessel has been partially injured or some amount of thermal injury has been transferred to the vessel, always prophylactically coagulated, because it's very, even whatever modality you are doing, whether it's Heller's or
routinely periesophageal plexus, no need to do the thermal coagulation. If you have a suspicion that there might be a partial injury, then you should do it.
Yes.
Because this is very important message should go. Otherwise, it will take a long time to do a thermal coagulation of these blood vessels.
Finally, you come up and you see if there is any bleeding or any potential bleeding. For example, there is some red hue here. It's not actively bleeding, but I'll just apply. So this is towards muscle side. So on muscle side, you don't need to worry much. You can use this injury. But the same bleeder on mucosal side, you have to be very cautious while you are using any form of coagulating current or cutting current. It's very important that you take that care. So it's quite relaxed. We can see that it's the G junction is very relaxed now.
So there is a small, I think, mucosal injury just at G junction. Here.
This one?
This one.
It's like not exactly an injury, and you don't need to practically do anything for this sort of injury. If it's a full thickness injury, then you can definitely apply a clip there. But if it's not a full thickness injury, then you can leave it. It's as good as nothing.
Very nice.
So the final step is to close the mucosal incision. And I think that should be it. If you have any questions regarding poem or regarding this device,
the OG junction is very widely open, very nice. Now only one logic comes here, that now the things can pass from oral end to aboral end easily, but the fact is that it can be reverse also, that is reflux.
Yes.
Now we would like to have few words about the post poem reflux from you.
Very good point, very valid point. So the thing is, there are few ways which we can by which we can reduce the incidence of post-poem reflux. I have some water.
So there is a problem that is with a poem. Chances of reflux is there, but symptomatic reflux is less compared to the incidence of reflux. And see, you will see the esophagitis in 30-40%, but the symptoms of reflux will seen in a 15% only. So there is a paper by Dr. Zahir in endoscopy. In that, he has explained everything from incidence to prevention of GERD in that paper. And he has also given a long-term follow-up, almost more than 6 years follow-up, more than 500 patients, right?
So I'll tell you what is the incidence of reflux and what is the truth of reflux after peroral endoscopic myotomy. The truth is that severe reflux esophagitis, that is LA grade C and D, is found in about 4 to 5%. So we have done a systematic review and meta-analysis published this month in Journal of Clinical Gastroenterology. The incidence of severe reflux, that is grade C and D, and look, endoscopy is the best way to detect reflux in these patients. Symptoms don't match. Even if the patient is asymptomatic, you have to screen these patients for reflux at least once.
Yes.
Second, PH studies they falsely report the incidence of reflux after this procedure. So endoscopy is the only way where you can determine the true incidence of gastroesophageal reflux in these procedures. Now, what you can do, what is the incidence of overall incidence of reflux esophagitis? It's around 40%. Now, if you see all the reflux esophagitis, they don't need attention. You always concentrate on those who are having severe reflux esophagitis, because that is going to create some trouble to you. So the 95% of them, they don't have severe reflux esophagitis. What happens in future? In future, the incidence of reflux esophagitis or GERD reduces with time. So this is very important that you need to know that in contrast to Heller's myotomy with fundoplication, the incidence of reflux after POEM reduces with time, and that has been shown by very elegant studies, where what they found was that with time there is some remodeling of G junction which occurs, and with that remodeling, the incidence of reflux keeps on reducing with time in these patients. So that is something very reassuring. In fact, in the beginning, even we were worried that such a high incidence of reflux may not be a very positive thing, and probably we should rethink before doing POEM. But now, without any hesitation, we can do POEM procedures and tell these patients that definitely proton pump inhibitor therapy will be required for some time, but at the end, probably they are going to be off proton pump inhibitor therapy after say a couple of years or so.
So I think what we take message from this narration is that 40% of the people, they need some form of PPI. May I take that message?
15%.
Yes, some the PPI requirement, the protocol that we follow is that we give all the patients PPIs for at least 3 months.
3 months.
Then we stop the PPI for 1 month and evaluate ask all the patients to come back and see. Look, it's very important that you stop the PPI for at least a month before you can look for reflux esophagitis. Otherwise, you won't come to know the true incidence of or true severity of reflux esophagitis if the patient has not stopped PPIs for adequate duration. Subsequently, those patients who have significant reflux esophagitis, we ask them to continue on PPIs and again follow them up for 1 year.
Sir, what are the percentage of patients who required restarting PPI after stopping for 1 month?
Who require?
Restarting of PPI.
Restarting PPI in how many patients?
So I'll say in my practice, at least 20% will require to continue PPIs, right? So those patients who report symptoms of reflux, heartburn, or regurgitation, we give them PPIs. Those symptoms who have objective evidence of reflux on endoscopy, we continue them on PPIs. So if you see the incidence of symptomatic reflux, it's only 20%. Reflux esophagitis, 40%. And if you go to PH study, as high as 60%. So we were really worried that what are we reporting on these PH studies? Is reflux really that much high? But then
No, no.
later we realized that.
Okay, forget the PH studies, leave it. Chalo. But 20%, I think is it not a high percent?
Which clip you are using, sir?
So I'm using clips by Madora. So these have a wide opening diameter, and you can open and close them an n number of times. So very useful clips, and the most important thing is made in India. So that is something that that drive has been going on for a while, and these clips are basically manufactured in India. So close. Fire. So very easy to rotate and to apply. So coming back to a high 20% comment, look, these 20% won't be requiring PPIs for life. It's very important to realize. They are not going to continue. If you go back to older studies where they have commented that the incidence of reflux after Heller's and fundoplication, look, it's only now that we are systematically evaluating each and every patient that what is the incidence of GERD. We were not concentrating so much on GERD, say 10 years back, but now we are concentrating on each and every patient. If this incidence of reflux esophagitis or GERD would have been a matter of concern, poem would have died by now. So the first poem was performed in 2008, and now it's 14 years. So I believe that there is some degree of maturity in our understanding regarding this reflux. In fact, we also published that what is the incidence of unresponsive reflux esophagitis who don't respond to PPIs, practically zero.
Right.
There is no patient who says that he has persistent symptoms or he has persistent reflux esophagitis after they take PPIs. So two reassuring things. One is GERD is going to reduce with time. Second is everybody responds to PPIs.
Okay.
And third is symptoms have never been concerning after poem with regards to gastroesophageal reflux. You will never find a single patient who is saying that he is having so severe symptoms of GERD that his life is in trouble.
Oh, thank you. Thank you very much.
So, sir, among those grade C and grade D reflux esophagitis patient, I mean, what are the indications for fundoplication?
For fundoplication, so
yes, sir.
People have reported using surgical fundoplication in these patients. And these are those patients who say that who have excess concerns regarding PPIs, that I don't want to continue PPIs for long term. So in those patients, we do suggest that they have an option of getting a fundoplication done. But look, if I tell about my experience regarding poem and our center who has done like all close to 3,500 poems, we have not done, or our patient, none of our patient has demanded that fundoplication should be done for them, because none of them have been unhappy for regarding this reflux thing. The main symptom is main problem is dysphagia, and when they get relief, excellent relief with that dysphagia, I think reflux has been a minor problem. Especially symptomatic reflux is really uncommon.
And second thing, you have to also think about the motility. You
Yes.
can't do fundoplication because patient has also a motility problem with the entire esophageal muscles. Okay, so fundoplication result is it is very dicey in what way it goes. Again, patient may develop dysphagia also. So that's why in each and every fundoplication, ideally we should go for the prior manometry to rule out another, because esophageal clearance is grossly impaired in eclampsia cardia. This is the one of the defense mechanism.
Yes. Very well point made, Saumin. In fact, you can do an endoscopic fundoplication. You have these devices now, endoscopic fundoplication devices, where you don't create a very tight trap, and if required, if the patient is not happy taking PPIs, or if the patient says that his symptoms are not getting resolved, an endoscopic fundoplication or any other endoscopic anti-reflux therapy can be performed in these patients, and these patients are just going to do fine, because the ultimate aim is to provide prevent, the patient aims at preventing a surgery for him. And if you do a laparoscopic procedure again, then the entire thought process of doing a minimally invasive surgery is defeated. So that is the reason that most of these patients, they do well. And an occasional patient who is not willing to take PPIs, you can do an endoscopic fundoplication.
Can you demonstrate the
once there is
speedboat
a scar-
probe outside, sir?
Yes,
right
yes,
now?
yes. Why not?
No,
So I'll just
probe as well as generator.
Sure,
Just show
sure,
it
sure.
to the audience.
Sir, once if
So
there is
if
any
you can
scar-
focus on the generator, which is here. So this is the speedboat generator. It's from Creo Medical UK. It's a UK based company. And these are the settings. This is cut 30 and coag 09. So the current version is RS2, means speedboat RS2. So it has undergone many refinements, and this is the current version which is going on. These are the settings which are used for all the procedure, whatever procedure you do POEM, you do endoscopic submucosal dissection. This is where you hook your device, from where the RF energy or microwave energy is being supplied to your device. And if I'll show you the device outside. So this is the knife, and this is under the control. This is the handle. This is the control handle. This is under control of the assistant, where he will rotate this device. So this has 1:1 rotation. Which direction you want to rotate, you can focus on this device here. So this is the device. You can see the upper yellow surface. This is the upper surface. And then as I rotate, you can see a white ceramic blade, which is a bipolar blade. And finally, this is the bottom side. On the bottom side, this is a protective hull. You can see a metal thing here. This is the protective hull. So from this side, the needle comes out. It's a 26 gauge needle. So you can inject with this needle, and then finally rotate this knife so that you can cut using this ceramic blade, which is whitish in color. So this is compatible with the therapeutic channel scope. So this is important to remember that it requires a minimum 3.8 channel so that you can use this device.
Excellent. Till while we are switching towards the OT1, where stone has been completely broken out by EHL and it is out in the duodenum.
Dr. Zahir, it was a really good dissection.
Yeah. So you can see this was the last fragment after we have broken the stone inside. So we took it out with a balloon sweep. So because we have done the procedure and we have instilled a lot of fluid inside, we'll just put a stent which we can take out in 15 days or 1 month time. So you can see the stone is lying here. So this is the large piece which came out, and before this a lot of fragments came out. So we'll just do another balloon sweep and just show you that the balloon comes out freely. Inflate.
Excellent demonstration, Sandeep.
Thank you. You can see the balloon came out freely, so there is no more stone in the CVD.
Fragments also have come out.
So for safety purpose, we'll just put a stent which without doing ERCP also, because we are sure that the stone has been cleared from CVD. We'll just we can take out with endoscopy.
Sandeep sir,
Yeah.
please can you show us occlusion cholangiogram?
Okay, okay. We'll show the occlusion cholangiogram.
Just audience occlusion cholangiogram.
Chalo, अंदर जाओ, guide है.
Diag ready करो.
I normally, if we don't do cholangioscopy, if we do just ERCP stone extraction, we always ensure by a occlusion cholangiogram. But because here we have seen with cholangioscopy inside, and we were sure that only one stone was there and which has come out after fragmentation. That's why we didn't do occlusion cholangiogram, but we can do it, no problem. So, दिखाओ ये fluoro दिखाओ. Can you see the fluoro? There in the hall, just fluoro.
Yes. Yes. Dr. Pal, is there any diverticulum besides the papilla?
Yes, yes. There is a diverticulum in the left-hand side upper part. You can see there was a diverticulum. So
Oh,
as you know, diverticulum is a risk factor for recurrent stone formation because of bile stasis.
yes, sir.
Can you see now? Cholangiogram, can you see?
Yes, sir.
See, there is no stone. You can see a good CBD and it is tapered down and my balloon is just at the outlet, just at the
Yes.
papilla.
Yes, sir. Yes.
Okay. Deflect, deflect. So we'll flush in some water and just put a stent for safety purpose. You can go to the other room. We are done here. Yes. Animal. दिखाओ एक बार दिखाओ यहाँ फ्लूरो क्लियर है ना?
Can we go to ESG procedure room?
So now it is completed, and now we are switching toward the OT2, where Dr. Kalpit has almost done 80% of the job.
दिखाओ.
Switch towards the OT2.
एक बार फ्लूरो. Inflate
So we have done so far 5 sutures. What we have essentially done is we have shrunk the stomach almost into 60% less. Not only shrunken but also shortened the stomach. You can see it's now looking more like a tubular structure, and the space of the stomach has gone down to nearly less than 60 to 70%, and this will help with almost 18 to 20% of weight loss.
So I think we can take, Saumin, what we can do is we can take furthermore questions and all in the second case when we showcase the redo ESG in post LSG weight regain patients.
Okay, definitely, sir.
Yeah.
We will come back to you. Till while we are switching towards the OT1.
Thank you, everybody.
Thank you, Dr. Kalpit. Dr. Sandeep?
Yeah.
You are again live.
So we are done. We'll just show how to put the stent then. We are just putting a stent. निकाल दिया यार गाइड. चल ठीक है कोई बात नहीं इसमें डाल. So in the meantime, we can take up if there are any questions from the audience.
What is the frequency you are getting a biopsy sample positive while you are doing a ERCP guided blind biopsy? If you tried out of 10 sample, how many means it turned out to be a positive yield?
It's a question.
No, I'm not asking about the study or something. What is your clinical experience?
Can you repeat the question?
Suppose you don't have a spy glass.
Okay.
And you are dealing with some stricture rather than stone.
Okay.
So what we used to do, we delineate the stricture via cholangiogram.
Yeah.
And we try to do a blind biopsy or inserting a foreign body forceps, and in the fluoro guided biopsy we used to take.
Yeah.
Okay. So what is your experience?
So basically depends upon the site of stricture. If the stricture is very low, then ERCP is the best. Lower in the CBD, then ERCP and brush plus biopsy is the option. If it's in the mid part or upper part, US will help you more. So US guided biopsy, FNB is the best option. If required, when you are doing ERCP, you can take a brush along with it.
दिखाओ.
So US FNB will increase your yield, and if you add brush, it will also further increase your yield. So it depends upon the site of the stricture.
Till the time we are preparing a OT3, can you demonstrate the spy scope outside, Sandeep sir or Kapil sir?
Yes.
Spy scope, what is the configuration, how it can be handled, as well as generator and processor?
So one more question.
Yes.
What is the utility of spy scope in case of benign biliary strictures? Like if
So see,
since
since the advent of this cholangioscope, the management of biliary stricture has changed. Now, as you know, the definition of there is a subset of patients which we call as indeterminate biliary stricture. So indeterminate biliary strictures is around 15 to 20% of patients in whom after doing ERCP, brushing and the usual investigations also, we are unable to diagnose. In those cases, this this cholangioscope helps us. So cholangioscopically, you can take biopsies, you can take brushing, And more so for strictures, the visual impression is more important than biopsies. So there are criteria which tell us whether the stricture is malignant or benign. So there are 4 criteria which has been described by in cholangioscopic, like if there are tortuous vessels, if there are nodular margins, if there is an infiltrative pattern, then we usually call it malignancy. But if these things are not there, then usually the stricture is a benign. So it is very important that this cholangioscopy helps us in distinguishing benign from malignant strictures.
So apart from
here
diagnosis, any therapeutic intervention like stricturoplasty or dilatation of the stricture?
No, sphincteroplasty, cholangioscopy is required for sphincteroplasty.
Yeah.
Okay, so for the intra-CBD stricture,
Yes, sir.
I have not done. Sanjay Rajput has, he said he can do that.
It can be used like people who have a post liver transplant stricture. Sometimes you are not able to pass a guide wire. So that time spyglass can be used to guide the opening. So we can see the glasses here. So it's you can see the scope. So it is around 214 centimeter of length. It has a the outer diameter is 3.5 millimeter and the working channel is 1.2 millimeter. And when you see the scope, it's like a what you call baby scope, and it has a, you can see it's a like a initially started as a mother baby scope, and so it has a tip which can be, so the benefit of this is this can be a single operator. It can be fixed to the scope with the help of this rubber. It can be fixed to the scope, and it has handles which can rotate the tip. So you can see like but only one way it can rotate the tip on one. So you can see that tip can be rotated, and it has a two flushing channel. One is continuous. This is for irrigation, and this is for guide wire, or you pass the fiber through this channel. And the uses depends upon the intraoperative usability. And anything, Sandeep, you want to add?
Yeah, so that's what it's about the machine, about the scope. So the recent scope is the SPY DS2. This has got a very high resolution. It can be 6,000 pixel images. The image is of very high quality, and so this is very useful. Any other questions if you have?
Any experience of stump calculus, post polycystectomy, CBD, cystic duct stump calculus?
Yes, Dr. Sanjay Rajput is with me. So sir has done around 15 cases of cystic duct, 30
cases.
30 cases of cystic duct stump stones, and he's going to publish it soon.
Yeah, so we get once or twice in 1 or 2-3 months cases who have a cystic duct retention of stone.
And how many cases of post-transplant strictures? How many cases have you done up till now?
So depends upon, because normally we're successful in doing that, but for post-transplant I've done around in this year I've done 2
Please
cases.
focus camera on mobile, sir's mobile.
So this is a cystic duct stone.
Yeah. Very good. Very good.
And in fact, now from type 2 MIRZ, I think spyglass will be cholangioscopy and lithotripsy will be a treatment of choice for MIRZs too.
Sir, what is the length of this baby scope? I mean, the spyglass.
230 centimeter.
230
centimeter. Yeah.
So many
small
small bowel pathology also can be
10 French. This is 10 French diameter with a length of 240 centimeter.
214.
And the channel is 1.2 millimeter.
Yeah.
Yeah.
Outer diameter is 10 millimeter.
So can it be used for some small bowel pathology also?
No.
We have used this for many indications other than the spyscopy also. We have been using this for even dilating the stricture, which is not possible with normal scope. We can use at a baby scope. So
Yeah.
we have used it in through the PTBD. We can do the
Yeah.
lethal lithotripsy.
The company
there
has
are many more indications which we can use where our normal scope cannot go. You can use this as an endoscope also, but it is a costly affair. You have to be careful.
So it's basically made for cholangioscopy, but can be used for other things.
It will be less costly than surgery and PTVD interventions. So our endoscopic procedures.
Meanwhile, because all OT has been completed simultaneously, it is a window period of 10 minutes. So I am going to introduce my team. So till the time, just go for my PPT. We can see. So because you can see the performing doctors, but there are plenty of the other peoples who are. Can you see? Share my? Can I share my PPT? So there are plenty of the other people who are equally important. I think it is without their endoscopy room cannot exist. Okay, but what happens in most of the time? Okay, we used to forget that people. So this is our team who worked hard. Few of members are already there. Dr. Ram, Dr. Naresh are there. Dr. Tejas is in operation theater, and team is body is the best example of the teamwork. Body is the best example. Body is the best example of teamwork. So if you see, if everybody works synchronously, then and then it will be work is going on. Even any vital organ does not function, it lead to the illness. So these are all the people who have communicated to you, invited you, and constantly remains in touch of you during this last 1 month. So I thanks all these people. These are all the medical officers who have prepared all these slides, constantly in touch with the patients, and since last 1 month. And Dr. Praful is in OT, Dr. Smith is in OT 3, Dr. Rajesh is in OT, and Dr. Harshil. So I thank all of these people because they have worked very hard for this conference. These are anesthetists. We are missing Dr. Pankti because he has just joined, but Dr. Isha is there. Dr. Jigal Soni is there. Dr. Bhumika and Dr. Vanshika. Vanshika is not able to make it because of some family illness. These are our technician. And I heartily thank NIG as well as the UNS Clinic because their expert technician are also here to help me. These are our computer master, and I heartily thanks Majestic people because of this flawless transmission. I must say there is I don't have any headache when this transmission is going on. And this is our class 4 worker. This usually we miss them, but these are extremely important to maintain the cleanliness and hygienist of the endoscopy room. So together we did many things. This is the first time we did ESG in South Gujarat, and Dr. Yogesh was there to help me in 2019. The first workshop we have organized in 2019. It was the first workshop. Then that was the first workshop. Why it is moving? We did for the endoscopy and colonoscopy. We did the first GERDEX, EUS guided coil embolization, EUS guided variceal embolization, and we couldn't get any case of gastric varices embolization because that patient we need to treat immediately. So we can't hold that patient for the workshop. And this is our first EUS guided gastrojejunostomy. We did first time in the South Gujarat, but I did nothing. It is all, and I thanks all faculties because the workshop is going on. But many of them have flight to catch, so it may not be possible to thank them individually at the end of the workshop. I thanks all the sponsor. You see all the speedboat device, the Java people that was providing a stand, Boston people providing a spyglass, Apollo people providing the sutures to the patients. So all this surgery, if you cumulatively cost this surgery, it may be around 40 lakhs rupees. Okay, but it comes at nothing for the patient, and we should thank them for the generosity because most of the accessories are provided by them. And I especially thanks Dr. Sanjay Rajput and Dr. Yogesh Sarwani because he helped me too much during this workshop because they are the Sanjay Rajput sir is the master of this workshop, and I used to call him anytime when I I have stuck up. So see, they both people have helped me a lot. So now we are switching toward the OT3. In OT3, preparation is going on. Dr. Rajesh Puri is there in OT3. So OT3 on kar दें. Am I audible in OT3? Okay. Rajesh sir?
Yeah, you are audible.
Okay. So your case, you have already seen the CT as well as the images. This is a young guy who is suffering from pseudopancreatic cyst, a large cyst. And what is your plan right now, and why you are doing with this plan?
Yeah, very good question, Saumin. Have shown the CT images to the
No, we
audience
need-
or should we?
No,
Can
sir.
someone focus the camera on the CT image so we can?
No,
if
actually, sir,
possible-
that CT image is in your computer. We
Okay,
didn't get a
okay.
plate.
Acha, Saumin, I just want to know, is he alcoholic pancreatitis or is a gallbladder?
No, it's alcoholic pancreatitis, and he had a history of alcohol before 2 years.
Okay,
Okay.
okay.
Since 2 years, he
So,
is abstinent.
so to the audience, I would just like to say, whenever you are come across with a patient of walled off necrosis or pseudocyst, what important thing you are going to visualize before encountering an endoscopic therapy? First of all, you would like to see what is the underlying etiology. Are you dealing with the chronic pancreatitis with the fluid collection, or are you dealing with the acute pancreatitis with the fluid collection? Because if it is a chronic pancreatitis, majority of the time they are pseudocysts. And if it is because of acute pancreatitis, two important things. Are you dealing with the pseudocyst or are you dealing with the walled off necrosis? Because the treatment, quality of life, re-intervention, cost of treatment differ. 85% of the patient has acute interstitial pancreatitis and they develop the pseudocyst. 15% of the individual, they develop necrotizing pancreatitis, necrotic fluid collection, and walled off necrosis. This is the revised Atlanta classification 2012. So whenever you come across with the fluid collection, these two important things are very important to look at. This patient has possibility of an underlying chronic pancreatitis because I have seen the CT scan, pancreatic duct is dilated, but that may be fallacious. If you have CT scan, he has a huge collection around 20 centimeter in size. Entire pancreatic parenchyma is replaced by collection with a hyperdense content. So this is a walled off necrosis. This is not the pseudocyst. There is a controversy between the walled off necrosis, between the plastic and the metal, and I'm going to talk about that. But before that, it is very important. Is it the collection is only perigastric, that is in the lesser sac, or it has gone to the paracolic gutter, right or the left? That is going to decide about your plan of the treatment. If patient has a lesser sac collection with a paracolic extension, then you just put a large bore catheter in the paracolic gutter and the entire collection will be going to drain. If you both are separate, then you do this is endoscopically and you do this is percutaneously. And if there is only lesser sac collection, you do endoscopically. Now, which plastic stent or metal stent? We have a Dr. Wrinkle. She's from PGI Chandigarh and she has done a lot of work on the randomized study and she has published in the UEGW. She is going to enlighten what is the role of plastic stent and the metal stent. Till that, I am going to make the position of the patient. Will you tell something? Will somebody will give her the mic? And then I will say, Dr. Yogesh is my dear friend and he will tell his experience and I am going to tell my experience and Wrinkle is going to tell what the literature says. Can we make him in the same position?
Meanwhile, we will like to invite Dr. Naresh Mehta, Dr. Hiren Vaid, Dr. Dinesh Prasad and Dr. Hemant Modi to chair the session. And current chairpersons can continue sitting here. Thank you, sir. Please continue.
No, but take one call, fluoro without fluoro. I can do without both the things. You want?
So, hello everyone. Myself, Dr. Wrinkle. I have done my MD thesis regarding cystogastrostomy, especially for walled off necrosis with solid component of more than 20%. randomized control trial with plastic stent, minimum 2 plastic stent versus metal stent, either Nagi stent or a hot exhaust stent. So total we have 48 patients. So even with the higher solid component, plastic good works as good as the metal stent in the all sorts except for duration of procedure. So with the metal stent, endoscopists have a ease for the procedure. For the plastic stent, it's little difficult, multiple accessory exchange in the longer procedure time and little more skillful also. And regarding
What is his opinion about the plastic versus metal? We will need, need 19
We use
GUs.
mainly, am I audible? Yeah, we use mainly
Right,
plastic stents for those patients who
Francis,
have walled off
and
pancreatic
this is what it
necrosis, but very less
Begin
than 30% of necrosis. If patient is having only pseudosis, that is clear fluid, then we use plastic stents. And if patient has necrosis, in whom we are planning to do a pancreatic necrosectomy, in those patients we use a metal stent.
Pediatric upper G.
Yogesh, but Dr. Wrinkle, as far as I could understand from Dr. Wrinkle's narration, that they are happy to put plastic stents even if there is necrosis solid component more than 20%. So they don't find any difference between a metal stent and a
that's what-
plastic stent. That is what I could confer.
That's what I'm
Am I-
telling, that what we usually do is whenever the necrosis is less, that is less than 30%, we can use plastic stent. And if it is clear fluid, we use plastic stent. But when the necrosis amount is more and we are planning to do a pancreatic necrosectomy in near future, we always use a metal stent, because the diameter of metal stent is 18 to 20 mm. We can take the scope
Agreed,
easily
agreed.
inside the cavity and do a necrosectomy.
Yes, agreed. That agreed. But what I may be wrong, but she told that their study showed that even if the necrosis solid component is more than 20%, even if it is more than 20%, they are happy to put plastic stents. That is what I understood.
Let me just clarify, and I will say Wrinkle to also to give the comment about her. So in the literature, there is a diversity of the opinion. The less than 10% necrosis plastic is okay, 10 to 30% or 40% plastic versus metal, and more than 40% is a metal. What I personally feel what is important is why this concept has come. When you put a metal stent, you raise the diameter by 16 millimeter or 20 millimeter. You put a plastic stent, within 2 days, the opening which you have created is again going to close, and the patient comes with the closed with the stent. If blocked, patient comes with the sepsis. So you require a repeated dilatation. So most important advantage of metal stent, number one, ease of putting the stent, number one, decreasing the number of step, number two. Number third, if you can go, you can do the direct necrosectomy or the follow-up necrosectomy without dilatation. You don't require to remove the plastic stent. These are the advantages. Yes. But when we talk about the literature, what they say is that the complications and the death and the outcomes are not different, but these parameters always play a role. What is the take home is, and the second concept about the metal stent, if you look at the literature, the people have shown the bleed. And if the metal stent is kept for more than 3 weeks, then the chances of the bleeds are more. So these are the two disadvantages. But in the real life scenario, if you come across with the necrosis of more than 20% or 30%, it is better to put the metal stent, and that is better. What is your opinion? Yeah, outcome is not different, but your ease, the length of the procedure, recurrent requirement of the necrosectomies, those things you are going to minimize.
Yes, sir. Every time we don't need to dilate. Sometimes with dilation, you may have a bleed. In the plastic stent, in a metal stent, the bleed will be under control, especially after dilatation. And the second thing, sometime in the metal stent, we found a large chunks of the necrosome, which is blocking the metal stent, and you are requiring then, which is not there in the plastic stent.
Okay, now the very important thing is, if you look at the CT scan report, what has shown that the splenic artery and the hepatic artery is going on the wall and inside the cyst. So sometimes the patient may bleed on the table, or they may bleed after some time. And the culprit is either the inexperienced endosonologist, or it is because of the metal stent. So if you look at carefully, it is still not clear. The patient who bleed, it is because of the ongoing inflammation in the gut wall. It is ongoing necrosis which is going to cause the bleed, or it is the stent which is going to cause the bleed. During procedure, the bleeding is mainly because of the cyst wall, which is when you dilate it, and there is a possibility these are going to bleed these patients. So I'm using the Pentax scope after a long time. I have used this scope around 15 years before. I want this should be go on the right side.
Opposite side. Yagnesh, where is Yagnesh?
So this is a fantastic scope, no doubt about it. And with some of the difficulties, now I'm going to talk about the few technical tips while doing. Patient is in the supine position. Generally, I do my procedure in the prone position. But as patient is intubated, the best position is the supine position. That's very important. Why there is a need to intubate? I do my all procedure without intubation. But in this case, I want to intubate because the 20 centimeter large collection risk of aspiration is there. So it is very important that you should intubate these patients.
Sir, in pseudocyst, actually recommendation is irrespective of size.
Yeah, I agree. I totally agree, Dr. Yogesh. I totally agree with you that irrespective of the size, you should always.
So we are not getting the endoscopic view.
Endoscopic view, please.
EUS view is there. Endoscopic view is not there.
So, sir, there are many gastroenterologists who still practice endoscopic drainage of the cyst. So, what is your take on this, and what do you feel? Should we still in era of EUS drain by endoscopic direct puncture, or we should always?
Can someone give us endoscopic view?
What is this? We are in the heart.
We have no endoscopic view at all.
और नीचे जाना पड़ेगा.
So what is the question? Yeah, so very good
yes.
question. I think doing the endoscopic drainage in 2022 is a crime. You should not do endoscopic drainage even if there is a bulge, because the reason is that you are not very sure that what is between the gut wall and the cyst. So all procedure to be done. Is the CO2 or the oxygen is on?
CO2.
I don't see the inflation. So you should do all procedure under with the EUS, and it's not because I'm doing. This is the world over the literature speaks.
Can someone give us endoscopic view? We can't see your endoscopic view from auditorium.
We are trying. Just wait for 1 or 2 minutes.
No, nothing. Is the oxygen is on?
But to be practically, while doing the EUS, your principle is to keep suction on. Okay. So endoscopic view, usually we don't require. We require a EUS, and in certain cases, we required fluoro, CM, because mucosa is completely opposed towards the scope. So you don't see anything apart from the pinkish mucosa. No lumen, nothing. And that is the true EUS. EUS always been done by everything has to be shocked. You see, this is the endoscopic view.
But can you see? Can you see it's coming? Nothing is inflating. So just give me a minute because I think there is Can we check the air or the CO2 is coming?
Till the time we are
yeah, Saumin, you can shift
switching towards the OT1.
Yes.
Remove karo.
Can we switch towards the
We can
OT1?
remove the scope. Remove the scope and check it. That will be easier.
मेरे बताऊं क्या लग रहा है? Cyst इतना बड़ा है ना? आ रहा है? So it is a problem is no, could be because the cyst is so big.
So till the time, sir, look at the cyst and puncture it. We are going for the live in OT1. Here is Dr. Radhika Chauhan from ANS Clinic, Ahmedabad. Ma'am, am I audible?
Yeah.
Okay, so she is going to perform a spiral endoscopy. Madam, please introduce the device first
Okay.
This is the new scope, I think, which is the most useful tool right now for evaluation of the small bowel. And along with her, Dr. Sanjay Rajput is there, who has the only in private setup where have a spiral endoscopy is available in Gujarat. So please tell me about the equipment and basic principle of this procedure, sir.
Okay. Good morning, everyone. This is 33-year-old female diagnosed to have Crohn's disease, and she is presented with abdominal pain, and on CT some strictures are there in ileum. So this is a spiral endoscope. This is called power spiral endoscope, and it is 168 centimeter long. It has integrated motor within it, and it has a spiral overhead tube. Okay, so you can see this spiral overhead tube. It has spiral fins over it. When I rotate this spiral in a clockwise manner, it propels the spiral endoscope into the small intestine. So we have to check whether it is functioning or not before introducing scope into the patient. So by forward rotation, it is rotating in a clockwise direction. And if I press it and give a resistance, you can see on a screen. Can you show the screen, please? Okay. So on the screen in PIP, you can see max on both sides. I'm doing a forward rotation. So you can see it is showing forward rotation like that in a PIP image. If I give some resistance, the rotation will stop. So this is the indicator that you need to stop there, and you have to use other maneuver like abdominal compression, water irrigation, and you should not push your scope further, because if you do that, there is chances of a complication like a perforation can occur. So this is the maximum limit of a forward rotation, and it will stop there. Same wise, if you press a foot paddle in a backward direction, so this we do while withdrawal, and it rotates in in an anti-clockwise direction. You can see that on display, it is showing backward direction, and you can see the green bar. So a green bar will show the speed of a spiral fins. So if I press little, it will show that it is the speed is less, and if I press more, you can see the speed has increased. So, and if I press, it stops. So likewise, in a forward, in a backward also, that your scope is angulated, and it is experiencing maximum resistance. At that time, you use manuals and try to withdraw it slowly. So before introducing,
it has a special mouth gag coming with this, bigger mouth gag than the normal one, and patient requires the nasal intubation.
Okay.
And some people use dilators for beforehand, just because we are using the large fins. Person may require a larger diameter of the esophagus dilatation than the routine one, that is around 18 millimeters.
the outer diameter of the scope is 11.3 mm at the tip and 12.8 at the shaft. The diameter of spiral overhead tube at the tip is 18, but with fins, you can see these soft fins, it increases to 31 mm. So this tube is 24 centimeter long. There is a rotation coupler here where you can attach spiral tube. So I'm going to introduce this scope into the patient.
Dr. Rajput sir. Hello.
Hello. Yes, sir.
Dr. Vispin Joshipura. Dr. Rajput sir.
Bolo.
Have you come across any trouble with the tobacco chewing people of Gujarat?
Yes.
For introduction of the scope?
We don't do if patient's mouth is not opening at all. So we will send them these patients for their laser fibrous decortication of the pharynx. They will come up with the opening of the mouth, which allows us to go in. Then only we will do this procedure, because તંબાકુ ખાઈને લોકોનું મોઢું નાનું થઈ જાય છે. મોઢું ખુલતું જ નહીં, બે આંગળી બી નહીં ખુલતું. So it is always better to do beforehand and take the help of an ENT person.
Right,
So
sir.
because of dilatation, some
Sometimes it is
trauma
very
is there.
difficult to go
And
inside when the esophagus has some pathology. So
Okay.
here we are.
So
looking
now my forward rotation is going to match. So at this time, I will ask anesthetist to deflate the endotracheal cuff balloon.
suction lage, બીજું suction lage.
Okay.
પેલું suction પાછળથી જઈને બેટા ટેબલ ઊંચું કરો.
Okay. थोड़ा extend करो ने. Okay.
Neck extend करो. You have to do a extension of the neck while putting in, and sometimes it is very difficult while introducing to the upper esophageal sphincter only. So you should never force your scope. You can abandon the procedure anytime.
Some
But do not
fibrosis is
complicate.
there
Yeah.
in esophagus. That's why because of dilatation, after dilatation, you can see some bleeding. So with a gentle torque and little
We
force,
can
I'm
expect
going
some.
forward.
We can
Yeah.
expect some Crohn's activity in esophagus also.
Yeah, true. मेरा एक gloves निकालना.
Sir, till you are going to the duodenum and further, we are switching towards the OT3, where
Okay.
Puri sir is ready to locate the cyst and the site of the puncture.
Sure,
Please
till that
switch to-
time we are trying to negotiate the esophagus first.
Switch towards the OT3.
Please come. Yeah, make it or make it small.
Very
Are we
small.
audible?
Yes, you are audible. Please enlarge the endosome view, this view.
Yeah, so the two things,
Thank you.
sir, I have focused, and the important point of focus is number one, your scope should be in the straight position. If you can see my fluoroscopy image, it should not be deep into the pyloric antrum, because for necrosectomy, when you are going with an upper GI scope, you require your scope should be in the straight position. Number second, you should choose the point which is avascular. We have put a Doppler, there is no Doppler signals. Will you remove the Doppler? So there is no Doppler signals. And if you see the necrosis, can you see the significant necrosis is seen in the cursor is this? Can you see the necrotic material here?
We have lost the vision, I think. Can someone show us the EUS view?
Just a moment.
We are not able
You can show stop endoscopic view. Yes, now we can see. But can I think
क्या हुआ?
EUS view, EUS view.
We need EUS
the
view.
sonography view.
Is the EUS view visible?
No, we can see just thorough view now. Can someone show EUS view in the main screen? Ultrasound view.
Now you can see.
No, I think
No,
once
no,
they focus.
okay, no problem.
Okay, now we can see.
Okay.
Just
You
focus
focus
a
here.
little bit.
ठीक करो ना, पानी लगा के कुत्ते का बाहर निकले।
So you are live.
Now the EUS view visible?
EUS view is visible, but it is actually the picture of the monitor. Now EUS view is visible.
Now visible.
Okay.
Okay, now what I'm going to do, I will puncture with the 19G needle after applying the Doppler. I've already applied the Doppler, and I'm going to puncture with the 19G needle. And this is the needle. Can you see it here? And my needle is in. Okay. Then I will tell my assistant just to remove the stylet. Will somebody show his, will suck the fluid? Ensure that you are inside the cavity. Can you see the fluid? Can somebody focus on this? Can somebody focus here on
External
the
camera focus on the fluid
Do
and
you
aspiration
recommend
process.
that send this fluid for analysis?
Yeah,
Biochemical
we
analysis?
always send for the amylase as well as for the culture and sensitivity, because you may come across with the infected. So can you see here is a dirty necrotic pancreatic fluid?
Yes, now we can see.
Okay. Now I'm going to tell him to put the guide wire. You are putting the JAG guide wire? Is a JAG guide wire?
Yes.
What is your name? Kamal is assisting me. And you can see actually you can do this procedure without fluoroscopy also. But it's better for the chances of the complications are less. But if required, you can do without fluoro. So can somebody show the fluoroscopy, please?
Any
You see the
particular
guide wire has come. Now I will tell him to make at least 2 to 3 rounds. So he has already made 2 to 3 rounds. And can you see the entire, can you see such a big round? Now what I'm going to do, just wait.
Yes.
I will remove the just wait needle. Now I will unlock it and he's going to exchange as we are doing with the ERCP.
Any
And
particular reason, sir, you are using jag wire, not VisiGlide wire, sir?
no, you can use VisiGlide. Sometimes the people have seen that with the VisiGlide, when you use the cystotome, you may not be able to puncture the wall. But in my practice, I use either a VisiGlide or the jag wire, both. Now I have changed. Now what I'm going to do, I'm going to dilate the tract with the 6 French cystotome.
Sir, we are temporarily switching towards the OT2, where we just want to show the normal endoscopy post-sleeve gastrectomy status.
Please.
So
please.
then we can load the equipment.
Yeah.
Switch to OT2. Okay, we are online. Rakesh sir,
Okay.
you are live.
Okay, right. So, as the audience is predominantly surgeons, so this is a very interesting case of post-lap sleeve gastrectomy. She had a BMI of around 36, 37 pre-surgery, and it came down to 29 around. But unfortunately, she has put on weight because she's having a binge eating habits. So what I'm going to demonstrate now is post-lap sleeve gastrectomy weight regain patients. What we can do endoscopically in a daycare setting under propofol anesthesia, conscious sedation. So the patient is in left lateral position. I'm going to show you the anatomy, what has been done post-surgery and how it looks like. If you can see the endoscopy screen, so this is the pyloric opening. And as I'm coming up, you can see a small residual stomach, the pouch which got enlarged, and surgeons can appreciate better than me in the audience. You see the staple lining in between, and also on the either side. This is a small stomach, and as I come up, you see the GE junction. So there is a expansion of the stomach over a period of time because of the binge eating habits of the patient. So now what I'm going to demonstrate is an endoscopic sleeve gastroplasty in this patient, what we call as pouchoplasty, where we reduce the pouch by at least 60 to 70% of the volume, so that there will be around 10 to 15% weight loss again in this patient who had a weight regain. So for this, unlike what Dr. Kalpit has showed in his routine ESG, you need a marker because you cannot afford to put your suture on the staple line because it's fibrosed. So what I'm going to do is I've just taken a simple upper GI scope, and I'm going to take a APC catheter and then put a lining around, sparing the suture line, the staple line, so that I'll have a roadmap of what I'm doing. So let me get the APC catheter out. You can show them the endoscopy view.
What is her current BMI, sir?
She is now around 33 back. She was 36, I believe. She's now 33 around. So as you see here, I'll take the scope. Can I have the pad? Oh, okay.
Right there.
Okay. So now what I'm going to do is you have the staple line here. So I'll spare that staple line and then make a rough APC. 1 second. Let me do on the anterior wall.
So for the audience, this is the staple line which he's talking about.
Yeah.
He's just going to mark above it and on the other side so that he knows where he's putting his suture.
So in fact, in the routine APC also, people do these markings, especially when they're beginners. So this will give a rough approach of sparing the suture line and then doing the staple line and then doing the sutures.
Does she has any reflux symptoms, sir?
She has, definitely she has.
So
in fact, I think if I'm not wrong, Saumin also tried on the semaglutide for her, but she again haven't had much of weight loss.
No.
In fact,
I'm talking about reflux symptoms. Reflux.
She has reflux symptoms, not very bad, but she's managing. In fact, the mere reason of having her weight regain is she must be having symptoms, but that not very bad, or else she would not have eaten this much. So what I'm doing is I'm marking. 1 second.
During diagnostic endoscopy, could you retroflex in the?
I'll do it right away. I did.
Okay. Hmm.
Yeah, that's one very important point. Again, very common point, because if you can retroflex, obviously you are sure that the pouch has expanded, apart from the weight regain what she has.
And the
Okay.
concern for worsening of acid reflux after revision should be much lower, just because you are leaving the pouch in the fundus,
Yeah.
which
So,
can act as a reservoir for your acid.
so you can see I could retroflex and it actually looks like a normal stomach. See, the unfortunate part in the human body about the stomach is like a balloon. So whatever you do in these bariatric procedures, it can be a surgical or endoscopic, the expansion will be more, and unless and until you have a good eating habit control. So anyway, what I'm going to do is I'll just suck it out. I have got a roadmap, and now I'll take out the scope and introduce a double channel scope to start the suturing.
So till the time you, sir, start the suturing, we are switching towards the OT3.
Yeah, sounds
where
good.
Puri sir is ready with the punctured and going to put a stent.
Okay.
So now, after puncturing with the needle, I have exchanged the wire you have seen. I have taken the
Please
6
enlarge
French.
the ultrasound view.
Yeah, we have taken the 6 French cystotome. Can somebody show the fluoroscopy? Yeah, so I am now using the endocut Q and I'm puncturing with the.
We lost the endosono view. Please, yeah, and yeah, nice. Sir का view चला गया.
No. So the wall may be thick. I am not able to puncture. Yeah, I have gone in. Can you see on the fluoroscopy I have gone in?
Yes. Yes, sir.
Is my fluoro visible?
Yes. Yes, sir.
Yeah, so I have punctured with the 6 French cystotome. Now the next step is I'm going to exchange. I'm going to dilate with the 6 millimeter or the 8 millimeter hurricane balloon. So hurricane balloon should be ready. Can somebody show the fluoro? So I'm doing the rapid exchange. Yeah, do it. We have a lot of wire inside. You please do it. So a good technician and the doctor coordination is important, because while exchanging the accessories, like he's telling do it slow, I'm doing fast. If this coordination happens, then you may lose the accessories. But I'm seeing the fluoro and I'm doing the rapid exchange, so I can remove it. Fluoro. Yeah, little bit do more. Yeah, little bit more. Yes. So the next step is dilatation with the hurricane balloon.
If we use a 10 French cystotome, can
Yeah.
we directly go with the stent rather than
Yeah, it's a very good
introduce-
question. Yeah, it's very good question. But actually 10 French cystotome is very firm device, and it has a 6 French long plastic device. Then the chances of the perforation is there, number one. Number second, that is a costly instrument, and if it damaged, then you are going to lose around 60 to 70,000 rupees. So the 6 French cystotome I have done. Now I'm using the hurricane balloon. One important point while using the accessory, if my endosono view is visible, you always should be able to see the guide wire. This is important. Second thing is, it is by the side. So what I'm going to do, I'm going to hold the wire with my left hand. So wire should not displace. Now I'm going in and I've taken the 8 French hurricane balloon.
8 French.
Okay. So how to ensure that you have not gone deep? Now it is showing some resistance. I will release the elevator, and can you see the EUS wise? This has gone in. Just give me a second. Yeah, can you show the fluoro, please? Yeah, can you see it has gone in?
Yes, sir.
Now I will tell him to inflate a little bit first. So I ensure that my one side is inside the pseudocyst or walled off necrosis and one is in the lumen. Yeah, inflate. Are you using the dye contrast? Yeah.
No, you're
No
not
contrast?
using it. No.
Can you see the balloon here in the EUS view? Can you
Yes, we
visualize
can
the
see.
balloon?
Yes, we can see.
Two thin white line is balloon, and
Yeah.
in between third
So-
line is a shaft of that balloon.
So this is the balloon. Can you see here?
Yes, we
This is
can
the
see.
balloon. So what is important is I will withdraw a millimeter more, deflate.
Can
A
you
little
highlight,
bit.
sir, why did you ask for contrast?
Yeah, because I can see under fluoroscopy. Yeah, inflate. Inflate again. Yeah, inflate. Completely inflate. So this dilatation is mandatory. We need to inflate. Don't deflate. Please inflate again once to show. And I'm going to enlarge the image. Yes, inflate. Can you see the balloon now?
Yes, sir. We can see the balloon.
Can you see it?
Yes, sir.
Now the two things are important. Actually, this will depend where are you doing. I would like to see the balloon in the USV also. Can you show the endoscopic image nicely?
So till the time we are switching toward the OT2, where Dr. Rakesh is going to take the first
Deflate.
stitch in revised ESG.
Inflate again. Inflate again.
Okay. We are on. Okay. So as you see here, as I told you, the APC markings are important because unlike the normal anatomy, this is a small stomach with a staple lining in between. So you need only two sutures, unlike what Kalpit has shown in the routine ESG. So you do one on the anterior wall, one on the posterior wall, and in between the greater curvature, you can leave it off. So I'll just start here as you see. So I'll take the first mark here. Yeah. Okay. Helix out. Rotate. 1, 2, 3, 4. Okay. So now I take the bite. You can show them my hand movements. Putting the helix in. Okay. Yeah. Helix out again. So I've taken the first bite, as you see. So now I'll reload the suture and then take the second bite on the other extreme wall. So as you can see here, I'm not taking the second bite near to that. Okay. Yeah. Yes. Yes. 2, 3, 4. Perfect. Take it. Now, so I have taken on the posterior wall. I'll go one step down on the posterior wall again and then take it there itself. You see already the pouch is getting concised in size and you will
Sir,
appreciate it.
temporary for 5 minutes, we are switching towards the OT3 where Dr.
Perfect,
Puri is
perfect.
going to deflate
Yeah,
balloon.
yeah,
So
no
what
problem.
entire cyst will be collapsed after that.
Yes,
So
yes.
vision will be difficult.
Please,
So
please.
switching towards the OT3.
Can you see the endosono? This is the gastric wall. This is in the gastric lumen, and this is inside the cyst. And this is a compression of the gastric wall on the balloon. So what I'm going to tell him to deflate, and I'm going to put the metal stent, and that will be the complete procedure. So can I remove now, or you are going to suck it? So can somebody
Sir,
show the
after
fluoro?
deploying a stand, just tell about the stand something outside. What
Yeah,
is
I will
the-
tell.
Okay.
Dr. Saumin, what I've decided is what I'm going to do is I'm taking the upper GI scope and I will show them the direct necrosectomy, or I'm going to show them the inside the cavity. This is the plan.
Yes, definitely, sir. Definitely.
Okay. So I think another 2 minutes and we are going to be through with this room. So now I'm just planning to put the metal stand, and then for 5 minutes you can shift to other room. So just give us 5 minutes.
Dr.
Please.
Puri, sir.
Yeah.
Dr. Puri, sir.
Yeah,
Can you
please.
can you share some of your experience regarding some certain surprises you come across while doing all such procedures?
Yeah,
such
very
as
good
bleeding,
question. Very good question.
mucus or something?
Yeah, very good question. Number one, surprises, because many of the time people quote that you do an endosono and look for the pseudoaneurysm. The cyst size is so big, you cannot see the entire wall, you cannot visualize.
Yes,
Number
sir.
second, sometimes people puncture the cystic neoplasm as a pseudocyst.
Yes,
And
sir.
number
Yes, sir.
third, which is a very unique problem, what I was doing around 5-6 years before, as I dilate the cyst was not adherent to the gut wall. And what happened was it separate and started collapsing in the peritoneum.
Right, sir.
I still has that video and the image which I'm going to show, the double neck sign, because I put the metal stent. So one was impinged by the cyst wall, and there's a long gap in between where it is inflated, and then there is a gastric wall. So this is important. Your procedure should be quick. You should visualize everything before doing the procedure, that your cyst and the gut wall is in contact. So now you see that my metal stent is going in. Can you observe my metal
sir.
stent? Can you show the fluoroscopy, please? Yeah.
Dr. Rajesh, do you plan to do a necrosectomy in this patient straight away, or?
Yeah, so I'm just going to tell you the two important things. Very good question, Dr. Jahir, you have asked. The indication of direct necrosectomy is if the patient is infected, otherwise not. The reason of showing them is just to show them because they must be seeing these kind of procedure not frequently. But literature-wise, indication of direct necrosectomy is patient is infected, otherwise you don't require.
Sir, I think it is better to go after 2 days rather than doing it today.
Okay, as you will say.
Yeah, because unnecessary we will go in and we will introduce some infection rather than making it more easy.
So theoretically,
Better to
Dr. Rajput, once you have opened the cavity, the infection will already going to go in.
No,
Your
but
scope is not going to
why
introduce
do
more.
we release first? Because patient is not septic.
Okay, then we can wait.
It
It
is
was
better that
purely
we
to
just put
demonstrate
the stent, allow the stent to settle down, because sometimes the stent also migrate during the procedure and it may come out.
Yeah, that will require an expertise to know. Now, he's delivering the stent. Will you deliver? Can you show the fluoro will be bigger? Yeah. Now, how to see that? Can you visualize? He has opened up. Can you see the EUS view of the stent?
Yes, sir. Yes, sir. We can see.
Don't release. Now, what I have done, I have taken out the stent up to the cyst wall.
Yes.
Have
sir.
you observed this?
Yes, sir. We can see. Very well see.
Very important thing, as we don't have a 6 millimeter hurricane, we dilate with the 8. Many of the time, pulling more, your inner flange can come out. So
Yes,
what
sir.
I'm going to do is, I'm releasing the stent inside the scope.
Okay.
If there's a lot of fluid, you are not able to see the gut lumen, it is always better to release inside the scope. And the proximal site I'm going to examine with the EUS view. So what I'm going to tell my colleague, aapka naam kya hai? Kamal, to release inside the scope slowly. You just watch EUS image. Yeah, release slowly, slowly. I'm giving the traction inside, release, 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 release. Yes, release. Once you're done, you tell me. Done. He has released now.
Wow.
Now, the one side of the stent is inside the scope channel. One side is inside the cyst cavity. What I'm going to do now, I will remove the EUS image to the endoscopic image. I will make it the big knob away. I'm trying to going to see endoscopically like this. And
you will deploy.
The amount of the gush of the.
Can you see the stent?
Yes. Yes, sir. We can see.
What I'm going to do, I'm pushing the stent and pulling my scope.
It will deploy the stent. Right.
Okay. This is the way you should do it. And I have done it. Okay. So this is the deployment of the stent. So this is by the Java company. This is made with the concept of Make in India concept. This is inside the cyst. Can you see it very well?
Yes.
Okay. So this is going to some time to take open. Yeah, you remove the
So one
stent.
question, sir, it is very well
Yeah.
deployed, but we have few stents available which just a single shot and you can finish the procedure.
Yeah, that
in
is a
5
hot
minutes.
exhaust. I absolutely
So why
agree.
chosen this procedure, conventional method rather than hot exhaust? Because that will be more easy. This is
Yeah,
done
so
almost
very
takes
good
half an
question.
hour.
Very good question, Dr. Harwani. There is a hot exhaust stent, which only one step going to take 3 minutes to complete the procedure, because you don't require puncture, you don't require this is dilatation. you don't require any procedure. Just it will act as a single step, and 2 minutes your procedure is over. The only thing is that is little bit costly, costs around 1.5 lakhs rupees.
Can you show us the good stent image so we can switch towards the OT?
Yes, I'm going to show you because there's a lot of fluid. Can we take the upper GI scope if the
Yes, definitely.
if the can you show the fluoro, please? Bigger fluoro.
Stent deployment fluoro.
And I'm going to show the EUS image also. I'm sucking the fluid. And it is important you should keep your wire in till you are sure that everything is going fine. If you require, then you can re-intervene. My plan was to dilate and go in, but I will respect Dr. Rajput has said that. But you can do the direct necrosectomy now. It's not a problem.
You can see, the audience can see the CM view enlarged, and you can see the flanges of the stent. So just that is the fluorographic position of the stent, which is a very short stent. We require a little bit of expertise.
So now the fluid is coming up with the gush. You will be able to see the endoscopic image of the stent also very well.
If you can see the fluoro image, this is the neck of the stent. Both side stents has been equally deployed, which indicates good patency also. And both sides, it is equally open.
Dr. Puri sir, what other handicap you feel which can be rectified further by the technology? What would you like to demand from the manufacturer to change in some design, material, something? What do you like?
The hot exhaust is the best.
No, actually, sir, Dr. Viswit Bhai, this is not a lumen opposing stent, but some lumen opposing stents are also available, which have very low risk of migration. Okay. So ideally in pseudocyst or when we do a GJ, we should put a lumen opposing stent so that risk of migration is also less. And what happens that the edges of this stent lumen opposing are inverted. So what happens even after 3 weeks, when the cyst collapses, there is very minimal chances of bleed.
Right. So
what is the opinion of house to show the necrotic cavity inside from the upper GI scope or not?
I think the waist is still narrow. That is what I felt. Huh?
Yeah, we have already dilated. The diagnostic upper GI is going to go in. That is not a problem.
Okay, then we can show that.
Yeah, so you take it to the other room. Give me 2 minutes. We are changing the scope and then we are going to show.
Sure, sir.
Meanwhile, you can take it to the other room.
Where is our spiral scope? Can we show the spiral scope?
Sir, in spiral scope, in the first patient, there is a significant esophageal fibrosis. So we have switched the patient and we have switched the another patient. So that is preparing God, but till the time you can see the revised sleeve. Another option in that patient, you can go via colonoscopy and you can go enter via the cecum. But cecum is also strictured, ICL is also strictured. So we plan to change the patient for demonstration purpose, and we will redo that patient after the workshop is over because it is taking time around 2 hours. So we don't have much time. Please switch towards the OT2.
Sure. Thank you.
Okay. Rakesh sir, you are live.
Okay. So what I did is I did the first suture and I'm doing the second, a little bit of bloody field, but I'll try to clear it. Let me cinch and then show you what has been done. Probably I might need one more suture to finish, or I can stop also, but okay. Let's cinch. You did? Okay. So my anesthesia team here is doing a fantastic job. I actually forced them to do a obese patient, a left lateral anesthesia, conscious sedation. And they are cursing me and also struggling. But again, yeah. Can you just give me the helix, please? Or the anchor exchange? 1 second. No. I wanted the helix.
Just Sadhu, I
just have to push it down. Okay. So this is the second suture which has been deployed. I'll push in. I want some water, 50 cc syringe.
Water.
Okay. Yeah, can you flush?
So the pouch has already gone down by almost 50%. Now he probably will put one
can do
more
in that.
suture.
Yeah.
And that will shrink it further more to maybe 60 to 70%.
Yeah.
That should definitely help with at least 15% of weight loss for this patient if she obeys her diet restriction, and maybe 20% of exercise supplemented with the diet will also help her.
Yeah, I think so. I also recommend this patient to be definitely on the GLP-1 analog, either oral semaglutide or injectable, whatever she prefers. Because when she has a binge eating habit, as you see here, I can show you a glimpse of what has been done. So you see half of the stomach is nicely stitched and this part is left. So I definitely want one more suture so that I can compromise the volume to the max. This is already the GE junction. And you can see my APC markers still left behind this way. So if you can cover this part, then it will be more useful for us from the point of weight loss. But definitely, Saumin, you have to make a point that we need, GLP-1 analog as a support for this patient, which is very essential.
Our audience demand spiral scope is ready and is inside the stomach.
Okay.
Please
so,
switch
Hello,
towards
one more question for this. How much is the cost for the total procedure?
for which procedure?
Entire procedure.
For this
Stapling,
revisions gastroplasty.
It is a relatively cheap.
No, I'll say you it's very cost effective because you need one suture, one cinch in a patient and maximum of 3 sutures, 3 cinches. So if you see categorically the cost, it will be around 1 lakh or 1.2 lakhs max. So that's what, and in fact, in a patient who has got a surgery, post-surgery, again, a redo is definitely difficult. And this is an OPD-based procedure, which patients can get it done within 4 or 5 hours, they can walk out.
And if it is only one suture, we can do around 50,000-60,000 also.
Yeah, 1 or 2 sutures.
Please switch towards the OT1.
Okay, I class glimpse once I am done. You can go back.
Dr. Rakesh, sir. Hello.
Sir will be available after a few minutes because this is an important step in the spiral. You just see once patient one scope enters from the stomach toward the duodenum to the small bowel. So you can see the beauty of this device. Okay, how easily and how deep we can see.
Okay, welcome back again. Because of severe mucosal fibrosis in a previous patient, we have to abandon that procedure. So this is a 60-year-old male and he is having a thickening in jejunum and ileum, suspected to be neoplastic as it is enhancing on arterial phase. So it was suspected to have a neuroendocrine tumor. So in this patient, we have intubated. You can see G junction there, and I am now pressing a forward pedal. So you will see the direction of clockwise rotation on display. So I have entered the stomach very smoothly. And now I'm going towards the pylorus. So in this, the beauty of the scope is you don't have to push the scope. So with a spiral clockwise rotation, it will force intestine and do a pleating of intestine on a spiral fins. And advantage is a very short time is required to reach the diagnosis or to reach cecum. The pan enteroscopy rate is very higher with a spiral scope, almost 10 to 15%. In Mohan Ramchandani case series, it was a 60%. With antigrade, it was a 30%, and in bidirection, that is with antigrade and retrograde, it was a 30%. So total 60% patient had a complete diagnosis and pan enteroscopy was possible. So now I am crossing a pylorus. You can see a duodenal bulb here. Some erosions are there, but I feel they are non-specific. And now I'm crossing a duodenal bulb, entering into the D2. You can see the rotation on display that spiral fins are rotating. And I'm just holding my scope, not pushing that much. Here, sometimes what happens, the spiral fins, the diameter is almost goes up to 31 mm. So it sometimes at pylorus it may get stuck. So there you may require a little force to push it forward. And another problem is DJ flexure. So now I'm entering into D3. Now you can see. And you don't require assistant that you require in a balloon enteroscopy. Only water irrigation. Another advantage of this scope is working diameter is 3.2 mm. And while other endoscope like single balloon, double balloon, it is 2.8. So the advantage is you can use the colonoscope accessory in this patient. You don't require a special accessory. Here my scope is angulated because I am trying to cross a DJ flexure and my rotation, they are reaching up to the maximum. So we have started water irrigation here, you can see. And slowly, it is progressing.
Do you need any special preparation for the patients?
For antegrade, we don't require, but for retrograde enteroscopy, definitely we require a preparation like the one we use for a colonoscopy.
But usually we give preparation for all patients because sometimes it is difficult to do only antegrade and you have to do pan enteroscopy from below. So it is better to give preparation to all patients.
So can you?
That shows the experience.
So we are changing the patient position because I am experiencing some resistance here. So there are 3 maneuvers you can do during a spiral enteroscopy. Change the patient position, do abdominal compression and decompression, that is abdominal massage, and use the water irrigation.
You are inflating this with carbon dioxide, I suppose, right?
Yeah.
And what is the pressure capped inside? What is the pressure cap for the insufflation?
Minimum.
Minimum.
Okay. Okay. I think now I'm crossing a DJ. That's why I am experiencing some resistance here. You can see on display, my spiral fins have stopped rotating. Okay, even I am pressing a foot pedal because scope is angulated at this moment. So sir has started giving a massage and slowly, let's see if I am able to cross. Okay.
You are at DJ flexion now or?
Yeah.
DJ flexion.
How does this massage help? How does this massage help to progression of endoscope?
So this massage causes, it gives the compression and decompression. So it helps in a pleating of the small bowel and helps in pulling the small bowel on a spiral enteroscope. The spiral enteroscope is called self-propelling enteroscopy. In a balloon, we push, but in spiral, we pull the intestine on a spiral fins. So it helps in pulling the intestine on a fins.
Can you just start the fluoro view, ma'am? So they can see how deep it is inserted. Until the time Dr. Puri wants to show something,
Okay.
we are switching towards the OT3.
Diameter, water irrigation, water.
Please show how this assistant is giving massage.
Okay. Dr. Puri sir, we are with you.
Yes, so very good thing, which I think this is a lesson. Because I've used the 3 centimeter size stent and the part of the stent is outside. So you see the flanges are on this side. At this moment, if you want to go in with the scope, there is a high possibility that you might dislodge the scope. I have taken the diagnostic scope. Now I'm taking the pediatric scope to go in. And what I'm going to do, I'm trying to do in the retroflexion. If with the diagnostic scope, I have gone in, but it was like a hockey stick. So it is very important as that if you go in and you are going to remove the stent, that will be detrimental. So you should be very careful while going in. So I've used the thin scope. You see the part of the stent is outside. Can you see? So this is the issue with the 3 centimeter stent. If I would have used the 2 centimeter stent, then my job would be a much easier. Now going in will be a difficult, but give me a moment. I will try to go. The diagnostic scope was much study, so it is easier to go with this. Let me just see that will I able to go or not, because
what we can do, sir, till the time you are negotiating to the stand, we are switching towards the OT2 where revised ESG has been completed. So once you are inside the cavity, just tell us, we will switch again. Please switch towards the OT2.
Good. So as you see now on the screen, okay. So as you see now on the screen, endoscopy screen, so this part, so you see the new lumen is narrowed, the pouch has reduced in size, and what we call it as a pouchoplasty. So this is the GE junction, right? You go down and then you see a little bit of cavity left here. I don't want to really do a complete luminal compromise, but at least 60 to 70% of the pouch is reduced in size. And this is good enough for her to have a good fullness post meal. And of course, as we discussed, she definitely merits having a GLP-1 analog as a supplement. And I'm sure this patient will lose around 10 to 15% of the regained weight in the due course.
And how many sutures you have taken, sir?
I have taken 3.
3 sutures.
3 sutures.
Sir, we didn't see any.
Sorry? No, you can't see. See, sutures are embedded inside these mucosal folds.
In the procedure you did.
Sorry?
If you see the suture, means you have not enough tightened the mucosa.
Exactly.
So that's a bad thing. You can't see the suture once you have completely tightened the suture and cinch it.
Yeah.
You can
So
see the lumen.
sutures are embedded inside the mucosa.
Now switching towards the OT1. Where,
Dr. Rakesh, there is one question. There is one question for Dr. Rakesh.
Yes, please.
That as a procedure, as a sleeve gastrectomy, as a procedure for a bariatric surgery, comes in is not much favored now by the bariatric surgeons. So now doing that not so favored procedure endoscopically, what is your take?
No, that's what. See, it's not now a favorite procedure because of the weight regain. That is what bariatric surgeons have now shifted themselves to OAGB or RYGB.
Yes, sir.
I agree with that. But as I told you, there are a subset of patients 27.5 to 35 BMI who will have the best benefit out of it. Between 35 to 40 is the gray area. Above 40 obviously is not a real indication. So what I'm saying is this is a minimally invasive or a non-invasive, non-surgical daycare procedure.
Right.
So even if there is a weight regain, this bracket of overweight and class 1 obesity, they'll definitely benefit better with lesser comorbidities like post-procedure GERD or GE junction leaks and so on and so forth.
Okay.
Inside you can see the OT3 view inside the cyst cavity and necrosome.
I think Saumin, you can go to the other theater.
Okay.
Right. Thank
you. So switch towards the OT3. And for a moment, within a 1 minute, we are going to switch towards the OT1, where spiral is really deep. And we have seen many of the things. So this is the cyst cavity with necrosome.
Are we audible?
Yes, sir.
So now we are inside the necrotic cavity and you can see the necrotic material. And if the patient is febrile, then yes, you can flush with the water. You can put the nasocystic tube and you can do the lavage also.
Thank you, sir. Excellent demonstration. We are switching towards the OT1 because of the time constraint. Okay. Thanks for excellent demonstration, sir. Switching towards the OT1.
So,
So,
meanwhile, we will invite a few more chairpersons. Current chairpersons should stay. Dr. Ashok Shah, please join the front row. Dr. Vikram Lotwala, Dr. Lavkush Sharma, Dr. Jignesh Singla. Please join the front row. And Dr. Bharat Sonani is not there. Okay. Thank you. Yes, sir.
Water medal, no?
Yes, Dr. Radhika, you are audible.
Yeah, so now you can see the jejunum. We have already crossed jejunal flexure, and you can see very nicely villi here and jejunal fold, and you can see slowly these jejunal folds are pleating on the spiral tube. I'm not pushing my scope forcefully. See
Can
my
we see the madam fluoro image so we can see how deep you are?
Okay.
You continue with your technician. Some technician, please switch on the fluoro.
Yeah, I mean, it is ideally not to do fluoro too much.
Yeah, I'm not wearing.
Yeah, we are not very fond of doing fluoro.
No, I'm wearing.
So unless we are stuck, it is better not to do fluoro because so many people are here.
You are the seasoned player. You know how deep it is. But
No. Once we are deep in, then only we will do fluoro because we don't want to do fluoro unnecessarily.
Still,
There are so many person in the OT.
So many.
Childbearing age.
Okay.
Childbearing age.
Okay.
So, better not to do fluoro unless you are stuck.
Sometimes think about thyroid also, sir.
Yeah.
Okay.
So unless we are stuck, see, this is how the changing the position helps. You can see we have changed the patient's position into left lateral and it has moved in. And it is not necessary to see every time when you are doing spiral.
Yeah, and sometimes you will not able to see the lumen, but you will feel that your scope is advancing. So here I'm not seeing the lumen because it is just touching the mucosa, but my scope is advancing further. Position change water then. So we'll
Sir,
start.
is there any?
Yeah.
Is there any chance of bleed or perf by the spiral, or what is your experience or comment?
Yeah, that is the beauty of spiral, that it will stop by itself. It will stop by itself. It will save you from perforation.
Change. Supine kar we'll change the patient position.
You have to hear the sound and the mechanism of this spiral. It is a beautiful mechanism that it will stop by itself if it has some pressure there. So whenever it has stopped, you should come back and see why it has stopped. Where is your scope going on? Then you can use the fluoro if you have any doubts. But perforation is very rare unless there is some pathology inside, like a deep ulcer or some diverticulum, in which you are going and you are not listening to the machine itself, because the machine is very smart here.
Okay, here I'm not able to see the lumen properly, but scope
So then
is
we can come back, see the lumen and then go again.
Yeah. So I will withdraw a little by pressing a backward rotation. Let's see. Okay. So there is a lumen.
Now,
yeah.
So coming back is not a bad sign in this spiral.
So whenever you are getting stuck, so at that time you can withdraw a scope by backward rotation, and then again by forward rotation you can advance your scope. So it is like a combination of all measures that helps you in reaching the diagnosis or reaching cecum.
Hello. Sir, what is the cost of this procedure to the patient, average cost?
The main cost is of tube. The spiral tube is costing around 30 to 40,000, but we can reuse this tube. We have reused this tube up to 3 to 4 times in those patients where in one patient you do the upper and then in lower you don't require the same. You can do the 2 or 3 procedure of the lower from the same.
Okay. So now you can see.
So it becomes cost effective. We charge around 30,000 for the diagnostic procedure with tube, with a tube extra. But if patient is poor, we can do it free of charge also. So it doesn't matter to us that if the patient has indication and if he requires the procedure, we can do it free of charge also.
Yeah, Manjara, it's going.
See how beautifully it is moving in.
So
So you
it
should
is
have a good massager with you.
it is a disposable tube which cost around 50,000.
50,000.
40,000, 40 to 50,000, and it is disposable. And the same, if you are doing an antegrade enteroscopy, the same tube you can use in that patient for retrograde, but not a vice versa.
We can see the effect of massage on the lumen of intestine.
Yeah. And that is
It is
helpful.
always pleasing.
We
And,
need to train the massager also, I think.
Yeah, you can show with me.
I think it was pointed out that there's no assistant that is required for it, but definitely you need a masseuse
Yeah,
to be on the
definitely.
standby and for
And that
continuous
is to
massage.
trained.
But it is very easy because in a single balloon, I feel that coordination of a deflating, inflating, pushing and pulling is required. And this only massage is required.
But still the indication of small bowel enteroscopy with the single balloon are there. It is not out of the era, because in lean and thin patient, if their patients are very small and where we cannot put this large tube, still we can do this small bowel enteroscopy with single balloon. So it is not that we only spiral can do the job. We can do with single balloon also or double balloon. So the message is that it is easy, it is convenient, it is helpful to the patient, but it is little bit costlier, and still there are indications for small bowel endoscopy with single balloon or double balloon. Because it is not
What about the complaint of post-operative abdominal wall musculature pain?
Pardon?
After this much of massage to abdominal wall, do the patients complain about abdominal wall muscular?
No, never.
No, most of the time they enjoy.
No. They are already sedated.
Till now, nobody has complained. But we
Only
have
problem is that if the patient goes for some other procedure.
because we had a patient of scleroderma where even after putting lot of jelly, there was skin excoriation after this. So,
By chance, if this patient comes back to Gastro Clinic, Gujarat hospital, then he will complain that in Anand's clinic, he was giving such a nice massage and you are not giving.
The adverse events are very less with a spiral scope. Major are very less. Major we can expect
it is moving. Still, if you are not seeing the lumen, it is still moving. It is still moving inside.
So till my that bar, you can see green signal bar is moving. I am safe. Once it reaches maximum, then I am encountering some resistance and I should not push that scope. So you can see the display, the speed there. Okay. So you can see lumen in between.
Sir, any special note from you regarding any
Our
post-operative
clinic has
patients?
the maximum experience of doing spiral enteroscopy.
Okay.
So he is a master.
No, I'm not a master, but I
Sir, any practical tips or notes regarding a patient who has already been operated, regarding lesions, regarding anastomosis?
Actually, it is a relative contraindication. Those patients who have underwent surgery in past, because of Adajan's, there will likely be complication and you will not able to reach the diagnosis also. But as far as concerned, you should avoid post-surgery, post-operative patients. But there is one study they have published in post-op patient also, but you need a experience.
Experience, yeah. Like Radhika madam.
So now you can see the lumen very clearly and
Sir, what are your common indications? You do it for obscure GI bleed, for undiagnosed diarrhea. What are the common indications that you advise spiroscopy?
So one is diagnostic and another is for therapeutic purpose. So in diagnosis, definitely obscure or overt GI bleed. And for therapeutic, even if stricture dilatation is there.
Bleeding.
And even for bleeding, you want to do APC clipping, that you can do. Second thing, if any
anemia,
foreign
that-
body removal, for that also, you can do spiral endoscopy.
One
Those
tricky
patients
situation is GI small bowel tuberculosis. If we
Sorry,
have diagnosis, then we can give AKT and patient may not need surgery. But many patients are operated just because we don't have diagnosis of tuberculosis preoperatively.
sorry, I didn't get you.
Actually, what happens practically that when a patient comes with a small bowel stricture, now you or narrowing of the small bowel, and no definite evidence of no histological evidence of is possible because of one cannot reach, and so practically many physicians they start anti-tuberculosis drug empirically. I think in this scenario, I think Naresh wants to point out that the enteroscopy is helpful.
And many times, see, if we know patient is having COX, then AKT will resolve the stricture in or more than 90% cases. But because we don't have histological diagnosis, sometimes we have to go for surgery. So how many times you have encountered this, done the biopsy and it has turned out to be tuberculosis? What is your experience in this regard?
Sir, if it is a fibrotic variety, AKT is not going to treat the stricture itself.
Sir, literature studies say that in more than 90% cases, there is I think study from North India only.
No. You have to differentiate between the ulcerated and fibrotic stricture. If patient have fibrotic stricture, they need dilatation or surgery. Or otherwise, only the ulcerated lesions can heal, and even if they heal, they will cause fibrosis. So if there is a fibrotic stricture, it is better to do a enteroscopy or any type of endoscopy or laparoscopy for diagnosis first, because now we are seeing patients of Crohn's disease coming after 1 year of AKT, before 3 years, 4 years. They have been treated with AKT, they have been fine, and there is a theory of Crohn's disease being caused by mycobacteria, so it might have responded to AKT first. So it is better to do a diagnostic procedure before landing on to AKT.
Dr. Rajput sir, you have very long, vast, broad, deep, all type of experience with the medical gastroenterology and endoscopic procedures. What do you think in our country, our state, what is common? Crohn's disease is common, or tuberculosis is common?
Tuberculosis has not increased as much as Crohn's.
So
tuberculosis is already stuck, it has gone to the slum areas, while the Crohn's has come to the area which are rich. Yeah, previously it was not diagnosed or it was not even thought of. Because I have diagnosed Crohn's disease before 22 years. My first case is 22 years old, 20-year-old. I have diagnosed in Sal Hospital in around 2000, when nobody was thinking of Crohn's. People were telling that this is a wrong diagnosis, and he is still under treatment of Crohn's after 22 years. So if you think you can diagnose.
So you want to tell that the Crohn's disease incidence is increasing as well as it is getting picked up?
Yes, it is getting more and more picked up. More and more picked up because of better CT scan, better endoscopic, and more availability of the endoscopy and CT scan centers all over the world. Previously, it was clinical diagnosis and people were giving AKT on hand, and then they were referring for the disease. But because of the litigation and all awareness and all Google things, people are now themselves saying that whether I am having IBD or not. Previously, people were saying that we were having IBS. They were coming with the diagnosis of IBS. But now younger and younger people, now they ask me whether I am having IBD or not. Just rule out IBD first.
Right.
So it is awareness, availability of the things, and the media, and your availability of more and more endoscope and CT scan, which has created awareness in the society, and they are diagnosing more and more cases of Crohn's.
Now you can see very fast it is progressing. with water irrigation and abdominal compression. I am not encountering any resistance here. Okay. And the folds are getting sparse.
What is the
So
maximum level where you can reach with this endoscope?
I see.
we can do pan endoscopy. We can reach up to cecum also.
Transverse
And-
colon. Last time we have reached up to transverse colon. Someday we will reach up to rectum also.
But the destination is cecum.
Destination
And
is cecum.
or the till you find diagnosis, if any stricture you encounter during the procedure, that is
The
where-
main motto is to reach the diagnosis rather than
Huh.
the length of the
depth of
reach.
insertion.
Yeah, depth of insertion. It has made diagnostic of those diseases which we were not finding out previously.
And if you find a tight stricture, you can dilate that, but don't try to cross that stricture, because you will dilate up to 18 or 20 mm. But the overtube diameter is 31 mm with pins. Okay, if you try to cross a stricture after dilatation, then you are likely to
Yeah,
do a
pinch may
perforation.
fall off, yeah, or pinch may fall off because of
Dr. Rajput sir, looking at this nice endoscopic view and fairly easy negotiation of the scope,
Yeah.
should I think to buy stocks of the capsule endoscopy companies or not?
Yeah, spiral endoscopy.
Very good question. No,
Capsule,
you
no.
I think I should not buy stocks of
But now-
capsule endoscopy
Yeah,
companies. no?
now there are indications. Previously, it was said that if patient is having active bleeding, you cannot do spiral endoscopy. But now there are published that you can do only endoscopy even during active bleeding also, because you can find out, there are chances of finding out lesions more easily than doing capsule endoscopy, wasting time and treating the patient on the same platform.
The contraindication for antegrade endoscopy is very large varices,
Coagulopathy.
esophageal stricture, like in a previous patient, definitely coagulopathy, and those patients with a submucosal fibrosis, because this patient, sorry. So in this patient, you have to avoid antegrade endoscopy. And for retrograde, if tight anal stenosis, if active inflammatory bowel disease is there, or any perforation, if you are suspecting anywhere in the bowel, you should avoid both antegrade as well as retrograde endoscopy.
Sir,
So,
have you
now while you-
encountered? Hello.
While you are negotiating, ma'am, we are switching towards the OT3,
Okay.
where Dr. Kapil Jamwal is going to perform celiac axis block. This young boy has a
Jaran.
acute pancreatitis
Badhiya
of
Jaran.
unknown etiology, and gradually has a recurrent episode and turned out to be a chronic pancreatitis. He admitted since last 3 months, 4 times with the pain, with intermittent intake of the painkiller. So plan to do celiac axis block to give him temporary relief. Switch towards the OT3.
This temporary
Dr.
relief
Kapil?
would be for
Yes.
how much time?
And please see us at the ultrasound view.
Yeah.
I'm just telling this AV guy.
Yeah.
This temporary relief of pain would be for how much duration?
Should be for around 3 months.
Okay.
3 to 6 months. So we are just anesthetizing the patient. So this patient we discuss, and the best option he chose is celiac plexus block. So we'll be using triamcinolone and bupivacaine, 0.25% of bupivacaine and 40 mg of triamcinolone. Precautions what we anticipate after a celiac plexus block, especially with steroids, is one is they develop hypotension. So this patient should be hydrated well. So I've told them to give at least 2 liters of fluid while we finish the procedure. Second is they can develop post-procedure hyperglycemia. So that we have to take care, because we are injecting steroid into the celiac plexus.
As a
That we have
surgeon,
to take-
we would like to see the MRCP.
Yeah. So I think MRCP, because they have done he initially presented with acute pancreatitis, then he developed WOPN, And then cystogastostomy were done, and they did a prophylactic PD stenting also in suspecting a PD leak. I'm not sure whether he had undergone a MRCP, but they did a
No, no.
PD stenting.
He had undergone MRCP. Right now, we don't
Okay,
have plate
okay.
Vishmit Bhai. And
Okay.
in entire this 4 or 5 hours workshop, we deliberately avoid any type of PPT. Okay, so each and every discussion should be live, but this is in follow-up with me and Naresh Bhai since last 3 years. He developed the chronic pancreatitis, having a pseudocyst of 9 centimeter. We placed the Axios before 4 months and removed before 2 months. We simultaneously did a PD stenting before 4 months, but still had a recurrent pain. So important message, what I have learned from the Dr. Roop Jyoti, that before the development of the neuroplasty, what happens, we used to select this modality celiac block. Once the patient is become very painful, try to use it early. Otherwise, what happens that once a pain perception or neuroplasty has been developed, then possibility this modality will not work as good as earlier. So right now we have slightly shifted clinically to do it little bit early rather than waited for a we used many time admission and at the last resort. Now we are doing it a little bit early to give a pain relief.
So you say that effect of this block is for 3 to 4 months. So after 3 to 4 months, if patient complains of severe pain or aggressive pain is there, then can we repeat this procedure?
Can be repeated.
Okay.
So you have to understand that there are multiple mechanisms of pain in pancreatitis. So this patient already has developed chronic pancreatitis. So there is a neurologic component, neuropenic component of the pain. Then there is the pancreatic cause if the duct is obstructed. So we can do a ERCP, put a stent, take care of the ductal hypertension. Then you can block the nerves. So we can repeat it. It's not a after 3 to 6 months we can repeat the procedure. Meanwhile, we can give some medicines which can take care like antioxidants. Then if the patient has got a steatoria or exocrine insufficiency, we can give some enzymes. So it has to be a multiple modality. Many drugs has to be given.
And what I am suggesting you, this is a relatively short case. So while you are withdrawing a scope, Kapil sir, you can demonstrate the structure in the mediastinum, normal structure in the mediastinum.
Okay. So our main purpose in the anatomical landmark is to identify aorta, so which we are seeing now in the center of the screen, and we trace it till it gets the first origin. And then we rotate it. So this area, which we...
So this is the aorta and this is the celiac
This
trunk.
is the aorta here. And this is the celiac takeoff. So this area in between is the area of celiac plexus, and which has to be targeted. So we can see that the celiac artery is taking off from the aorta. This is the origin, and it goes down and then towards the other supply. So we have to see any vascularity or anything. We have to see first before we see. So,
and you have to identify the crus of the diaphragm. The diaphragm crus will just stop in ahead of the origin of celiac artery. So you can see the crus of the diaphragm and you can see the celiac artery. And our needle has to come to that position and then the injection has to be done. So you can identify some ganglia also there. There is so celiac plexus ganglia. So initially there was a concept that if we inject into the ganglia, the pain reduction is more. But again, some studies have shown that those patients, they don't do as good if we inject into the ganglia. So nowadays, again, celiac plexus neurolysis or celiac plexus block is done rather than injection into the
structure
ganglia.
we are seeing on slightly anti-clockwise. This is the adrenal. We can see beautifully. This is the adrenal gland here. This is the adrenal, 2 limbs of the adrenal gland. This is the body of the adrenal gland. So this is the left adrenal gland. This is the right limb. This is the left limb, and this is the body. And when we rotate a little anti-clockwise, we can see that our structure of
This is the left gastric artery. That
Yeah.
was the left gastric artery.
Yeah.
So this is, you can see the origin of the left gastric artery
Artery,
from the celiac trunk.
Yeah, this is the origin of left gastric artery.
This one.
So this is the left gastric artery which is going towards the right side of the screen. And when we talk, we can see part of, and this is an area of interest which we have. We should see both the structures so that we remain in center. You have to see there should be not be any vascularity there before we start injection.
So again, this injection, there are two ways. One is unilateral injection, one is bilateral. So either you can inject unilaterally in the celiac artery, that's one side of the celiac trunk origin, or you can inject in both the sides of the celiac trunk. Now this, the first injection is under view, and the second, to get the other side injection, you have to just rotate the scope clockwise. Then when just the artery disappears, you can inject it there also. So it is a sort of blind, the second injection. So, and the studies have shown that bilateral is better than unilateral injection. But since it is a bit difficult and we can't see the structure, we usually do unilateral, but we can do bilateral also.
So one question. Is there a particular subset of pancreatitis patients that you use this modality for? I mean, you said that it has to be multimodal. You have to employ many things, including stenting, pharmacotherapy, and this. But is there a particular subset of patients that you find this most useful for?
So, no, so this is the last resort. We don't do celiac block at the first instance. So when the patient first comes, if there is a ductal hypertension, if you see there is a duct stricture or a stone which is obstructing the duct, you can do endoscopic therapy. Usually all these patients who have exocrine insufficiency, they are on drugs, antioxidants. Then after that also, if the patient does not respond to the treatment, then only we resort to this at the last, that is celiac plexus block. Because there is still controversial, like not many all may agree that this helps, but definitely in those patients where there is no other way and the patient has got severe pain, then we can resort to this.
Do you face any technical difficulty if there are large celiac axis nodes?
Yeah, if there is celiac plexus nodes, if there are nodes just above the plexus, then it will be difficult. Of course, our needle will not reach there. So there are important vessels there which you have to avoid. As Kapil is doing now, you can see just above the celiac trunk is the left gastric, so you have to avoid that, and your needle has to come below that. क्या हुआ है? Continue. नाम नहीं entry क्या होगा? इसलिए ऐसा हुआ. So Kapil has already loaded the needle. So what we are using, 19 gauge?
19G.
So we are using a 19 gauge needle. You can, there is a special needle also, celiac plexus needle also is there, which has got fenestrations in the needle. So that you have to understand when the needle comes to the plexus, so there are pores inside which there are pores first in the needle, then on the sideways of the needle also. So that special needle, if you use, then the entire plexus, the drug is delivered into the entire plexus. So special dedicated needle is also there. We can use either a 22 gauge needle or a 19 gauge needle also. So you have to be very careful here because some very important vessels are there underneath. As you can see, the left gastric artery, the celiac artery. So if your needle touches those arteries, and then there can be bleed. If your injection goes into the arteries, there can be so many complications. There can be infection, there can be bleed. So you have to be very careful, you have to be very meticulous. Measure kar lo, measure kiya? So you take your time, adjust. Then once you are sure that your needle is in the plexus, then you can start injecting. So first you have to aspirate, and once you ensure that there is no blood in your aspirate, then you inject the drugs.
Sir, if you accidentally puncture celiac artery or aorta, then what do you do?
Nothing, you cannot do anything. As you know, these arteries, they have a very thick layer. There is intima, media, and all. So usually if you puncture artery also, nothing happens. The bleeding, because the needle is only 22 gauge and 19 gauge needle. If you accidentally puncture also and blood just come out. You cannot do anything there. You cannot give any compression or something there. So you just hold on. The bleeding is not much. The bleeding will stop by itself. But you should not inject. You should not inject your drugs into the vessels.
We used to do sometimes trans-aortic biopsy also. Dr.
Yeah.
Mahal has demonstrated that, and even I think Dr. Yogesh has done 1 or 2 cases of trans-aortic biopsy. But it is at the end time when you don't need, means don't have anything to do to take a biopsy. Okay, so once you puncture, that is excellent puncture. Thus you have to just inject accurate drug.
Nikalo. Biopsy thodi na hai. So you can see Kapil has injected. You can see the tip of the needle, which is just above the origin of the celiac trunk. So we have aspirated. The cameraman can show the needle. There is no blood. So first we'll inject the steroid level.
You can see this echogenic cloud.
Yeah, you can see the echogenic cloud, which is forming when the injection is done.
So I'll just withdraw.
So while injecting, you can keep on withdrawing the needle, so there is even distribution of the drug along the plexus.
Excellent demonstration, sir. We are switching towards the OT2, where gastric poem will be done by Dr. Zahir. This patient, switch towards the OT2. This patient is a refractory gastroparesis and on the prokinetic, only responding to the levosulfide since last 2 years, and now he developed the EPS with the levosulfide. So he had to discontinue it. Gastric emptying study suggests the delayed gastric emptying. There is a one tool called EGG, which is not easily available in India. So we are not able to go for the electrogastrography to see pyloric tightening or not. But there is, as a desperate measure, our patient is very educated and he wants the alternative. Then selected the G poem as it is a relatively safe procedure, and Dr. Zahir is going to demonstrate, and Dr. Yogesh is coming there to assist him.
Hi, welcome back. So this is a case of refractory gastroparesis, and the management is really tricky and complicated in these patients. We have very few options, and why we started doing G poem is the lesson learned from laparoscopic pyloromyotomy. These patients had, a proportion of patients had relief. So now the same thing can be done endoscopically. The principle is same as we did the poem for Ecclesia cardia. Here we see this is the pyloric opening. So we come 3 to 4 centimeter proximal to the pylorus. Make a submucosal lifting injection, give an incision.
We can start lunch. Those who want to take, we can. Meanwhile, we can continue the watching the surgeries. Please, those who want, they can start lunch. Thank you.
Zahir sir, please continue your commentary.
Yes. So I'm between lunch and but I hope once we do this procedure successfully, even this patient will have a good lunch and dinner as well. So I have given a submucosal lifting injection, and with me is Dr. Yogesh, who also has plenty of experience in all these third space endoscopy procedures. So I'm just bringing my knife out. So this is, I'm using a different knife. This is a Arbi knife here, which I'm using. So you have to remember that gastric mucosa is thicker as compared to the esophageal mucosa. So you have to dig a bit deeper.
What are the minimum tests which you will, investigations which you will suggest for deciding to do this procedure?
Yes, that's a very, very good question. And the first thing that we like to do is a gastric emptying study. That is the bare minimum requirement. Second is we don't do it as a primary therapy. We always give these patients a trial of pharmacological therapy, dietary interventions and all. And if we feel that these patients are not responding to all these measures, then only. Look, the response, whatever you do in refractory gastroparesis is never going to be 100%. Even if you do a GPOM procedure, the response is not going to be 100%. So we tell them that, look, this is a desperate measure and these patients are going to get relief in on 60% of occasions. So it's not 100%. So they should be prepared that the result may go on either side. They may not get sufficient relief also, but then this is a desperate measure, as Dr. Saumin also said, that these patients have really poor quality of life, and it's just like if you can do something for them, that should be. So again, you can see that after a mucosal incision, this is the layer, submucosal layer that we are seeing here. And we are just trying to enter into the submucosal space, right? This is our pylorus, and we have done a mucosal incision here. We are just clearing the this submucosal fibers so that we can again go inside the tunnel.
So, Dr. Zain, there are many new investigations available, but they are not, in all centers.
Yes, yes, yes.
So, only diagnosing on gastric emptying study, do we justify this procedure?
So I think the data on for example, if you are talking about EGG, that is electrogastrography, we still don't have that robust data to suggest that whether EGG can predict response in these patients. Of course, we are still learning whether EGG can help in deciding whether this patient is going to get relief or not. But as we gain knowledge, I think in future we'll be able to know whether we can try and see for the predictors of response. As of now, if you ask me, is there any sure shot predictor of response? My answer is no. But a subset of patients on EGG, if you do that study, then it will suggest you that probably there is deficiency of ICC, that is interstitial cells of Kajal. And probably these patients may not respond as well. But we don't have enough knowledge whether this is going to change the management as of now or not. There are studies going on, and probably in near future we'll be able to get an answer whether what are the robust predictors of response in these cases.
Till the time we are switching toward the OT1, where they get some ulcerated surface mucosa in spiral endoscopy. Switch towards the OT1.
Okay.
पीछे लो बायोप्सी दिखाना पड़ेगा.
So some erosions are there, you can see. And I don't know whether this is Watana or something, some capsule. Can you hear me?
Yeah, please go ahead.
Okay.
We are reaching just near to the IC wall, and there is some thickening seen.
Some erosions, ulceration, superficial.
Sir, is there any way to know where is the tip of the scope?
Yeah, that is fluoroscopy. You can see the on fluoroscopy, but
Fluoroscopy on.
yeah. ले आए भाई चल. मैंने पेरू है मेरे लो.
May fall हो रहा है pressure.
नीचे मैडम ये.
So we are in ileum. You can see.
તમે પણ પહેરી જ લો.
Folds are sparse.
હું छोटू नहीं पाछળ ऊपर છે.
मुझे भी चाहिए.
मैडम को भी चाहिए. लेड एप्रन लेता हूँ.
So this erosions is means do you think is it a scope induced or it's
No, they never
no,
seen
just-
before
just-
going there. We have seen this before reaching there.
So is there any no evidence of the you are reaching up to IC wall, but there is no evidence of the gross stricturous lesion?
Till now. Because we may be around 3-4 centimeter or 5 centimeter away.
We are
from
in
ischemia.
ileum, that is for sure. You can see the folds are sparse and the villi also shorter compared to jejunum. इसको left lateral करना पड़ेगा.
Can you
हाँ.
pull appendicolith from the cecal base by this procedure?
Go, go. चलो मैडम जाओ. ए छोड़ दो. You go.
Okay, okay.
So I mean, you can move to the G poem and then we can come back.
We are switching towards the OT2.
Jai, sir, how do you,
Right,
Jai,
Varun.
sir, how do you decide the depth of your current and separation of fibers?
So the electrocautery settings.
Yeah, and your visual impression or what?
So yes, it's a tactile feedback that you get how the tissue is responding. So one single setting is not good for all the procedures. Sometimes you have submucosal fibrosis. There the settings become different. Sometimes you get a lot of submucosa, so you can raise your current settings. So as of now, there is a lot of advances in these electrocautery settings. So right now I'm using a electrocautery RB YO3, which is the most recent version of RB electrocautery, and these I'm using a current which is called precise sect. So the advantage of precise sect is it automatically modulates according to the current that we or the tissue impedance that is being detected here. So there are many advances which are taking place and making our life better.
Any difference in the esophageal poem and G poem for technical specifications, instrumentation, something you want to
So
tell?
yes, instrumentation is more or less the same, but gastric mucosa is thicker. Sometimes you may encounter big, large vessels, so you have to be careful. Stomach is quite vascular. And the other important point is that it's a little more challenging because you have to identify the pylorus ring. Sometimes you may lose path and you are not able to see the pyloric ring. So you have to keep on coming out and of the tunnel and see where is are you heading in the right direction or not? Are you heading towards the pylorus or not? So I usually take my scope out on and off and see my path of dissection. So this is my path of dissection. So I know that pyloric ring is somewhere here. So I'll keep on dissecting till I reach this part. So this is the pylorus, and this is very important that you keep on checking your path of tunnel. Unlike esophagus, which is quite a straightforward organ, unless it's a sigmoid esophagus, here sometimes it may be tricky and you may lose the path. So that is very important that you keep on checking the path of your
Speedboat is
Are
used in this procedure also.
Big vessel there.
Yes.
Speedboat, can you use speedboat here also?
Yes, definitely. Unfortunately, the speedboat guy had his flight. We could have used speedboat. Speedboat can be used here. So all the any tunnel procedures you can use speedboat.
Speedboat is more speedy. Faster.
Yeah, it's just a what electrosurgical knife you are used to, and otherwise I don't really see a big difference. But then it's a new technology, it's a new current. For example, I'm using a monopolar device here. The current which I have to be really careful that I press, I don't injure mucosa while I'm doing this. You see a big vessel there?
Yes.
So do you want to see some red?
No.
No?
No.
Okay.
What is your experience about post-op symptomatic relief? And second thing is some unexpected by reflux or something new symptoms development after this procedure.
So bile reflux, I have not seen, but the response rate is say around 60%. So you have to tell the patient that, look, I'm doing my best, but it's not that this procedure is definitely going to give you relief. This is something you have to, so he shouldn't expect that he'll definitely get relief. So that is something patient expectations, sometimes they are too difficult to handle. So right from the beginning, you have to tell them that, look, I'm not sure this is going to give you relief, but this is max I can do.
There are two types of patient. One is who is responding very well to prokinetic, but he don't want to continue. And second sort of patient, those who have incomplete or partial relief with prokinetic. The choice of procedure, will there be any difference?
So the one who is getting good relief with prokinetic, I always suggest him that no need to shift. This is not a very fancy thing to do.
Again, it depends on the type of prokinetic. If he is using levosulfide, then again long-term administration is
yes,
a problem.
Definitely. So levosulfide, like this patient had neurological side effects, and some of which can be really cumbersome and irreversible. So, and then again, look, in the present era, there are a lot of litigations that are you should be aware of that. Look, and when you tell these patients that you may have irreversible neurological side effects, nobody is willing to take levosulfide. In fact, gastroenterologists are shifting away from levosulfide gradually.
And so those who are non-responder to prokinetics, is there it is a contraindication to this procedure, or what is
No,
your
no, not like that. In fact, this procedure is meant only for patients who are not responding to prokinetics.
Should we consider alternate diagnosis in that patient? That is what I want to say.
Pardon me, I didn't get it.
If
Should
patient
we
is absolutely not responding to prokinetics, should we consider alternative diagnosis?
Yes, you can do. Of course, you have to objectively evaluate for gastric emptying before you finally say that your symptoms are due to refractory gastroparesis. Psychological comorbidities should be addressed, and if there are any, I think they should be addressed first before you should take him for any invasive procedure.
Problem is most of the antipsychotic have anticholinergic effect.
Yes, exactly. For example, if you use tricyclic antidepressant,
yes,
then again, but their anticholinergic effect on stomach is usually not that strong, and patients who have a strong component of depression or anxiety, I think before doing any procedure, all those factors should be taken care of, because otherwise it's like you are not going to give these patients any benefit. They'll come back and say that my symptoms are not resolved. So we have a some technical glitch for coagulation mode. So we are getting a different cable. So you see, we have caught this vessel very close to the muscle so that we don't injure the mucosa. So this is you have to be very careful when you are doing any third space endoscopy procedure. Now you can see that we are coagulating this vessel. We coagulate it till it blanches and then finally cut it. So fairly large vessels can be dealt with now these endoscopic hemostatic devices and knives. Smaller vessels can be dealt with the same knife, and larger vessel we have to use the current, coagulation current. Patient selection is still, we are still far from the optimal management in these patients for two reasons. One is we don't know what are the predictors of good response, which is very important before you select the patient and you counsel the patient that, look, you are going to have a good response or not. So there are several predictors evaluated in some studies, but then there are all data is all conflicting. So as of now, we do the procedure, but before that, we do counsel the patients that look, there are chances that you may not do uh, very well after this procedure also.
This entire gastroparesis story is bit perplexing because by if you see by the procedural end, we are doing like what we do in poem for the achalasia cardia. In achalasia cardia, there is a visual evidence that the OG junction is not opening, while in gastroparesis, there is no visual evidence that the pylorus is not opening.
Exactly.
Then
Yes,
they, so
I agree. I completely agree. The thing is, if you see the pathophysiology of gastroparesis, it's not only pylorospasm that
Yes.
is
So that-
resultant symptoms.
So
So to deal with only one component, we
Yes.
have some studies which suggest that if you check the distensibility of pylorus, look, visual impression may be erroneous and may be subject to inter-observer variability also. But the thing is, if you do an endoflip, which is a test to measure the distensibility of sphincters like pylorus, then you may probably be able to tell that, okay, here there is a strong component of pylorospasm. For that, we need to see what are the normative values of pyloric sphincter pressures in our patient population. You don't need to go with the what is the data available from the West. We have some data from the West, but then we need to see data from our population, that what is the normative value and what is reduced distensibility of pylorus. Only then we can like bring it into routine clinical practice. As of now, this is being done as a last resort, because this patient developed severe neurological side effect with prokinetics, and now we are left with no other option, and it's a resort to improve his quality of life. So I again say that this is not the procedure that should be done routinely in all the patients. That is not the message I want to give by doing this procedure. And the reason is, if you take unselected patients, the response rate is around 60%. So still a large proportion of patients, they are not going to get relief.
So the problem is not with the procedure. Actually, I think the entire science and pathophysiology of the gastroparesis is not completely understood.
Yes.
That is the problem, and not the procedure. Procedure is very well technically sound procedure. So probably the procedure is ahead in time as compared to the understanding of the pathophysiology of the problem.
Yes. I agree with you. If I have to quote the data, almost there should be around 30 to 40 studies depicting success rates right from 40 to 90%. But look, the thing is, still I believe that we don't have a large amount of quality data with us. So we need to understand that it's a complex, it has a complex pathophysiology. Pylorospasm is just a small fraction of that pathophysiology, not the entire pathophysiology.
In future, I believe that there would be classification of gastroparesis, that these patients have pylorospasm, these have slow stomach,
Yes.
they have discoordination. That type of classification would come in future, and in this particular set of patients, you go for G poem. That is what I feel.
Yes. In fact, that's a very valid futuristic process, and I believe that that classification is definitely going to help these patients. So we come out, we see we are on the verge of reaching pylorus. This is our bulge that we see. It's a centimeter away from pylorus. We keep on doing. It means we are on the right track, and we just need to keep on proceeding with the same technique that we are doing. I repeatedly come out because stomach is wider than esophagus. So there are chances that I may lose the original path and go back to, may not reach the pylorus if I don't catch the right track.
Do you see pneumoperitoneum after this procedure in few patients or?
Yes, yes, yes. Pneumoperitoneum is part and parcel of all third space endoscopy procedures.
Okay,
So
but
in
it is no
fact,
consequences.
it's not even considered a complication now. You just have to put a needle and Yogesh, you have any comment? How do you choose your patient and what do you tell your patient before?
Cases.
And how is your experience with like both of them responded
what
or?
you told 50 to 60%, not that great result to be very honest.
Yes,
I think choosing the right patient is very important. As I was asking you which kind of patient you choose. So post-surgical with gastric pull-up, those who have pylorospasm in them we can use, but not in diabetics.
Yes, yes, yes. So in fact, brain eaters, I avoid brain eaters who have a lot of expectations and who say that, so I tell them, if you are expecting too much from the procedure, then probably you are not the right candidate. So it's like, and some of them, they do get dramatic response as well. It's not like none of the patients do well. It's some of the patients say they improve so well that it's like they gain weight and their quality of life improves. So there is that is the thing where you bargain for, okay, let's do it and see. Right now, doing and seeing is the only thing that we know. Maybe in future we have good predictors of response and endoflip comes up in a big way, then probably we will be better in selecting these patients.
In gastric pull-up patients, we do intraoperatively pyloric dilatation from inside to avoid it. And same thing if it happens post-operatively, pyloric dilatation can help. What is your experience in gastroparesis by due to other cause? Generally, after gastric pull-up, pyloric dilatation is more than sufficient for most of the patients.
Yes, yes. It's like, in fact, people have done dilatation therapy, Botox injection therapy for these patients with some success. But unfortunately, the response rate is again very poor. So if you ask me how much these patients respond to dilatation, I think maybe around 30%, 25 to 30% they respond. So that's again a gray area where, for example, Botox injection and all, this is a gray area where you are not really sure whether this patient, but definitely if you plan to do a GPOM, then some experts advocate that you do a Botox injection. If the patient finds or improves, then probably later on you can go ahead and do a GPOM procedure, because that will act as a guidance.
But it will make poem difficult, Botox.
So not necessarily. It's like but it's like a trade-off between difficult poem versus predictor of response.
Surgical, during surgery, when we do pyloric dilatation, it is a little bit different. We put a sponge holding forceps from inside. Outside is our hand. So we can take little bit, we can apply a little bit more force. So I think that is the reason during surgery, when we do pyloric dilatation, generally they don't develop post-op this gastroparesis.
We are switching towards the OT3 where there is a periampullary malignancy, unoperable, and referred for the previously plastic stenting has been done and now referred for the metallic stenting. It is quite difficult to cannulate. You can see the position of endoscope as well in the fluoro. Dr. Sandeep, you are live.
Yeah, hi. So this is a inoperable periampullary malignancy. Previously, a plastic stent was placed. Now the patient, since it's inoperable, you have to think of chemotherapy and other treatment. So this plastic stent, the plan is to change the plastic stent and put a metallic stent, self-expanding SEMS. Now the problem here is the growth, as you can see, there is an extensive growth almost involving entire D2. And it was very difficult to get, we cannot reduce the scope here because the space of the duodenum has decreased. So what I have done is I have taken out the plastic stent, and it was almost a blind cannulation. We could not see anything, but somehow our guide wire has gone inside. And you can see the cholangiography also, the dilated CVD and my scope is in a weird position. It's a long loop. I cannot reduce the scope here. So the next what we will do, my cannula is inside. Now I will exchange the cannula and we will just put the metallic stent here. So here we will put a uncovered stent, 8 centimeter uncovered stent we will put. And that will be the end of the procedure. So already biopsy proven inoperable adenocarcinoma of the periampullary region. So if this case, if ERCP would not have been possible, we were planning to do a US guided choledochoduodenostomy or hepaticogastrostomy or a antegrade route. But somehow when we were just thinking, my scope went in. But as you can see, I could not reduce the scope. So these are all these periampullary malignancies when they present at such an advanced stage. These are the only options. So we'll finish it in 2-3 minutes. We'll just demonstrate how to deploy the metal stent. So here we'll put a self-expanding metal stent uncovered. Covered we will not put for obvious reasons because the gallbladder is there. It can obstruct the gallbladder. Then the second thing is the stent can migrate if we put a covered stent. So can you see the guide wire? Is the guide wire visible? You see the topmost part, you can see the guide wire. These are all malignant mass and you can see my stent coming out. So this is the stent which is coming out. So you have to put a traction. So the stent has gone in. Can you show the fluoro?
Fluoro is on.
Fluoro दिखाओ.
Push.
दिख रहा है?
अभी नहीं आया, उसके scope के पीछे है, behind the scope.
Can you see the stent? 8 centimeter है ना? दिखना चाहिए. दिख रहा है?
Yeah.
Tip. Can you see the tip?
Just below the highlight.
Please concentrate on the fluoro.
Zoom. Yes.
Yeah, so you can see the stent now. Just the tip of the stent has gone into the right side. This is the right anterior duct.
Yeah.
Right hepatic duct anterior. So as the fluoros, this cholangiogram, we are seeing the left duct very nicely. So the dye has not gone into the right anterior branch, but my stent is going there. You can see the right anterior branch. Yeah, so we have come to the end of the stent.
Yeah.
Yes, it has gone inside. So we will start deploying the stent. So this is a simultaneously, we have to look at the fluoro image as well as the endoscopic image so that the stent, appreciable amount of, normally what we do is around 2.5 diamonds of this stent should be outside. But here I can't see much because of the anatomy. So here we will keep it a bit longer because of the mass. So this yellow portion which you see is the end of the stent. So we'll start deploying. Yeah, start. We'll just put a constant pull and he will start deploying. And you have to see the cholangiographic picture also. That is the fluoro. There you can see the stent opening. दिख रहा है? दिखाओ. Constant मत दिखाओ, बीच-बीच में दिखाओ. हाँ. देखो. Open हो रहा है?
It take time because it's
if it is in a loop. Okay. Let me come out little bit. नहीं, बाहर आ गया.
Started opening. कोई बात नहीं.
नहीं, मैं यहाँ ज़्यादा हो जाएगा ना. You have to push little bit inside. Yeah. हाँ, खोलो. खुल रहा है? I think 6 centimeter will be okay. हाँ? क्या हुआ? टूट गया? कर रहा है? Open नहीं हो रहा है ना ऊपर. So undilated duct होगा क्या वो?
नहीं, basically maybe it's because loop.
Loop के लिए open नहीं हो रहा है because the scope is in a long position. खोलो. रुको. मेरा ये ज़्यादा आ जाएगा यहाँ पे. हाँ, अभी खोलो. See if it
Elevator छोड़ दो.
एलिवेटर छोड़ दिया मैंने. नहीं, एलिवेटर ऊपर है. देखो. नहीं रहा है.
Reduce it.
ज़्यादा.
Reduce the scope.
अब खुल रहा है.
So the stent is not opening inside. अभी शुरू हुआ.
Is it because of tight stricture or?
No, it's mostly
Because of the loop of the scope.
Scope position.
Okay, okay.
Because here I am unable to deloop the scope because the position is very narrow there inside. नहीं हो रहा. So we'll exchange. We'll take out it. Take out the stent. Wait.
Wire push the wire. Push the wire.
Wire push करो. दिखाओ. एक बार floor दिखाओ. हाँ. We'll just take out this and we'll see if we can reduce the scope, but it's difficult to reduce the scope. We'll just try once more. Guide wire रखना हाँ. और लेफ्ट साइड में जाना है इस बार. लेफ्ट साइड पूरा ऑब्वियसली डायलेटेड है. नहीं तो और एक चीज कर सकते हैं ना, लेफ्ट साइड में तुम कोशिश कर सकते हो गाइड वायर को नेगोशिएट करने का ना.
Change it now.
Sandeep, have you deployed the stent?
No.
I have taken out. It is not opening inside.
Okay. So you can take another stent also.
Yeah.
There must be few stents there. Yagnesh, please help me.
और चेंज करो, डायरेक्शन चेंज करो.
देखते हैं. एक चीज, लेकिन ये निकल गया तो दोबारा डालना बहुत मुश्किल होगा क्योंकि अभी कुछ नहीं दिखेगा अंदर. मैं इसको निकालना नहीं. ओ अंदर गाइड वायर
एलिवेटर छोड़ो.
When we use uncovered stent, how long it will stay? Basically, tumor ingrowth is an issue. So how much time does it take?
Yeah, so depends whether you are treating the tumor or not. If the patient responds to the chemotherapy or radiotherapy, whatever the treatment modality the patient will be given, then of course the tumor ingrowth won't be there. But if the patient does not get any treatment, then of course tumor
Wire is
ingrowth.
coming. It's quite difficult position to hold. Who is the technician? Please hold the wire.
So if the patient undergoes treatment and if the tumor responds to the chemotherapy, then the stent will be there. Then the stent won't get blocked. Otherwise, if the treatment is not there, then the stent might get blocked due to tumor ingrowth.
How much time it will take? 3-6 months or even few years?
Yeah, so metal stents can stay up to years also. I have seen metal stent patent for a year also, more than a year also. So entirely it depends on the type of the tumor and the type of treatment the patient is undergoing. Sometimes food material can block the distal end of the stent. That you can do an endoscopy and you can clear that.
Okay.
So we have taken a different stent or that one only? बाहर ओपन हो रहा है. So let's see. एक बार एक काम करो, गाइड वायर देखो लेफ्ट साइड में जाता है क्या?
Change the guide wire. Now put the stent inside.
Inside ना, हाँ अंदर चला गया, अंदर चला गया. Just see if we can change the guide wire to the left side. देखो
पीछे आना पड़ेगा. हाँ, push अगर.
एक ही जगह पे जा रहा है. देखो उसको थोड़ा बकल
stent पीछे करो.
थोड़ा नीचे दिखाओ, tip of the scope दिखाओ. Can you see the fluoro? We are trying to negotiate the wire into the left side.
Okay.
So that because it looks more dilated, I'm sure the right side will also be dilated. Just this thing has not gone there, the contrast. Or we can put some contrast and see opacify the right side. इसमें जाएगा ना contrast? नहीं जाएगा. आ जाओ बकल करके जाओ.
राइट में गया.
एक्चुअली लंबा हो गया. 6 सेंटीमीटर होता तो अच्छा होता.
ठीक है. ओके.
अभी दूसरा डॉक्टर में गया क्या? उसी में गया था. और नीचे आओ. हाँ.
Length outside longer. That will be one.
So we'll put in longer length outside then. नहीं. और क्या कर सकते हैं? दिखाओ.
Put a wire inside.
Wire डालो.
Push wire.
पुश. दिखाओ. ये बंद हो गया. ये करो.
बंद कर दिया भाई.
अरे यार तो टाइम लग गया. हाँ ठीक. चलो ठीक है, खोलना शुरू करो यहाँ. लेकिन ये like a fairly long stent will stay in the duodenal side if we deploy it here. But that's okay. खुल रहा है कि नहीं देखते हैं अंदर. खुल रहा है? एलिवेटर नहीं है, ऊपर ही है. नहीं रहा.
This is the same stent or other stent?
The same stent. खुला खुला खुला. दिखाओ ऊपर. So the stent has opened. If you can see in the fluoro? Fluoro थोड़ा zoom कर सकते हैं? नहीं खुल रहा है. नहीं खुल रहा है. मैं तो पीछे ला ही रहा हूँ और खुल जाए और ऐसे बाहर बहुत है और बाहर आ जाएगा. समझ रहे हो?
Sandeep, in such difficult situations, when you are not able to place this stent, what all alternative methods you can think of to drain this biliary system?
Yeah, suppose now if we can't put the stent here or if the stent is not opening due to this difficult anatomy here, we can go for alternative routes like US guided endoscopic ultrasound guided drainage of the biliary system. Like we can do a US guided choledochoduodenostomy or US guided hepaticogastrostomy, or we can do a antigrade also. खुल रहा है? नहीं. ये टीप के लिए पता नहीं कैसे क्यों नहीं खुल रहा है. तो मैं ट्राई करता हूँ एक बार स्कोप रिड्यूस करने का. छोड़ो.
I think it is very difficult if you do via reducing the scope. Try to change the stent, or if it is that stent is also not deploying, then and then you reduce the scope. Otherwise, second cannulation is quite difficult in this case.
Yeah, second cannulation because of the blood and all, we will be unable to do here. Oh, the scope reduction is also looks very difficult. दिखाओ एक बार. Acute angulation हो रहा है ना वहाँ पे scope का. अभी देखो, अभी देखो, देखा? एंगल है. वो acute angle जो हो रहा है, लेकिन वो तो बाहर है.
The disease is fairly advanced. Can we put multiple plastic and
Yes, we can do. We can put multiple plastic.
Because this is very quite a large growth, so that can be one option.
एक दूसरा स्टेंट देखोगे? 6 सेंटीमीटर दे दो, एक 6 दे दो, देखते हैं. Exchange. So we'll try with another metal stent. Maybe this stent has got some, if the stent has got some defect in opening, but it was opening outside. We took out and we tried outside, it was opening, but for some reason it's not opening inside. Guide wire miss नहीं होना चाहिए. हाँ? दिखाओ. ठीक है. हाँ.
Till why we are shifting towards the OT2 to
Yes,
see
yes.
the G poem.
Okay.
Dr. Puri, Dr. Zahir has left because he has a flight to catch. So he has been taken over by Dr. Rajesh Puri.
Hello, sir. We are with you.
Dr. Rajesh, are you able to hear us?
Now, yes. So, can you see us now?
Yes, we can see internal view.
So now you can appreciate the pyloric opening here. Inject. We have reached up to the pyloric opening. Inject. Yeah. So this is the pyloric ring. Can you appreciate the pyloric ring?
Yes, sir.
Yes, yes.
Inject. And we will go once out, we'll come out and we'll see. Let me just take out the scope. We'll take out the scope. The most important principle, you should not keep on insufflating the air. Otherwise, what is going to happen is you are going to increase the diameter of the opening which you have created. So now can you see we have reached up to here? Okay.
Yes.
So I think Zahir has taken a little bit more proximal side, but it is okay. I will again go in and This is the direction where we were. I will inject a millimeter more. Yeah. Yes. But I think we have reached up to the pylorus. So what we are going to do, we'll start the myotomy. We have the IT knife. Will you give me the IT knife? Yeah, I know, but we have a IT knife. More for the precaution to avoid the injury to the opposite wall. Yeah. Can you show me the, yeah. Inject. Do we have IT knife? The only advantage of IT knife in this position is we avoid injury to the duodenal mucosa, which should be taken care. Can you inject a little bit more? Yeah. I need a IT knife if we have. Otherwise, I will do it with this only. You don't have? Okay. So let me start the myotomy. Can you appreciate the duodenal inject? Yes. Okay. So now I will do the myotomy. And myotomy again can be circular and longitudinal. Put a little bit more water.
Now we are switching toward the OT3. I think they are trying to deploy a stent again. OT3 switch. Dr. Sandeep, you are live.
Yeah.
now.
So can you show the fluoro to them? Can you show the fluoro?
Yes, we can see fluoro.
So have you seen, can you see the fluoro? The tip of the stent has opened. We just changed the stent. Initially we took 8 centimeter. Now we took a 6 centimeter one.
Okay.
So the stent is opening now. So we'll deploy the stent. Come on, Choro. Excellent. So the stent is, you can see both the endoscopic image and the fluoroscopic image.
Yes.
So little bit, you can see the stent outside. So this is uncovered stent. We'll keep little bit more length duodenal side in the duodenal side because of the tumor. So you can see the gush of bile which is coming out.
Yes.
And we have deployed the stent.
Wonderful, Sandeep.
Thank you.
Excellent. It's a very difficult case to cannulate. I must congratulate Dr. Sandeep.
Excellent demonstration, sir.
Yeah, thank you. So now we'll take out the assembly and you can show a fluoro image. खींचो
बंद करो
बंद करो
तभी आएगा
आएगा हाँ अभी आएगा ओके एलिवेटर डाउन है आगे So you can see the duodenal side, a lot of bile and biliary sludge. Can you show a full fluoro now?
Yeah, we can see.
Yes, we can see full stent in fluoro.
Okay. Thank you. So while coming out, you should always never forget to deflate the stomach, because while extubating or while the patient comes out of the anesthesia, the patient might aspirate. So always we should empty the stomach before coming out.
Thank you, sir. We are switching towards the OT2 where G poem is going to be completed.
It was difficult. Initially, you thought we will change to US guided, but somehow the stent went, the scope went. We thought the scope won't go.
So now we have done the myotomy.
Puri, you are live now.
Yeah. Now can you see the peritoneum? Can you appreciate the peritoneal structure outside?
Yes.
always keep a scene. Can the anesthesia people will see, because you will going to get the pneumoperitoneum. That is important. In this, pneumoperitoneum is bound to happen. So if required, we can do the decompression. If you feel there is any problem while doing the, yeah. Are you facing any problem? So try to inflate as minimal as possible. So I think 3 centimeter is more than sufficient.
This precision is just like a goldsmith.
वो था नहीं इनके पास यार. I asked for it. So it is always better to do the insulated knife. Dr. Sandeep is with me, and the insulated knife is a better option in these patients to avoid injury to the adjacent organ. I do agree, which is always better to avoid mucosa opposite side of the duodenal wall. Do we have an insulated knife, IT knife? We have IT knife, IT nano. If we have, it is better. Yeah. That is always better. But I think this much of the myotomy is sufficient. You require around, yeah, we have cut it. Do we have the insulated knife? Is that abdomen is okay? So don't inflate air too much. Can you see the CO2 level is high? Okay. So if we will get the insulated knife, it will be good. Let me just, yeah, 42, 44, we can do it safely. Do we have
I
insulated
think this
IT
is
knife?
good enough, sir.
IT nano?
No, we don't have that.
We don't have?
No, but I think this is good enough. Myotomy you have done perfect.
Just wait for a minute or so. You see earlier, we don't have. Okay, so we'll do with this only. I'm into the duodenum, I'm sucking the fluid. So the best part is, the most crucial aspect in this is when you are doing the pyloromyotomy, there is a high risk that you are going to injure the duodenal mucosa. And please close it, close the knife completely. Yeah. So this is the aspect you should very carefully observe. You should not injure the duodenal mucosa. If you have done it, then the patient will end up into trouble. So that is number one. Number second is, try to insufflate as less as possible. Otherwise, you are bound to increase the opening of this, and then it is difficult to close it. So these are the two important points. I think we will do, this is okay. I think this length of the pyloromyotomy is okay. The duodenal side, let us observe. But I think we will do this much. Okay. So like you see the retroperitoneal structure below is, so that is important. If you have the out, if you have the insulated knife, your risk of complications are minimal. So I will do step by step. Ideally, I should go below. I hook up and I'm going to pull towards my side. Is like this. If you don't have, I will go below. I will hook it up and try to cut on my side. This is the way you should do. Okay. Be very cautious, not be in the hasty. Okay. Step by step. Yeah, we'll cut it. Because the insulated knife is not there, you are not very sure what is behind it. You understand? Yeah, we can see omental plant. Out, completely out. Okay. I'm going to be in. Okay. Patient CO2 level is okay. This okay?
Yeah, I think it is good enough, sir.
Yeah, I think we have done it. Yeah. I will do like this. Okay. This is. Can you see the duodenal mucosa there? Do we have the forceps? Can you give me the co-grasper? I can just pull it and I will cut it. So this is the ring. Is that right?
Yes, sir.
I will come out. Now, can you see the opening of the pyloric ring?
Yes, now it is widely open.
Yeah. So the insulated knife would have solved our purpose very nicely, but because I just want to cut this last portion and then I'm going to close the opening. Yeah. So what I'm going is, as we have discussed in the morning, many of the time the part of the fibers they remain. Why I'm not cutting this? Because I don't have a access to the distal side of the knife. What I'm doing, so what I'm going to do is I will try to catch with the knife. Yeah. Open. Can you open like this? Yeah, vertical. Will you rotate a little bit like this? Yeah. A millimeter. Yes, is okay. Is okay. Hold. I ensure that you see this is not the muscle for this is not muscle. Yeah, this is momentum. I think we have cut it. Don't you think?
You have completely cut off. I think it is time to close now.
Open. Close. Open. Close. No. Open. So the closing. This is much more tougher than in comparison to the doing the closure of poem procedure. This is important. Sometimes you may require the Apollo underswitch in these cases, or you give the transfer incision. That is another important thing. You give the transfer incision, which is little difficult, but chances of the complete closure will be there in that case. Open. Yeah, the little bit of difficulty you encounter. So now you see what I have done. What I'm going to do is same like poem. I clip a little bit on the side. Is that right?
Till the time sir is doing closer, 43 is ready for the procedure.
Rajesh
Yeah.
sir, one question. When we can see the peritoneum, are there chances of infection going into the peritoneal cavity because stomach is
Yeah,
not
actually, minimal amount of fluid goes. So I think you can take care of that. You give a shot of the. Now you see the first clip is not right.
means
not-
infection is not a concern.
No, it's a very small amount of fluid, but I think you know that the first clip is not okay. Can we remove this clip now? Please give me the second clip. The first clip is not rightly placed. And this is a little challenging than poem. Poem applying the clip is most easy, but here it is a difficult proposition. And you see my first clip is not right. And this really require a little bit more expertise and more vigilance. So all the clip will open like this. You understand, like this. Okay. Yeah, open. Yeah, rotate a little bit. Yeah, that's okay. Oh, like this. Yes. Okay, because this first clip is not right. Okay. So we'll not go according to the first clip. No, we'll do it. We'll do it. Just wait. Wait for a minute. Let this clip to go up. Okay. Now better. Now better. Just don't rotate. Don't rotate, please. Don't rotate. No, I want this clip should be like this. Yeah. Wait for a moment. Yes. Yeah, but my first clip has created a so now before applying, I should make sure that both the side has been hold nicely, because this appears good, but the stomach wall is thick. Just wait. Wait. Now it has to come from both the edges. And if it doesn't come, can you close it? Yeah. So now before applying, I'm going to inflate again. And I will see that is it right or not. Has it hold both the sides? You feel it is okay? Sure? Okay. Okay. Sure? The right margin is also? Yeah. Apply the clip. Okay. I think this is okay. Now the job will be easier. Give me more. But the first clip is important. You see the right side is also hold nicely now. But you know that this side is a little bit more everted. We will check it in the subsequent. Yes. But this is important in the stomach actually, because risk of peritonitis will be there. You can't take the chance. Open. Yes, that's okay. No, little bit more. Very slowly. Done it. Very good. So what I'm going to do now this side, I will apply the clip just distal to this. make the right knob like this, so I can clinch both the sides. Is that okay? I make sure that both the side of my left side is come more than right side. Yes, just wait for a minute. Close once and show me. Closed. I think it's okay. Sure? Sure?
Yeah, first class, sir. Just deploy. Yeah.
Close. I think this is okay. This clip is okay. No, but actually this is a little bit more difficult, and I should ideally would have removed the first clip. It would have shown. But I think we'll take care of this. Close, close, close. Now things will be easier, but the stomach mucosa is a little bit more thicker. Open, rotate, good. So now what I'm going to do, I will just go behind this clip, hold both the side of the mucosa. I ensure that, yes, this. Push the clip. Do the suction, things to be come between the two jaws of the clip. And then I will tell him to close first. Yes, closed. This is the advantage of Medora clip or any clip like from is it okay? Sure. What is the opinion of house? Is okay? Okay. Close. Fire. Okay. I have to see the right side is there. Is that okay? Yeah. So one more clip. But we'll keep this patient NPO for 24 to 48 hours with the Ryle's tube in. His abdomen is not distended. The key while doing the myotomy, you should not keep on insufflating the CO2. That is important. Open. Rotate. Rotate. Yes, just. Now what I'm going to do, I will go just behind this, hold both the sides. Yeah. No, why you have light? Yeah, I wanted to see that. Okay, open. I think it's okay. You don't have Medora? Is Medora? It's a single shot. You can't open it. Okay. So now put the water. Can you give me the water, please? I will just reassure that everything is okay. Yeah. Wait for a moment. One more clip. What do you say? Huh?
Yes, sir. Definitely one more clip.
We apply. I don't think now required. Do you think? Yeah. So this is another clip. So you give me the clip which I can see open and
this
close.
clip is last clip is unilateral. Sir.
Yeah, I will do it. Close. So this was not a opening closer clip. So this is important. So what I'm going to do is I will apply otherwise I will remove this clip and then I will apply the new clip. Can we remove this clip? Give me the red tooth. Give me the red tooth. Now there is a trick to remove the clip also that is important. You have to give the jerk of the scope. Use the force of the scope to remove it. You have? Okay. Meanwhile, let me just see. Where are we? Open, open, close. So now to remove this clip, what you are going to do, you hold the clip and use the jerk of the shaft to open. I will hold it, close. Now what I'm going, loose, so hold it. What I'm going to do, I will use the force of the scope to remove this, like this.
We are
Release
switching toward
this.
the OT1. We have find some stricture there. That what we are looking for. Please switch toward the OT1.
So can you see me?
Yes.
Yes, we can see.
So as there was no progression during antegrade enteroscopy, we put clip and we started doing a retrograde enteroscopy. So from cecum, I have entered into the ileum. So here you can see very well circumscribed diaphragmatic stricture. So it must be almost 50 to 60 centimeter from the IC wall. Can you see that stricture?
Yes, we can see that.
So we'll take a biopsy from that. Looks benign to me, and maybe don't know the history of NSAID, because usually this kind of stricture you get in a patient who are taking NSAID. I will take a biopsy, and after that I will dilate this stricture. So the learning point during power spiral enteroscopy, when you are not progressing, despite spiral rotation, you need to stop there. You have done all the measures like water irrigation, abdominal compression and decompression. Also change the patient position from supine to lateral or vice versa. Sometimes what happens, there will be a malfunction of spiral overtube. Either it get detached from the rotation coupler, or sometimes the spiral fins breaks also. So recently we had that problem. So when you are not advancing despite all these measures, you need to abort the procedure. You can clip that or do injection with the India ink or methyl indigo carmine, and retrograde enteroscopy you can start. Open. Bye. So what do you say? What is your opinion?
Hey, this looks like benign. I think even
Yeah.
biopsy is just a formality in this case.
No, you have to prove whatever you see abnormal. So, I mean, you have to take biopsies. You may see eosinophilia in this. There are cases of eosinophilic stricture in the colon, so you can treat them.
No, but not reported as a carcinoma. There is definitely
No. We still have to go. We have to see the clip. So we are still not convinced that we have reached the clip. So spiral is persistence and perseverance, patience.
It requires lots of patience.
That is why it is given to you, madam. You have a lot of patience.
Thank you, sir.
The best person should do it.
Open.
Somebody else would have done half the procedure and would have said that, no, I will not go from beyond, stop the procedure. But madam said, no, we will go.
Okay.
We will go inside.
No.
That is what the difference between the excellence and the normal people.
Bite. Okay.
बस ये चला जाएगा ट्यूब
सीधे
सीधे चले जाएगा it will go. ट्यूब चले जाएगा.
Okay, let's see.
Yes,
Doesn't
गया.
maybe the 16
Normally the
centimeter.
tube, tube can go with stricture like this.
Let's try actually.
Eosinophilic old age, no?
I can see the clip through the no, there is.
वो चमक का है मैडम.
Okay.
आपके मेहनत की चमक है. But now it will go easily. अभी बहुत इजी जाएगा क्योंकि आपने बहुत अच्छे से उसको एंगल क्रॉस कर.
Okay, let's see. It is progressing. You can see on a display in a PIP image.
Yeah, if you think it is lesser, it is very small, then you can do.
When you
But
feel
you
that
don't
very
cross
tight,
just a very tight picture. You don't cross that very tight picture. So it is always better to do dilatation and then see. If it is dilated less than 18 millimeter, then it is better not to go in.
Okay.
Take biopsy and come out.
Do.
Hey, fluoro लगा के देखो.
Let's
No,
see.
now it's going very easily.
Yeah.
हम clip से आगे तो नहीं चलेंगे.
No. I don't think so. I have crossed the clip. No, sir.
तो ट्रॉमा वाला पोर्शन तो चला गया.
No.
We are switching towards OT3.
Lunch break
Okay,
रहेगा ना?
where
Yes,
the
you
very
can.
simple procedure, but I think many surgeons are doing that procedure, the dilatation of stricture. So we have kept 2 or 3 simple procedures like EVL glue and dilatation of stricture. So switch to the OT3. Dr. Yogesh, you are live now.
Am I audible there?
Yes.
Okay. So I must congratulate Saumin for this wonderful conference. This is a 50-year-old lady who has presented with dysphagia, and she is already diagnosed case of peptic stricture. She was dilated few days back, but again she has complained of dysphagia to solids. So as you can see on this forward view scope, there is a partial stricture at the G junction. On endoscopy, it seems that it's not that tight stricture, but as patient has dysphagia, we should dilate it. If I try to pass my scope across the stricture, I am feeling resistance, but I'm able to pass that. And as this is a single stricture, it is not multifocal, we will plan to do a radial dilatation rather than longitudinal dilatation. So there are 2 types of dilatation available endoscopically. First is radial, which means that you have to dilate by a CRE balloon. You can dilate maximum up to 18 mm. And other is longitudinal, which can be dilated by the Savary-Gillard dilators. Can I get a CRE balloon, please? Yeah. So this is a CRE balloon. You can see here. This is available from Boston Scientific as well as other companies, and we can dilate the stricture up to 15 to 18 mm. And such kind of dilatation reveals an radial force. So this we use only when the stricture is focal stricture. But if the stricture is multiple strictures and we are not able to negotiate through the stricture, we are in doubt that that might be multiple strictures. In that case, we pass a wire and we give a longitudinal force. Give me a Savary-Gillard, please. So this is the Savary-Gillard dilator, which exerts a longitudinal force rather than a more radial force. So the first step is always delineating a stricture is very important. So here you can see that stricture is partial and the mucosa is almost normal. It's not a friable mucosa. Already biopsy has been done earlier, which is a benign biopsy. But if you are doing it for the first time, you are visualizing a stricture. Biopsy is very important. You should not dilate without taking a biopsy unless until it is a corrosive stricture. So we will pass a guide wire first. Guide wire, please. So here we are using a jag wire, which is used for ERCP. The reason I am using this is because it is a very flexible wire and we are using CRE because CRE balloon length is almost 350-400 centimeters. So we need a wire which is of same length. We cannot use the steel wire which is used for Savary-Gillard dilators. For purpose of demonstration, I would also show you the Savary-Gillard wire which we use. That is the steel wire. Show me the steel wire, please. So this is the steel wire which is more stiff and exerts and is more stable while using the Severi-Gillard dilators. But we cannot use this wire when we are using a CRE balloon. So we pass the wire across the stricture.
Dr. Yogesh,
Yes.
would you, after a dilatation, send this patient for fundoplication as he has got a hiatus hernia, which is the reason for peptic stricture?
We can see hiatus, but unless until patient is having peptic stricture, he should not go fundoplication because that will lead to more dysphagia. So we will treat him with PPIs, and if patient has persistent reflux disease, in spite of PPIs and lifestyle modification, then we will do fundoplication. So we pass a guide wire here.
They do excellent after fundoplication. No repeat need of dilatation also. We have series of
That's what I'm
cases.
telling. If the patient has small hiatus or just lax LES, if after 3 months of PPI and lifestyle intervention, if still they are symptomatic and there is no peptic stricture, in that case we'll go for fundoplication.
Yeah, so I think what my colleague has said is absolutely right. Whenever there is a small stricture with the hiatus hernia, the only two options, either do a small esophagectomy and then do the reconstruction for this. Otherwise, you have to dilate the stricture, give the PPI, make sure that the stricture is not recurring, and then do the hiatal hernia surgery. Otherwise, patient will end up into again a dysphagia. So I think what Yogesh has said is absolutely right. You have to dilate, treat, and then do the fundoplication. Otherwise, this patient, because if you don't do it, the reflux will keep on happening and patient is going to develop the restricture, because it is not that patient is symptomatic. Patient is symptomatic. The stricture has developed because of the reflux esophagitis only. So he requires a permanent treatment, and that is dilate. Once the stricture is remodulated, and then you do the surgery in these cases.
So thank you, Dr. Rajesh Puri. So as this patient has symptomatic dysphagia to solids, we will dilate this till 15 mm. Usually solid dysphagia occurs till 16 mm, but previous dilatation was only up till 11. So we won't be much aggressive. We'll dilate till 15 mm. Please make this patient supine, please. In such cases, when you are able to see the stomach as well as the opposite side, there is no need of fluoro. But as we are here in a workshop, I will demonstrate this in fluoro also.
But this patient require an aggressive PPI therapy.
Yes, sir.
So the stricture should not reoccur.
Yes, sir. Just a minute. Fluoro, please.
So recently we come across, and this is a reasonably well dilated stricture. That stricture was recurring, and we discussed with our GI surgeon, and they says they might do the small esophagectomy in the lower part.
We will dilate. Please dilate. We are dilating this till 15 mm. Just a minute. So it is very important for the surgeons who are practicing endoscopy that you have to keep resistance towards you, towards the scope tip. Otherwise, the balloon on dilatation will migrate into the stomach. So very important to keep resistance against you. You can see how it is migrating. Very important to keep resistance and keep on pulling this balloon towards you, towards the scope tip. You have to dilate for at least 45 seconds to 60 seconds. Fluoro, please. Oh, how many seconds? Any questions?
No, nice demonstration.
So now question comes, when should, already biopsy has been taken in this case, but question comes, should we take a biopsy in case of peptic stricture before or after the dilatation? So the guidelines say that once you dilate, then you take a biopsy, because it has been shown that chances of perforation are more if you take biopsy prior to dilatation. So always do a dilatation and take biopsy from the strictures. Okay, so We have done this for 60 seconds. Exchange. Some bleeding is always expected. Jelly, please. Jelly. We'll also look at the hiatus, as it is definitely a matter of concern. So, Dr. Puri, what do you think? This is Hills 2? Dr. Puri, sir?
Yeah, Dr. Yogesh, I think this is a very good question, and it is very important, those who are learning, to first describe Hills 2 or 1 or 3 or 4, you have to keep on inflating for 1 minute.
Yes.
1 minute inflation rule is mandatory. And after inflating for 1 minute, then you should examine what is a Hills grade this is. So please inflate for 1 minute.
Yes.
Wait and watch. Minimal I can see now from the distance, although there is a blood, but this is Hills 2.
2, yes.
But you have to inflate for 1 minute, Yogesh,
Yes,
this
yes,
is important.
Yes.
And if you come across with the Hills 2, up to Hills 2, you can do endoscopic
endoscopic.
fundoplication, and beyond that, patient require a surgical intervention.
Yes, sir. We'll inject some water to visualize the types of Hills grading. Yes, sir. So this is Hills 2. Dr. Puri, do you agree with me?
What you are saying, Dr. Yogesh? Hills 2, yes.
Hills 2, yes.
Yes.
Always check for any perforation. Any further questions, please?
No, excellent demonstration.
Thank you.
And now we are again switching toward the OT1. And in OT2, we are going to demonstrate magnification endoscopy and NBI by Dr. Rajesh Puri, but patient is shifting. And in OT1, spiral endoscopy is going on. Can we switch towards the OT1?
Meanwhile, here I think we can conclude the session on offline. Online it will be there. We can see in the YouTube live and Facebook live. But I think we can end the session here physically. It will be like, if anyone want to attend, then we can carry on. There is no issue. Otherwise. We thanks all of you, those who have attended this session on your busy practice, and this Sunday where we rarely, as a surgeon, we rarely get time to get relaxed, and still you spare a lot of time. So we thank you. Thank you all the sponsors also, those who have helped a lot. So thanks a lot.
However, online program is going on. So all the OT members stay alert. Okay. There are plenty, 4 or 5 case still are pending. Okay. And we are going to complete it. And online YouTube, Facebook, and those who are watching online in entire India, the question answer session is going on.
No.
So we have find one stricture, and now we are looking for a clip from retrograde route to complete it as a pan enteroscopy, and to remove any doubt that what is the exact pathology is.
No, keep supine only. Supine only. So, are we on screen?
Yes, we can see the endoscopic view.
Yeah, so we are trying to search for a clip. And there were one more stricture, like a previous one that we have crossed. Maybe my spiral fins are getting stuck there. That's why I'm not advancing. But let's see. Supine, supine. So we are changing patient position.
Previously, you were searching for the stricture, now searching for the clip.
Yeah, so I to just to do a complete endoscopy and whether I'm missing anything or not. You can see a lot of bend I am encountering in these patients. Bends, acute bends are there. So maybe we are just near to the clip because you can see this bloody liquid is coming from antegrade endoscopy.
And some marks are also seen.
Sorry?
Some spiral endoscopy marks are also seen on the mucosa.
Yeah. So I think we are just near. Maybe I need to cross that bend. So those patients with central obesity, big abdomen, sometimes it's difficult. So we are doing a fluoroscopy. Can you see this acute bend?
Yes, yes.
Okay. So on a fluoro, can you show a fluoro? This is
Can you see the clip on fluoro?
4 or 5 centimeter fluoro on the. So this is the clip. Can you see on fluoro?
Yes. Right.
Yeah. So trying to cross that bend.
Probably it is the same band which didn't allow you to go further.
Yeah. Yeah.
So it might be some 4 or 5 centimeter long segment.
Yeah. Can you take out the fluoro? थोड़ा पेशेंट को नीचे करो, नीचे करो, खींचो. Again, this looks like some stricture. Yeah. Yeah. So I feel multiple diaphragmatic stricture this patient is having, and which is not allowing my spiral tube to go ahead. So let's see, I will try for 5 minutes. If I'm not going, then we'll abandon this procedure. Toto. ये ना acute bend है ये ना. क्या चुन के पेशेंट दिए? Am I on live or what? I think Saumin sir is taking some revenge from me. This
Madam,
is
you are
first.
live. You are live, but I was in OT2. So you are live. So whatever you want to conclude, whatever you are finding, whatever you want to
Okay,
summarize, you can summarize right now.
Yeah, I will try for 5 more minutes, and if I'm not able to cross this bend, no, because small bend I have crossed, and if not, then I will conclude. So I was telling this staff that you are taking some revenge from me.
No.
That's why you have given such case to me.
You see, it is not about the case. It is
Yeah.
all about the unpredictable. We never know. Okay. So it may be the angulation or something like that, that the pan enteroscopy cannot be completed. But what I want to ask is, what are the percentage or what are the chances that we are not able to do the pan enteroscopy with spiral? What the literature says.
Okay, so literature says pan endoscopy with antigrade is possible in 10 to 30 cases. Like in a Western series by Baina, they were able to do pan endoscopy with antigrade in 10%. But Mohan Ramchandani series, they have done in a 30%. Okay. And if you do combine like antigrade plus retrograde, chances are of a 50%, 50 to 60%. So it's not that even if you do antigrade and retrograde, 100% is not there. So in 40%, you may, despite doing antigrade and retrograde, you will not able to reach the diagnosis or not diagnosis, but we will not able to complete a pan enteroscopy.
And what is the commonest area? Means where the difficult to reach.
So in my experience, after pylorus and DJ flexure, ileum, distal ileum is the most difficult area to cross, where you will encounter so many bends, and it will take so much time to cross that bend. Jejunum is very straightforward, so it's very easy to cross a jejunum. But ileum, distal ileum is little difficult.
So most of the time the culprit is the distal ileum. That's why we are not able to complete the pan enteroscopy.
More likely. Yeah.
And we are also stuck in there only.
Yeah, we are getting stuck there only. Let's see if I एक बार left lateral कर दो. And sometimes the factors patient related also, Dr. Saumin. So obese patient, no, in that also it's not that procedure related, but patient related factor also, like obesity, past surgery, they will preclude pan endoscopy.
More difficult in obese or anything?
More difficulty in obese. Obese with a loose, flaky abdomen. Sir. Okay. सर आप थोड़ा ना मेरे साइड से है. थोड़ा जेली लगाना है यहाँ पे. जा रहा छोटू.
Give massage to this massage man.
He Chotu, Chotu online.
Yes, he needs massage.
हाँ कर दे, कोई दिक्कत नहीं। अभी ये एक बेंड है, अगर ये चला जाता है ना, so as this procedure are time taking, it is better to do under general anesthesia. So antegrade and endoscopy, we always prefer to do under general anesthesia. Retrograde you can perform in a propofol also. I need to cross this bend. Water, water, water. वो पहले ठीक कर रहा था, पहले ठीक कर रहा था। थोड़ा पकड़ के रख।
वो अफसाना जिसे अंजाम तक लाना न हो मुमकिन, उसे खूबसूरत देख मोड़ देकर छोड़ना अच्छा।
But I must appreciate your persistence. Such type of patient, it is very difficult for me. I cannot do case for such a long and with such a persistence and with such a patient, I must say, because you are just 3 centimeter away from your target, and for 3 centimeter you are fighting for since last 30 minutes. So this required a great persistence and great patience.
छोड़ 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 ये छोड़। I need a long endoscope maybe. Water also. Pressure. Continue. छोड़ अरे भैया इसको लिफ्ट क्रॉस नहीं कर गए ना हम लिफ्ट जेली चाहिए हाँ करता रहे छोटू तो पकड़ के रखो पकड़ के रख प्रेशर देखे रहो पेशेंट काफी आगे चला गया है मेरे नहीं ये देखते हैं ये अगर क्रॉस हो गया तो फिर बस ये पकड़ो रे यहाँ पे इसको पकड़ो छोड़ बेंड पे बेंड आ रहे हैं इसके छोड़ विल अबॉट हाँ हाँ आगे भी बेंड है एक मिनट छोटू What are I doing? दे प्रेशर बहुत स्कोप मेरा शॉर्ट हो गया है हाँ, मुझे लगता है वहां के वहां पे ही है। हाँ, वहां पे देख देख लेते हैं। इसको ना ऐसा करना पड़ता है, सीधा सीधा करता है और पैर पैर नीचे, स्कोप को। हाँ,
come back, and before grading a varices, the main thing is we have to inflate the esophagus completely. So the grade 1 is the varix, we can visible, but it disappears when you inflate. Grade 2 varix is a which persist. Grade 3 varix which occluding less than 1/3 of the lumen, and grade 4 it is not working. Yeah, and the again we are just grading the varix. Okay, so the grade 1 varix is the varix which is present, but during when you inflate the esophagus it disappears. Grade 2 varix it persists during the inflation. Grade 3 varix is a large varix, but it occupies the less than 1/3 circumference of the esophagus, and grade 4 varix are the varix which occlude the entire lumen. So this has a grade 2 and grade 3 varix. Now there is a simple tips how to do EVL. So while you are doing a EVL, you have to preserve this tip. You have to preserve this tip because this tip is very, very important. Okay, and this is the most delicate part of the scope. So most of the surgeon, what I have seen, they started endoscopy, and because of the some problem or some chronic maintenance, they discontinue. But they have to preserve this tip. That is the most important part of this scope. Okay, so the EVL band is a very simple technique. It's a rubber band, and you have to suck the varix. And when you have completely sucked the varix, you feel that your vision is completely of the varix. You just have to fire, and it is a perception, feeling, tactile sensation, which is most important. Now this girl is loading EVL band. Okay, and there are many companies which is producing EVL band. Right now we are using it of Focus, and you have to just okay, and there are many companies you can use. It should be your comfort. Okay, and it is all about your perception, tactile sensation. If you feel that this band I am more able to perceive absolute fire, then you should use that band. Okay, so you have to just press the cap. Now another important thing is the lumen diameter of this cap. So when there are many local companies, sometimes you find the diameter is slightly shorter than the tip diameter. At that time, if you forcefully try to fit this cap over your scope, chances of getting tip damage is very, very high. Okay, so you simply load this and try to keep this thread at 6 o'clock position. If you see the endoscopic vision, it is at a 6 o'clock position. Okay, so it will not obscure your vision when you are going inside. Always check for outside suction or the gloss. You can see the gloss is easily coming out inside, coming inside. Apply a lubrous jelly, maximum lubrication, because there is a slight friction. This the EVL diameter is high. Reach up to the stomach, come back and select the varix which is just started about the G junction. Suck, you observe the vision and fire. This is misfired. So this is the problem with the band. Sometimes suction is not adequate, and sometimes if band is too old, go more than 6 months, 4 months, and it is in your endoscopy room, sometimes rubber gets delayed. So we just come out and we remove this band. Needle ले ले, needle ही करना. And we are doing the banding, you have to keep ready glue also, because you don't know anytime. No need to prepare right now, but it should be handy. It is not like that we have only EVL band, and those who are doing a EVL band must have glue inside their endoscopy room, as well as they should be skillful enough to glue in case of any unexpected bleed. So this band is beautifully placed. Now either go clockwise or anti-clockwise. If you feel that varix is not coming properly, then you have to just move your scope up and down. So it will come inside your scope. Oh, I think band is finished. Okay, so now you think there are few varix above also, but if you have to trace that varix, if downstairs you have applied some band, there is no need to band it again, because once this band and this varix get thrombosed, automatically the varix you have seen in the middle or upper esophagus automatically disappear. So this is a very simple procedure, but the save your tip of the scope. And second most important issue that while you are doing a EVL, you should be equipped with the glue also, and you should learn how to glue also, because sometimes unexpected bleeding happens, and sometimes esophageal varix associated with the gastric varix, and you can't do EVL first, and then you think later on I will send some patient for the gastric varix, because after that it is very difficult to go inside the stomach. So those who are doing the EVL, simple tips, try to learn how to do glue also. Even you can use glue in the esophageal varix also in case of the inadvertent bleed. Okay, now we are switching towards the OT3, where there is a case of enteral stenting in case of the metastatic disease of CA pancreas with gastric outlet obstruction. So So switch towards the OT3.
Am I audible? So
Yes, sir.
today we have a case of an elderly male who has presented with complaints of gastric outlet obstruction. And on workup evaluation, he has a mass lesion at D2 and D3. But we have done an endoscopy. Actually, the lesion is more distal. It is as D3 and D4. So what we are doing is the CT scan shows that lesion is at D3, D4, leading to luminal stenosis, as well as he has pulmonary and liver metastasis. So this shows it is stage 4, and we will do a palliative stenting, enteral stenting. So first of all, what are the indications for enteral stenting? First is that obviously a metastatic disease, which is not curative. Other, is patient symptomatic or not? Suppose if a patient has duodenal malignancy and no symptoms of gastric outlet obstruction, though he has metastasis, it is not an indication for stenting. Can you see the endoscopic image? You can see the endoscopic image? So what we do is, first we locate the stricture and then try to pass the guide wire with help of a we'll try to pass the guide wire across the stricture with help of a biliary cannulae, which we use in a ERCP. Kamal is trying to pass the guide wire. Jare? Wait. Is it going? Turo, please. Turo, please. There. There. Yes. No. Can you make the patient supine, please? Turo. So? वांधो नहीं था कर दे तू कर रहे मुझे वांधो तू आ करे
Going in OT1 to demonstrate a GI genius artificial intelligence for increased enhancement detection of the polyp. And I am here as his substitute to do enteral stenting. Now, most important thing is to pass the guide wire. I think we are across the there. Go. We are coming back. This is a double channel scope. Acha, do you want to put a direct enteral stenting? Then it will be a different. No, it is better to do it double channel. No? We can directly put a stand there. Only thing is stomach is so much inflated. That's why we are looping. Well. Well. Fire is coming there. Draw fluoro. છે ઉપર પેલું GI જીનિયસ વાળું લગાવડાવી દે ને. ફ્લુરો हो गया भाई. Now try. Previously we have already crossed. हाँ वही करें. जाना तो जाना चाहिए. शुरू. शुरू. It is cannula. Cannula तो रिटर्न नहीं आया. ये now do it. Well, though I am blind, but you do it. Where is your wire? Is it triple lumen, double lumen? Okay, do it. Oh, we are crossing, but we are not able to. Scope, see, but a double channel there. This is double channel scope. You have seen with the endoscopy. That is the difference. Fluoro? I think now we have crossed. So now I'm withdrawing. Is it okay? Are you happy? Should I withdraw? Exchange? But we have to delineate the stricture, na? Huh? Now can you die? Okay. So this is the most important part. Now this time we are using a double channel scope because it is easier to insert an enteral stent entirely with delivery device inside the larger channel. When you have a single channel scope, the diameter is little bit low. So diameter is little bit low, so you are not able to, you are not able to So just preserve this image. Okay, so it's a short segment. We will try the 6 or 9 centimeter stent first. Okay, save image and transfer it to the other side. Plus it if you want. Hey, wire. Exchange. Slowly. Because my position is not very good. We are going to deploy Boston wall flex duodenal stent. 6 centimeter we are going to deploy with 22 millimeter diameter. See the next case here? No. Here are cystogastrostomie, 2-3 ERCV metal stenting. So I personally feel the esophageal stent and the antral stent, that is the most underutilized as a form of the palliation in malignancy patient. Because in terminal patient, most of the time, relative wish is the whatever happens, but my brother, father, mother or sister has to eat something from the mouth, and it should improve the nutrition. But somehow I must say it is underutilized because of some problem of the cost. Have you tried this? Bar cutting job. Skinking. Show me the fluoro. Okay. Now we are out. The tip gets stuck. Now we have. The good thing about the double channel scope that you can place it under direct vision. Just remove this. Try. Okay. Now try it. It's going. Okay, let me all more shorten this. No, let me lengthen this. It is not coming out. What we can do, you can just remove this and put some jelly in front of the scope. See the front assembly that it can be done. Until the time you are doing that, give me 12 centimeter stent also. One minute. The stent is, I think, perfectly fine. There shouldn't be any problem. Just see. Apply lubrication in front. It may help. Silicone oil. What I have done. Silicone oil लगाओ आगे. The silicone oil we used to lubricate when the everything what we call the surface is more sticky, and even your scope button when it gets jammed, you can use silicone oil. Ideally, we should apply marker, and there is a 2 radio opaque marker in this stent also. But right now we are in a position where we can see directly the distal release of the stent. Okay, so it is very easy to see under direct vision. And if the stent its length is 12 centimeter, so we have enough length to deploy in both the side of the tumor. Post piece then. So see the position of wire. Wire is okay. Okay. Got it. Kumar. This is getting stuck the same where I think there is a problem with the scope only. Yeah? Channel, I don't, channel the motivate it. But somehow. Okay, what we can do. We have another double channel scope. Do we have another double channel scope? 100 series? 160, 2T 160? 2T 160 I think is there. And just first remove this stand. See in the 2T 160, is it passing on? So what we do, we try to change. Okay, the scope. Let's see, either it is a fault in the scope head. And if it is not going in that scope also, then we keep the wire here, we put the marker, and we try to do radiologically. Check karo. Slippery thing. No. Curved happens, then it should not be stuck at the opening. It should be stuck at the site of curve. There must be narrowing at the fire. It is going easily in that scope. Give me the gloves. So should we keep wire inside and you want to go over wire scope? Okay. A catheter. Yeah. You just keep slightly outside the scope. Keep the fluoro on. Just leave the scope for better. Fluoro. Let's decompress the stomach completely. Later on, entry will be easy. This is another important part when you have to deploy into something into the duodenum or jejunum. Try to decompress the stomach as much as possible. So chances of loop formation is rare. क्या बोल रहा है? वायर खत्म हो गया. अच्छा, okay. Then it is okay. Fluoro. I'm just, I think if wire is coming out, then tell me the sense. Wire is in. Wire is in. It is in the contrast part. Okay. Wire? It is there, no? It is there. Give me the. We are doing it over the stand.
Hello. Sir, in case some patient when unaffordable for stand because stand cost is very high, in that case, what approach you will prefer in that case? If patient is not affordable, poor general condition, and for palliative purpose, for feeding,
Just go for feeding jejunostomy.
feeding tube, NJFT feeding tube.
Feeding jejunostomy.
Uh,
Nasojejunal feeding tube will not last long.
okay.
Okay. So if there is a no diffuse peritoneal mats, it is better to go for feeding jejunostomy.
Okay.
But nowadays there are few local stents are available, which is relatively cheap. So you can try that also because this patient is a particularly on palliative care and
Yes,
the
sir.
lifespan is maybe a 6 month, 1 year, we don't know. So even local stent works good.
Yes, sir.
So only thing is the problem with the deployment sometimes.
Yes.
Otherwise, is fine. If patient is very poor, you can use that also.
Another question is that, sir, if this case may be post for gastrojejunostomy.
EUS guided GJ.
Yes, sir.
You can post. But in this case, it is a slightly dicey because practically you are doing a EUS guided gastroduodenostomy. Okay.
Okay.
And in this case, stricture site is slightly distal. It is distal to the ampulla. So there is a possibility that you may, if you not very sharp, it may be possibility that your and in the jejunum means and in the duodenum may be proximal to the tumor or itself tumor may be involved in the placement. Just CO2 on. Okay. So before posting, I think better to do one EUS in this case particularly. It is not infecting then. So EUS guided gastrojejunostomy, otherwise it's an excellent form of palliation. I feel so because nowadays it's gaining popularity in the benign stricture also. So even the benign stricture can be taken care by EUS guided gastrojejunostomy and practically it's a daycare procedure.
Yes, sir.
Okay. However, technical success rate is around 90%. 10% you may not get adequate window or 10% chances you may face the problem to find a suitable loop. But otherwise, it's excellent form.
Sir,
Now we
another
can
doubt
see
is
the
that
tumor.
when we are not able to see the distal end of the tumor,
Yeah.
so
Distal or proximal?
yeah,
This
distal.
okay.
This is the proximal end of tumor. When we are not able to see, because not able to negotiate and not able to see the distal end.
Okay.
So how we decide the size of the stent?
You just put a contrast. Okay, this is a short segment, but initial 6 centimeter stent was not deployed. Another stent available is 12 centimeter. What I feel there should not be short. Means if you are feeling that, please tell me, send me the proximal marker of the stent. Where is my scope tip? Ah. ये रहा, एक मिनट बाहर 10th बाहर आ गया सब कुछ ही बाहर. So you can just put a contrast and see the length of stand, the stricture, sorry, and then you decide the length from fluoroscopic examination. I think it is sticking somewhere. It is a wire. This patient has a huge stomach distender. That is another problem, lead to the repeated negotiation. हाँ हाँ बिल्कुल बिल्कुल है ना. Try to finish it. Marker यार. हाँ पेशेंट अंदर नहीं जाता ना. I become blind. Bro, I think we have crossed the stricture. Arey, GI Genius is complete. Hello. 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 Now we will shift to OT1, where Dr. Yogesh Sarwani is there, and cross the tumor or what?
Today, the job which is assigned is to demonstrate artificial intelligence in endoscopy. So to begin with, please focus on this instrument. Focus here, which is from Medtronic. The name is GI Genius. Whenever the word genius comes, the first thing which will come in our mind is that he or she might be intelligent. So this machine is also same. It is the machine for artificial intelligence. Now, just to begin with, what is artificial intelligence? That whenever we search something on internet, or if we try to look for some song on internet, the internet recognizes what kind of choice we have. For example, if we are willing to go for some romantic songs, it will keep on showing romantic songs. Please ban kar do. So here the machine knows what we are looking for. Machine knows that we are looking for polyps, and hence it will detect the polyps. Now, why such kind of technology is important? The reason is that though in India there is no protocol for screening colonoscopy as compared to Western states, but in India the risk of colon cancer is very high, and adenoma detection rate in India is very low. So if artificial intelligence is used, we can increase the adenoma detection rate from 33 to 45%. And studies have shown that 1% increase in adenoma detection rate can reduce 3% risk of colorectal cancers. I repeat, 1% increase in adenoma detection rate will reduce risk of colorectal cancers to 3%. Hence, this is the importance of this technology. What I will do is, this is a normal white light endoscopy. This patient already is a known case of polyposis syndrome, but it has been kept here for demonstration purpose. You can see a multiple polyps, small polyps on white light endoscopy also. But in those patients in whom already CA colonic cancer is there and you are doing a screening colonoscopy, or you're doing a screening colonoscopy for first time, in those patients, this technology is very important, especially if they have family history of colorectal cancer. So this is a small machine. It is easily portable. And the importance is that it is compatible with all kind of scopes which are available by Olympus, Pentax, Fuji, and everything. So I would ask my colleague to start the machine. Just by one button click, the artificial intelligence system starts. Is it on? Okay. You can see your multiple polyps, but as I told you, in those patients whom you are suspecting polyposis syndrome, or in those who are doing screening colonoscopy, we can use this technique to increase the adenoma detection rate. So how does this work? Basically, engineer is better to tell, but there are some computer assisted detection techniques and computer assisted diagnosis which helps to detect polyps. So here you can see there is a rectangle, green rectangle around the polyps which are seen. These are small polyps. So this is increase in adenoma detection rate by GI Genius. It is also important that the preparation of the colon should be very good, because many a times if there is a stool or if there are many bubbles, this technology will false positively detect those bubbles also as polyp. Or if there are any prominent veins, it will detect as polyp. You can see here the rectangular part, these polyps are very well detected on such kind of artificial intelligence technology. Other thing is that we have to remember this is only for adenoma detection rate. It is not for characterizing the type of polyp. So it will only detect the adenoma, but it won't characterize the type of polyp. Either it is, according to NICE classification, it is 1, 2, or 3. Or in that case, you can do an NBI also, which is available with 190 scope. Is there NBI in this? Yeah, so you can on NBI scope. Okay, so there is no NBI in this system, but you can utilize the NBI once you characterize the type of, once you know there is a polyp here, and then based on NICE classification, which is an NBI classification, you can plan to resect the polyp. You can see here multiple polyps which have been picked up by green triangle. So this is artificial intelligence. You can increase the adenoma detection rate. Honestly, this is not the ideal case because it is already known case of polyposis, but it has been kept for demonstration purpose. Can you ask Saumin, is polypectomy has to be done or not? Karthik, is Karthik around? So here is a large polyp. Again, this does not need artificial intelligence, but for small polyps, artificial intelligence is required. Dr. Saumin, can you hear me? Do we need to demonstrate polypectomy also? On YouTube, are there any questions for artificial intelligence? Majestic people, push lo. Are there any questions for artificial intelligence? लो, बंद कर दो, हो गया ना? हाँ, बंद कर दो. नहीं. Okay. 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 So with this, I complete my demonstration. If there are any questions on YouTube, I will be happy to answer that. ठीक है? हाँ? क्या? नहीं, बस हो गया. Yeah, that's okay. I know that.
karo. Somebody has to talk. Hello. So there is excellent demonstration. We are not going to do polypectomy because this patient has a familial history and they are planned for colectomy. So there is no need to do a polypectomy because there are plenty of another diminutive polyp in entire colon. And in such a case, we have to remove the colon already. So I think there is no need to do polypectomy right now. The plan is to preserve the rectum for this patient. And once you go for the anastomosis, and after the anastomosis, we will use this GI genius. You can use this GI genius to see the residual polyp in the rectum, either diminutive, and you classified it via NBI or magnification endoscopy. And via this, you can, for surveillance colonoscopy, I think it is excellent tool, and whatever the diminutive polyp reside in the stomach, in the rectum, that we can remove. Now, another case we are going to induce right now is a pseudocyst of the pancreas. There is a large pseudocyst around 18 centimeter and plan to deploy a multiple plastic stent in this patient. Now, indication of this drainage is the persistent vomiting and abdominal fullness. So two, three things is most important, that while you are doing a US guided cystogastostomy and the cyst size is large, then you have to intubate the patient. Otherwise, what happens? Once you once the fluid is start coming, then once this fluid start coming, then it is high chances of aspiration. So better to go for intubation. So better to go for intubation. And we are going to intubate this patient. Now plan to put a multiple plastic stent because this is equally effective as a metal stent. But only thing is it may get blocked sometimes and the cyst may get infected. Okay. So we are planning to put a multiple plastic stent. And in the above OT, there is another lady, young, who has a history of obstructive jaundice before 3 years and did ERCP in some other centers, followed by the perforation and multiple organ dysfunction. And after that, she has been operated. She has been managed conservatively in the same institute and they recovered. And at that time, they have put what we call the drain in CBD. So, and after few months, they have removed that drain. She again presented with the jaundice before. She again presented with the jaundice before, I think 4 months. And at that time, she was in cholangitis. So we put a multiple plastic stent. So at that time, there was CBD stricture, but though in the lower end. But we are able to put a 3 or 4 plastic stent. So plan is to do right now, if they remove that plastic stent, go for spyglass and see what is the morphology of the stricture and can we take a spy bite biopsy from there, and plan to put a fully covered self-expanding metal stent. Now, fully covered self-expanding metal stent is a beautiful modality in which benign biliary stricture can be resolved in 80% of the cases, even it is a chronic pancreatitis. Or if you don't have a fully covered SEMS, then you can put a multiple plastic stent in the multiple times. That is called the Costa Magna protocol. And after that, you can find the resolution of the stricture. But it requires multiple times of the ERCP. While in the fully covered stent, you just have to do ERCP for 1 time. You have to wait for a year. And then we have to see after removing of the stent that the stricture resolution occurs is not. So this is another modality that we can safely use in the benign biliary stricture. And to prove it a benign, spyglass is must. On spyglass biopsy should be done. Now in this case, patient has a stricture since last 3 to 4 years. Okay, and so we don't expect any malignancy. because its duration is large, means long, and the imaging is static. There is no progression of the stricture or something like that. But what is the etiology of the benign stricture? We have to see that. And then we take a spyglass if possible, because it is a very lower end. But I think we may be able to do a spyglass, because I am able to put a 3 plastic stent, so it may be slightly dilated, and we may be able to insert a spyglass. So I think Dr. Yogesh and Dr. Kalpit Devani will be there to do a spyglass, and Dr. Kalpit is there. So Dr. Kalpit is a guy who is doing a spyglass in the USA, and he is very good in that. Let me check. He is still in the institute, or he has to do some other work, so he may left also, because time is running out. And right now our cystogastrostomy patient has been induced, and we can start cystogastrostomy. So the two things you have to focus. One is the ultrasound image. The guy in the AV department. Okay, one is the ultrasound image, and second is the CM image. Okay, there is no need to focus on my face or my hand movement, because that is okay. So ultrasound movement and CM image is must, and we want to put a multiple plastic stent in that. So this is a EUS scope. If you want to see, this is a EUS scope, and this is a Pentex EUS scope. Our machine has also a elastography protocol. Okay, sir, you can go. So 1 minute, sir, please come here. So Dr. Kalpit and Dr. Rajput is here. He is going to, sir, please come here in the frame. Kalpit, please. So he is going for some work, and I thank wholeheartedly ANS team, Noble team, and Kalpit sir for their contribution in this academic event. Thank you very much. Thank you, sir. Thank you. Thank you. Thank you. So, and this guy, this is a Pentex scopes. Now, advantage with the Pentex scopes is a slightly large diameter channel, but disadvantage is slightly cumbersome to use compared to the Olympus scope. And we have EUS elastography software, so you can use it in the lymph node or a mass characterization, which it is a benign or malignant, so that we can use. Give me the jelly. Cystogastrostomy can be done in supine position as well as in the lateral position, in whatever way you comfortable. We are trying to introduce a scope in the supine position. If we are not able to introduce it, we have to make it lateral. Another case, ત્યાં line up થયેલો. ના આવે. There is a spyglass, na? There is spyglass biopsy and fully covered metal stent deployment in OT1. Kiran Parihar, patient name. OT1. You have to make it lateral. Make it lateral. Make it lateral. Okay, good enough. So we are now inside. Can we see the ultrasound image large? Okay. Now many people are doing this where the marker is coming from the left. And now this is the cyst. You can see the turbid fluid, but this is not a necrosis. It is a more a turbid fluid, and it gives us some amount of compression. So a little bit difficulty in the negotiation of the scope. Okay, give me the needle.
Sir, before you puncture, sir, which site you prefer for puncturing the needle?
I personally feel it should be below GE junction. Okay. And site in stomach or site in cyst?
Sir, which site is better? EUS guided below G junction, at what site you prefer? Whether vascularity wise you check wall of
Yeah, it
thickness.
is very simple. It's a real-time image. You just put a Doppler. Okay. Now there is some amount of vessel, you slightly change your position. Okay. Now this is okay. There is no real-time flow.
Yes,
You
sir.
can use this side. So that is the advantage of the Doppler. You are not going blind. Okay.
And the thickness of the wall, sir?
At least 10 millimeter.
Okay.
Oh, sorry. Distance should be less than 10 millimeter. Distance from the EUS probe to the cyst wall should be less than 10 millimeter. Otherwise, it is a relative contraindication to do cyst. So we just apply Doppler. This is a needle.
Sir, which needle? How much gauze you are using, sir?
I am using a Olympus Easy Shot 19 gauge needle. Okay, you can zoom it so you can see there is a white, too thin white line. Okay.
Yes.
I need somebody to hold this scope. Head and side. We have punctured. Remove this by remove this. Where is Hardik?
Sir.
So you see this needle is a beautiful ecogenicity. Compare to the other needles, the ecogenicity is very good in the Olympus Easy Shot.
Yes, sir.
Okay, so you see the thin pus-like material.
Yes,
Can you
sir.
focus camera here on this syringe? Okay, so there is a thin turbid pus-like material is coming, and that's why it looks like a necrosis. Remove it. Now, once you remove that, you have to flush with the water.
Why we are using water to flush needle, sir?
Otherwise, your wire gets sticky.
Okay.
Okay, because there is a debris material inside the
Needle.
So if you go for 2 to 3 exchange, if you go for exchange, then exchange will be difficult. Slightly zoom out. Okay.
Sir, during cystogastrostomy, as per your past experience, whether you have seen any time bleeding or any vessel that caused?
Yes, yes, I have seen. It depends. Even particularly it happens in EUS, not after puncture. It usually happens once you go for dilatation. Okay. So what happens if something is running inside the wall? It is not in your puncture window, but when you dilate, okay, it may be possible that force may lead to tear of that vessel, and that lead to the bleeding. Now, depending upon the size of the vessel, it may be a torrential bleed, or it may be a simple bleed, which may be automatically subside. But I must say, because I have 1 or 2 experience of the torrential bleed when I was studied, so ideally you should have your surgeon colleague with you, or you should perform this in an institute where interventional radiologist or surgeon should be available. So if any complication, because this bleed is massive bleed, it doesn't give you a chance. Okay.
Yes.
Now you see the wire. It is. Okay. Go. Okay. Now we are exchanging. It's a 22 centimeter cyst. Okay, so you can't expect that the wire will take 2 or 3 curve inside the cyst. Otherwise, your wire will be short.
Yes, sir. Sir, when cyst size is large, so to decide for stand, when patient is affordable for plastic and metal stand both, then when the cyst size is large and liquid content, then how we can analyze the necrotic material?
You see, basically analyze the necrotic material. Okay, the best is MRI.
Yes.
If you are not able to assess the each and every aspect of the cyst in EUS and cyst is too large, I think MRI is the best tool to assess the any necrosis.
Which cyst, sir, you directly send for surgery?
That which is not amenable. And septated cyst, particularly if there are multiple septa inside which is not communicating, loculating cyst but not communicating with each other. At that time you may drain one of the pocket, but you can't drain the entire cyst. At that time surgery is preferable. You see there is a debris.
Yes, sir.
Debris is there.
Yes,
In
sir.
ultrasound image in the dependent position of the cyst.
Yes, sir.
OT1 માં ચાલુ થયું પૂરું.
Yes, sir.
So now we are using a cystotome. Can give exhaust also, no issue. Whatever it is or whatever available. Any exhaust as a cystotome. Exhaust catheter as a cystotome if you want to give. Or cystotome is if give me cystotome. Give me cystotome, whatever in your hand here.
If we put, sir, metallic stent, then when you will decide to do necrosectomy, or any cases while doing necrosectomy you find bleed,
You see,
and when to
basically-
decide when you will put a nasocystic drainage tube.
Okay. So first of all, imaging is very, very important before deciding regarding the endoscopic necrosectomy. Because if you are dealing with the infected necrosis, okay, and there are few areas of the collection which is not communicating, and you drain particularly one part of collection, though it is a large and small pocket is remain untouched, and you go for necrosectomy for that large part, laser may be suboptimal. What happened? Okay, the result may be suboptimal. So if there are multiple areas, I usually don't prefer endoscopic necrosectomy. But suppose this is such a case, and second is one is a very sick patient, infected necrosis, very sick. All the areas in imaging you can think you can approach after putting a metal stent or nasocystic drain. Then I used to go for endoscopic necrosectomy. And if it is an infected necrosis or it is you are planning for a necrosectomy, I usually prefer to put a nasocystic drain in each and every patient because it is a harmless and you can frequently wash the necrosome. Okay, so if you do it daily basis, so maybe there is a chances that the session, ERCP session or necrosectomy session will be less. Okay, correct. So you can shift to the OT1 when other case is ready. Till the time we are puncturing it.
Dr. Yogesh.
Or US FNA is not helpful. So this is a lady, young lady with a indeterminate biliary stricture, multiple times brush cytology taken, but inconclusive. And she is presenting again and again with strictures and cholangitis. So one indication of spioscopy is large CBD stone. Other indication is CBD or CHD strictures. So in case of biliary strictures, when your brush cytology is inconclusive, brush cytology only has 50% sensitivity and specificity to diagnose the biliary stricture. In such cases, you get two options. Either you can do an EUS FNAB from the stricture, or you may do an spioscopy and spy biopsy. So those patients who have hilar strictures, in them preference is spioscopy, because multiple studies say that EUS is not a good modality for hilar strictures, while those strictures which are in the distal CBD, in them you can use EUS-FNA. For distal biliary strictures, spioscopy is not a good modality, but for mid and proximal CBD or CHD hilar strictures, spioscopy is a better modality. So I won't be discussing much on spioscope, already discussed today morning. We have to do a biliary sphincterotomy prior to introduction of the spioscope. Biliary sphincterotomy has already been done earlier in this patient. There are two ways of cannulating the bile duct for the spioscope. One is by placing a guide wire as in traditional ERCP, and then, wait, I will tell you. And then passing a spioscope above it. Other method is direct cannulation by the spioscope, especially if the papilla is wide open. So here you can see the channel PIP image. Now we are in the bile duct, or we are in the duodenum. Important is to preserve this blue, sky blue part of the spioscope. We are in. Now you can on the light, spioscope light, and you can change. You can do yes. Irrigation, please. CO2 irrigation is important. In spioscope, irrigation is important. And always use CO2. Here you can see there is also some part of residual stent inside, which needs to be removed before we place a metal stent. You can see the part of his stent. Some stent has been left inside. First we take a biopsy and then we'll remove the stent. So this is also one of the indication of spioscope. Internally migrated stents you can remove. You can see here an irregular mucosa, suspicious mass lesion. Please give me a spy bite biopsy. We will take a biopsy from this area. So this is a spy bite. Please focus here. Excuse me, cameraman, please focus here. This is a spy bite, and it is designed in such a way that it can pass through the 1 mm channel of the spioscope. Open. You can see the spy bite here, designed in such a way that it can pass through the 1 mm channel of the spioscope. So Bhavesh will be helping me today. अंदर भी है स्टेंट काढ़ो लो पहला ना ले लो बाहर से ले लो. So you can see a stent which is in proximal CBD also. Some part of the stent is there, and we will take biopsy first and then remove it. Are you back? Okay, okay. So there is some technical glitch. The biopsy forceps is not coming out of the spioscope channel. In this case, there is nothing to panic. You just need to take the scope in the channel and then pass the biopsy forceps. Yes, now you can see it has already come through the channel. We can reposition it within the scope and then go. Can you increase the endoscopy image, please? Endoscopy image. And पकड़े रखो. Yes, we are in. But I don't. Okay. You can see such challenges always will occur when you are doing any advanced procedure. So here problem was that the biopsy forceps was not coming out. So what we did is we made the scope straight by pulling back into the duodenum. Now we are back into the CBD. How can we? So this is the area of stricture. Bhavesh, come out with the biopsy. Wait. No, stone away. And turn cut. Right, left cut. Clutch, stone nothing. Take biopsy forceps inside. Take inside. अंदर ले ले. पाओ नहीं तोड़ो कर. तू ले ले ना. तू ले ले. Just endoscopy ની જેમ right left touch કરવાનો છે બીજું કોઈ નથી. જેમ endoscope હોય છે ને એવી રીતે. Bring it in the center. What's your good name? So Praful, Dr. Praful is here with me. He will help me to locate the scope, spioscope in the center. You have to maneuver it just as you do for any upper GI procedure. बदली ना तो पकड़ी रखो तुम कहीं ना बस. पकड़ो, करो, चेंज कर दो, चेंज कर दो. Okay. So you can see here the irregular mucosa, inflamed mucosa. I will ask Praful to take out the biopsy forceps. Is it coming out? Do it very gently. Do it very gently. Is it coming out? Pull the Kamala. Okay, it is there. Just try to remove it. Try to bring it out. No? Yes, it is there. Just try to bring it out. Yes, you are there. Try to bring it out more. More, some more. Yes, open. Okay. You can maneuver from here. Okay. Just as you do for your upper GI scope. And then you can ask Kamal to close it. Okay. Bring it in the center. Bring it in the center. Yes. Bring it in the center, center, center. Okay. Okay. Take a bite. Kamal, जब बोलूं तब बंद कर दो, हाँ? You keep it in the center. There is nothing big deal. Just think that you are in the fundus, okay? And try to locate the fundus. Try to locate the body part. That's it. Nothing big thing in this. Don't think that you are doing a colonoscopy. Okay? Keep it in the center. कमल अभी बंद कर दो ना जब यूज नहीं हो रहा तो. बंद. खोला. Open. Take a bite. Here. Open. Take a bite. निकालो. Keep it in the center. Center. Just think you are doing endoscopy and this is a this is body of stomach. Okay, don't think that you are doing colonoscopy, cholangioscopy. जाए. ऊपर सौमिन ने बोला है कि परफॉर्म करे थे बीजे. बोल जो आवतो है तो बोला है. अंदर लो. सेंटर. हाँ. एक मिनट यार काढू बस. Hello, Saumin.
Okay, it is बहुत simple that. તો વિચાર is ની કોલેન્જોસ્કોપી નો ફક્ત વિચાર કે તું બોડી ઓફ સ્ટમક જોઈ રહ્યો છે બરાબર જો રાખ સેન્ટરમાં રાખ का बायोप्सी फोर्स से रिपोजिशन कर लिया बायोप्सी फोर्स से रिपोजिशन कर दिया बाहर आ गया है ना ऑन करो बेन બેન તમે જો ને આને પકડો એ જવા દો એની કોઈ જરૂર નથી એવી રીતે પકડો હા ચલો બેન પકડો હવે વ્યવસ્થિત આને ટાઈટ પકડો હા ચલો પેલું ચેન્જ કરો ત્યાંથી ચલો કાઢો સેન્ટરમાં રાખો બેટા તું સેન્ટરમાં નથી રાખતો राख हाँ बस चलो निकालो बायोप्सी फोर्सेप निकालो कमल बस कमल बायोप्सी फोर्सेप निकालो आ गया ना ओपन ओपन करो करो ओपन किया पीछे लो आगे जाओ पीछे लो आगे जाओ और बाइट लो लिया लिया चलो लो बाहर नहीं आया ले लो खींच लो निकालो निकालो आ गया चलो देखो आया नहीं आया आया ओपन क्लोज sometimes you may not get a good chunk if the biopsy forceps is very small caliber. करो करो ट्राई करो आ रहा है नहीं करो आ गया ले लो sometimes it may be more cumbersome to come again and go again but you have to do it so again you are in try to focus in the center
Yes, yes, yes. Liquid diet.
Center.
Because cyst is a high pressure zone. So always
Hmm.
fluid is coming from cyst to the stomach.
Wonderful.
It will not grow from stomach to the cyst in the initial time.
कमल निकालो.
Yeah, yeah. It is just like cysto.
निकला?
It is a
Open.
cystogastrectomy, but
ऊपर
route
से
is
ले लो
different.
चलो. Open.
And diameter is different.
थोड़ा
You can
shake
do
करो.
around 4 centimeter also, depending upon the cyst wall. We can maximally do 20 millimeter. But इनके केस में क्या नेक्रोजोम इतना नहीं है, टर्बिड फ्लूइड है. सिटी जो आपने करवाया ना उसमें, तो इसमें 20 मिलीमीटर की जरूरत नहीं है. Even in this stand, suppose if you want to do a necrosectomy, you just do CRE, small CRE, and you can go with upper GI scope and do necrosectomy. Okay, sorry. Yogesh, are you able to hear me?
We are taking a biopsy first.
But I don't think, Yogesh, are you able to hear me?
Yeah, I can hear you.
Okay. So there is always some unpredictability. You can see the fragmented stand of previous procedure. Okay, that has done, I think, before 2 years is still there. Okay, and that is the advantage of the spy scope.
No, first you give me this. Just check.
So this is another good demonstration. Any migrated foreign body or any migrated stand inside the CBD or sometimes in the PD can be removed with the spy scope. And there are two devices, spy snare as well as the spy basket. But spy snare and is better, or a spy biopsy forceps is better to catch a stand and to remove it. So that is the beauty of the spy scope.
Picture में नहीं आ रही है. Picture नहीं आ रही. So we are first removing the stent, residual part of the stent. ठीक है.
I think, ma'am, this procedure is going to be a lengthy little bit, spyglass one. So you can take another patient here only. Less to ERCP, we will do it here only.
काढा वाडा काढ्यात नाही ग. ना एग्रीड पण आ रही गो लागत ना. चलो. कर आई जस्ट. Not I will. आवाज resistance.
You can temporary. I can switch off from here. So give it in my hand.
काढ हवे का. अच्छा. આ શું છે? સ્નેર છે ને? Okay. Keep in center. Keep in center. You can do upward movement also. No. Wait. Wait. Okay. Take out this net. ઘણું બધું છે યાર અંદર. કેવી છે? કાઢો. आया बाहर आया. हमने पोजीशन किया था ना वहां पे, तो फिर क्यों नहीं आ रहा? नहीं आ रहा? So, as there is some technical difficulty in removing the basket, what we'll do is we will do a traditional ERCP first, pass the wire, and with help of the balloon, we'll remove the residual stent first. Change to the endoscopic image, madam. लो. नहीं कोई बात नहीं, आप मुझे वायर दो और बलून दो. चलो चेंज करो बहन. सो दो. हाँ 5 एज बहन. हाँ करो. चलो ये बंद कर दो 2 मिनट के लिए. Can anyone show me fluoro, please? Fluoro. गयो वायर. फ्लोरो. अरे फ्लोरो दिखा देना. To rotate. To rotate. चल वायर ना को ऊपर. 5 वायर. ओके ओके ओके. और पीछे करो, वापस करो थोड़ा. नहीं नहीं स्पाइन सीधी करो. If you can, if anyone can show the fluoroscopy image, just show the fluoroscopy image. Cameraman, please. Show the, please pay attention. Huh? You show the fluoroscopy image. Go wire ऊपर का. So you can see here that there is a long part of residual stent. This is an earlier stent which has not been probably removed, or it has not been recognized earlier probably. Okay. Exchange. Wire क्या है? ऊपर गयो. गयो ऊपर. बलून दो. करो एक्सचेंज करो. We are trying to remove this by the balloon. As the stent is probably impacted inside and it is not coming out, it is not being held by the basket. We are using the traditional method. बताओ. फ्लोरो. ऊपर करो. इन्फ्लेट. इन्फ्लेट. डिफ्लेट. फ्लोरो. गयो ऊपर गयो. फ्लेट. बताओ. आयो नीचे. रेड टूथ लो थोड़ा छोटा वाला, बताओ, बुलाओ, बुलाओ, बताओ, बुलाओ। फ्लोरो थोड़ा नीचे करो, रेड टूथ दो। We are using all accessories whatever we have with us. We failed with balloons, so we'll try by a red tooth forceps. Fluoro. Open, don't open. Open with fluoro. Fluoro. ओपन, कहाँ जा रहा है यार ये? ओपन किया, पकड़ो मैं। नो, पकड़ो, पकड़ा, लग रहा है? पकड़ी रख जाओ मैं। फ्लोरो, ओपन, वाला दिखा दो ना, वहां दिखा दो। चलो, ITV में चलो, ओपन, पकड़ा, पकड़ा है कि छटक गया? नहीं, आ गया, आ गया, छटक गया। इम्पैक्ट થઈ ગયો છે ઉપરનો જે છે ને, હા कौन से अपने बनाया हुआ ले, हाँ चलो, बताओ, खोल, खोलो, पकड़, पकड़े, लो सीआरई दो। नहीं नहीं, सीआरई दो ना, स्पिंटोटॉमी तो किया हुआ है ऑलरेडी। पहन लो, छोड़ दो, वहां पहन लो पहले। बाणी 15 ही दे दो. तो कोलेंजर दिन था को मतलब ऐसे तो चला बाहर. चल चलो फिर बाहर. पकड़ो फ्लोरो प्लीज. गया बाहर ऊपर से. कहाँ गया? नहीं जा रहा. बताओ. स्टिक डक में जा रहा है. Okay. दो तीन है. दो तीन है अंदर. चलो. CRE balloon.
Yogesh, am I audible? Yogesh? Yogesh?
Yes, Saumin.
Am I audible?
Yes, yes, you are audible. Actually, the stent is impacted inside,
Okay.
and it is not. It is a long part of stent which is impacted.
Okay.
And I personally feel there are two previous stents which are one is loose and other is impacted. So we are not able to remove by any SPY accessory. We are right now dilating by CRE, making the sphincterotomy wide open more, and then we'll do a balloon extraction.
Okay. But it is not holding in the spy bite or something?
No.
Snare?
We are trying by traditional method.
Okay.
And then once we are able to remove the stent, we will take a spy bite.
So meanwhile, you can switch towards the OT3. So here is the case of 60-year-old male presented with the obstructive jaundice before 3 months, and it was cholangitis. Endoscopy revealed periampullary growth. ERCP stenting done, biopsy taken, biopsy turned out to be a malignant. And now our plan is to remove the plastic stent and deploy a metal stent.
कितने किया 15 किया.
So now we are in. This is ampulla. Fluoro, there is the stand. Fluoro.
हो गया.
I think it is.
बलून रेडी है ना, तेरा वाला है ना. चलो डिफेक्ट. बाहर रखना. देखा अलग अलग है, ये ब्लू कलर का है, वो ग्रीन कलर का है. दो है अंदर.
Embedded inside.
मेटल रखना है, लेकिन मेटल तो तब रखेंगे ना जब सब निकलेगा उसके बाद. चल डन.
Long loop is.
वही वाला दे देना, तेरा वाला था ना, वो दे दे.
नहीं, but looks like loop is outside. But we are not able to see the
देखिए थोड़ा.
stand. Fluoro.
जमानो बाकी है आएगा इसमें, नहीं जाएगा.
think it developed gastric outlet obstruction also. Give me the JF scope.
करो ओपन.
JF 100.
पकड़. ठीक है.
Where is stand? Fluoro.
बताओ. चलो अब स्पाई डाल दो इसके ऊपर. क्या करेंगे बोलो. निकल. हाँ मारेंगे. निकल. अरे वो स्टैंड दो, बता देते ना. So Saumin, can you shift for 2 minutes to OT1?
Shift it to OT1.
Yeah.
Mane cannula.
So am I visible now? So am I visible? Okay. So this is a stent which was impacted inside and we could remove it. The entire stent was impacted inside. So sometimes SPY accessories may not be that useful in case of, whole stent or impacted stents. So you may switch over to traditional method. So now we'll introduce the SPY scope, take SPY biopsies, and then place a metal stent. I think Saumin, you can switch over to your OT.
Yeah. Fluoro?
सुने मैंने है ना पूरा अंदर
Fluoro?
ओके नहीं पहले तुम सीधा ये डालो पाए दो पाए स्कोप दे दो
तो बाहर है, कहीं दिख नहीं रहा।
फ्लोरो प्लीज fully covered 6 centimeters.
હા આપણે જ કરી છે. It is embedded in the tumor stand.
यहाँ पे हो ना तब बायोप्सी फोर्सेप डाल ही दो
But where is stand?
स्पाइस को हाँ दो ना पहले दो बात
Make it prone. Patient prone करो.
क्या है वो बायोप्सी
Maybe
फोर्सेप
may get some position to see.
क्या वो पहले जो यूज कर रहे थे वो
Semi prone.
वही
खाली हाथ पहली बाजू ले वो तो ले लो कि नहीं ऊपर वांधा है जोवा दो चलो फ्लूरो. Let me reduce the scope.
चल वो दबाओ पेन पे बटन दबाओ पेन
फ्लूरो
लो इधर रुक जाओ क्या है प्रफुल क्या है प्रफुल आ गए बताए सेंटर बताए
तो राउंड रखो
सेंटर बताए रुक 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 जल्दबाजी मत करो इरिगेशन एंटर सेंटर सेंटर ओके हाँ स्ट्रक्चर जो करो ना तो ले लो वायर ले लो 5 बाइट आप
I think this is હા ને બાજુમાં જરા કમસ્ત દેખાય છે પણ એ નથી લાગતો મને પાણી મારો. We will try for 5 more minutes, otherwise we will take this case tomorrow with proper time.
वायर है अंदर वायर निकाल दिया ना मैं अरे करो भैया ठीक है
नहीं यार तो તમે જો ને અંદર પાછળ તો નોર્મલ નીચે તો નોર્મલ મ્યુકસ આવી જાય છે ને નાઉ
ના
વેરી સ્ટેન્ડ
ઇડિયોટિક સોપ આમાંથી નહીં આવે ને ચેન્જ હા ચલો ઠીક છે ઠીક
તમે
છે
અપર જે
સેન્ટર
નેક્સ્ટ વાળા બોલે ईआरसीपी
ओके
ના 5 મિનિટમાં
ओपन
નહીં થાય ટર્મિનેટ કરશો
थोड़ा बाहर निकालो बाहर
हाँ?
निकालो थोड़ा ओपन
अब
ओपन नहीं है थोड़ा बायोप्सी पर से बाहर निकालो हाँ
वी आर लाइव और
ऊपर अप कर
OT1 is live
क्लोज
we are live or OT1 is live
अप करो यार
okay
अप
okay
कर दो
but your camera is I think okay
अप क्लोज यस टेक सेंटर करो आए सेंटर करो नहीं नो छोटी तुम्हारे यहाँ भी होता होगा ना ऐसा प्रॉब्लम आता होगा ना ऐसा तुम्हारे यहाँ भी हाँ ले लेना इसमें क्या पूछने की क्या बात है नहीं वो हाँ ले चल करने दे चल सांप को करने दे ओके ओपन क्या ओपन पर नहीं है सेंटर करो यार सेंटर करो सेंटर नहीं हो रहा दे दो उसको दो ऐसे नहीं हो रहा ओपन करो पुश पुश हाँ क्लोज आया कुछ चलो अब ये सामने दिख रहा है यहाँ से ले लो पटक रहे नहीं आया मत करो कुछ मत करो चलो निकालो बस पीछे लो ऊपर अभी मत करो बायोप्सी फिर से बंद लो मैं बोलूँ उसके बाद ही निकालना छोटा परफोरेशन है ऐसा लग रहा है पकड़ो रुक जा चलो आउट ओपन वो ओपन पुश करो रुको लो ले लो जो एंटर करो प्रफुल ले ले तू ले ले उसको दे दो यार सांप को दे दो तुम आया है कुछ कौन एक बार और कर लो चलो। ठीक है, एक और ले लो चलो। CO2 है ना? एक एंटीबायोटिक આપી દો. Zostem 3 grams. હા, થોડુંક છે ને ત્યાં લાગે છે તો મેટ્રો બી આપી દો. आया कुछ? ओके, ठीक है। चलो सेंटर सेंटर हाँ रुको रुको अंदर ही लो अंदर ही लो बताओ फ्लोरो नहीं दिस इज नॉट राइट आप ये अंदर लो आप सिर्फ सब अंदर लो आउट ओपन ओपन एक मिनट बोले उसके बाद करनी सेंटर लो पानी खत्म हो गया शायद बंद कर दो बायोप्सी फोर्स हाँ कितने 4 तो आ गए ना 4 आ गए ना ठीक है चलो निकालो डाल दो वायर डाल दो इसके तो चले સિસ્ટિક ડક લાગે છે હોઈ શકે સિસ્ટિક ડક ફ્લોરો ગુડ ચલો હા હા એ તો વાંધો નહીં આપણે કોઈ બી चेंज कर दो चेंज हाँ खोल दो they can shift to OT1 is OT1
You are already live, sir.
okay
Yogesh, you are
so
live.
we have taken biopsies 5 by please show the yeah. So cameraman can focus here we have taken 4 bites hopefully the issue will be solved now can you see the 4 bites
Yes, we can see.
And now we are placing the metal stent, the final step. So in a young lady, this could be anything. It could be IgG4 associated stricture. If this patient has an history of cholecystectomy, is there any cholecystectomy in the past?
No, but they have done cholecystectomy because I think
So it could be an ischemic stricture also, or it could be IgG4 disease also. We are placing a fully covered metal stent, and we will remove this after 3 months. The fully covered 6 centimeter stent by Mitra.
अच्छा आपको वहाँ डाल दिया क्या फुल्ली कवर्ड ऊपर डाल रहे हैं क्या आप
आ गया ना फ्लोरो इमेज प्लीज आ गया ना खोल खोल आ गया ना यार आ गया यार खोलो चलो खोलो So endoscopic image, please. No, don't do anything. So deployed this metal stent and you can see the clear flow of bile from it. Hopefully this patient stricture will benefit from this metal stent.
excellent demonstration
Thank you.
Resham.
Thank you,
and
sir.
excellent persistence because migrated or impacted stent was not reported so I think it's a excellent demonstration
बस अभी
you switch towards OT2 OT3 sorry this is the last or second last case okay so here is a case of chronic pancreatitis with benign biliary stricture CA99 is normal CT scan suggestive of benign stricture he also has a history of PD stenting plan to convert a plastic stent into the fully covered metal stent. Give me a jelly. So as we discussed previously, fully covered metal stent has an excellent result in the benign stricture, and we should use it more judiciously. Most of the people think about the cost when we start with the fully covered metal stent. But if you see the cumulative cost of multiple ERCP with Costa Magna technique and for benign biliary stricture or a single shot with fully covered metal stent, I think it scores over comfortability of patient as well as what you call the affordability or final cost effectiveness will be more. So here we can see we have placed first here we going to remove the pancreatic stent. Then give me a cannulation. We will. One. Bite. Open. I think there is some edema of D1D2 junction. कौन सा भैया? दादानु करता करता ये स्टैंड वालों नीचे बोले वो આપણે pus is coming out. Open. Okay. Bite. Open. આપણું સ્કોપ છે બહુ હાર્ડ છે લાખો નહીં ઓપન રાઈટ ફોટો ઓકે નહીં આ તો main required if we may fail to cannulate. Open cannula, sphinctodome, whatever it is. Even D2 edema છે અને લો બાર બ્રો do cholangio first. Now you have some direction, go there. Yeah, good, good. Now you are coming back. Continue to inject contrast, continue. Hey, we want to see the one. Long segment stricture is there, but however, we require to do biopsy post-stenting. Okay, so there is a stricture which is extending up to the mid CBD. Extend. Give me fully covered stent. It's a 6 centimeter. I hope it is adequate. So this stent is from, this is a bonus stent. Okay, this is a fully covered stent and the length is around 6 centimeter. Usually we preferred a 6 centimeter and the guiding wire is 035. Okay, total delivery length is 204 centimeter and delivery device is 8 French and diameter is 10 millimeter. So this is from the Make in India campaign. So they are giving this free of cost for the Indian patient. So radiological marker is there. Fluoro image, fluoro. If you see there is a, if you see my finger, fluoro. There are two markers. Okay, one is from there and second is here. Okay, that is radiological marker. And here is the endoscopic marker. This portion. This orange portion. Okay. This, you just focus on my finger. Yeah. Now you visible. Okay, this is endoscopic marker. You will better visualize when we are doing a deployment. Okay, in endoscopic view, you can better visualize. Okay, flush it. No. Now you can see, if you see the endoscopic picture, you can see this yellow thing. So this is your endoscopic marker. Deploy. Thigh, deploy. Now tell me like that. Now deploy. So you see, you can see the movement, sliding movement. Deploy. The principle is your endoscopic marker should be in your vision. Now this is deployed. So very smooth deployment. Nothing to worry. Fluoro. But the stricture length is little bit suspicious because it is up to a mid CBD. So possibility of malignancy is there. But we have taken breast cytology, which is negative. CA99 is negative. CT is negative. So let's see how it responds, and we are going to do imaging after 1 month again. Next, esophageal. So now stricture of CBD, particularly in such a case, it is very difficult to identify is it benign or malignant. Okay, so when it is you are suspicious of malignancy, and the plan is to remove if the imaging changes are there, to remove this plastic stent fully covered. You can easily remove it and try to do a spyglass after certain stricture dilatation from lower end. So spyglass can be easily inserted and we can see the pathology. Now disadvantage of this is it induces the fibrosis. So sometimes biopsy may turn out to be a negative even with the spyglass. So we will this will be our the last case will be the corrosive stricture. If there is a short segment stricture, we put a esophageal stent, and if there is a long segment, we avoid it. Okay, and corrosive stricture short segment is relatively unusual, and but patient every time improved after dilatation, and the patient wants to assess herself from for plastic fully covered esophageal stent placement. So they are just transferring the patient. Just update regarding the patient, we have to cancel one spiral enteroscopy due to hemodynamic instability and multiple VPC. Otherwise, all the cases we have done right now is stable at now. And we are planning to take a evening round around 8 p.m. and probably we are going to discharge at least all patient apart from endoscopic sleeve gastroplasty and the spiral enteroscopy, because it was little bit lengthy procedure, as well as spyglass, the last spyglass that was impacted stone, because that was a relatively lengthy. Otherwise, I think we are able to discharge all the patient by 8 p.m. tonight. Regarding the corrosive stricture, the few things they try to avoid the endoscopy in 3 weeks to 3 days to 3 weeks. And during the first 3 days, only if necessary, go for endoscopy. And you have to apply the jargon classification for that. That what is the class of injury and should we directly go for the FJ feeding or not. Second, regarding the benign esophageal stricture, fully covered this ACMS is works wonder, particularly after the post radiation stricture when histology is negative for the recurrence. So we are planning to do this last case. We have to reassess this case. If the short stricture is the short segment, then we are going to deploy the stent, and if it is a long segment, I think it is better to remain under the dilatation protocol, and we will explain the patient to go for the self dilatation. Another thing about this case is she does not require a frequent dilatation. Okay, sometimes once in a 3 month or once in a 6 month. So her stricture is responding. So that is the another reason I want to place, if possible, a fully covered esophageal stent that her stricture may resolve completely after the placement of this stent. The few this stent can be kept inside for 1 year, up to 1 year, but usually I will remove after 5 to 6 months. Okay, and chances of migration is high, but chances of the migration is a good thing. If your stent migrate after 1 month, it indicates your stricture has been resolved. Okay, so or second possibility, that if stricture is not tight enough, then migration may occurs below the stricture. Okay, so that's why we select case judiciously, and particularly you have to wait to place a stent. At least I personally feel 6 months. Up to 6 months you can't place a stent or do dilatation, because fibrosis and inflammatory process is going on. So sometimes it depends upon the tightness of the stricture. If it is too tight, I am not going to deploy a clip. But yes, if it is minimally tight, we can deploy a clip. How it is not a very popular modality, to put a fully covered esophageal stent in corrosive stricture. But I feel if it is short segment, long duration stricture, more than 1 year, and patient require a frequent dilatation, you should give a trial of it, because there is no harm. Okay. What happens sometimes that there may be a mucosal embedding a stent embedded in the mucosa, and subsequent removal may be difficult. But that happens when you placed it early, during the first 6 months of the corrosive ingestion. After 6 to 8 months, when you see the rest of the mucosa is okay, no inflammation, then you can put a routine stent. For this patient, I don't recommend surgery, because she requires once in a 4 month or 6 month dilatation. And if it is a relatively short segment stricture, self dilatation is good enough. But if there is a complex anatomy, and if we have to dilate it frequently, then you're from Zena, na? Please. So these are the people who supported greatly. This is from the Zena laser. Okay. And the stone we have brought with the laser, this supported by Zena, and they have do it free of cost, and it is an excellent modality. Okay. And these people is from Medora. Okay, they have provided a stent to the patient, pseudocyst stent, as well as the biliary stents, covered as well as uncovered. Okay, and everybody knows Dr. Yogesh Sarwani, my dear friend. Okay, and this is the last case. So everybody is so happy. And now we are going to add, particularly AV guy. They are waiting that when this is going to happen, when this is going to end. So probably we are not going to deploy a stent in this case, but let's see the anatomy once, and then we will decide. Yeah. Yeah. Where is Bhavesh? So we just measure the cricopharynx. It is at a 15 centimeter. Why there is no inflammation? Start endocarbon here. So there is some amount of fibrosis, slight tightening at 26 centimeter. Then again, inflamed mucosa. Now this is tight. This is tight, but this is up to 32 centimeter. Now give me a pediatric scope first. Okay. So we are not going to dilate right now, because we want that stent to stay. Okay, so we see with the pediatric scope, and if it is a short segment stricture, we can deploy esophageal stent. But if it is a long segment stricture, we are not going to deploy a stent, because up to 32 centimeter there is no significant resistance to the adult scope. Let's see it with the pediatrics. So we are now at 32 centimeter. You see, mild injury with the scope may also lead to the bleed. So this is 36, 35. Beyond that is normal, but only issue is G junction is at 36. So we have hardly 1 centimeter margin. Is and abnormal mucosa is from 30, 24. So 24 to 34 is abnormal mucosa, and at 32 we get some resistance. So I personally feel we should not deploy. What do you think? It is a long segment stricture, so we are not going to deploy the stent. But I will go ask a patient to go for self dilatation if she can do under observation for initially 2-3 days, because history of her corrosive ingestion is long, so we are not going to deploy esophageal stent in her. So these are where is Bhavesh? Okay. This is our technician Yagnesh and Madam. This is one Bhavesh is missing, and another is please come. Please come, everybody. Praful. It's okay. So this is Dr. Rajesh, the one-man army. Oh, so this is Dr. Praful. Praful is here. Okay. Right now I'm feeling a little bit dizzy. Praful is here. He is one of our team members. Smith, please come. Smith is a very good endoscopist and my colleague, and he helped me since morning. And here is Dr. Rajesh. Okay. All the management work will be done by Dr. Rajesh. He is one-man army and meant to go. Dr. Isha. So she is our master anesthetist as well as endoscopist, I can say, because she can do all type of the procedure. And here is Amit. So all the hospital work is done by Amit. So I am thankful to all the team members. Okay, without them, we are not able to complete this workshop. So we have almost completed 22 cases from 9 to 5 with 3 OT with 1 marathon spiral enteroscopy and marathon spyglass. So thank you once again from Gujarat Gastro Hospital. Sorry, अरे आमा लागेल उतर टूटी जશે.